Check. 1, 2, 3. Check. Check. Testing. Check. Check. 1, 2, 3, 4, 5. Check. Check. Testing. 1, 2, 3, 4, 5.
This one belonged to you, to
Me?
CITRIS.
Okay.
So I don't know, should I get back to you or you want me to
Yeah, I
hold on
can
to
take
it?
care of it.
Okay.
Yeah. Do they need any more power supplies for? I mean, power strips.
Are there any in here?
Well, I don't have that many. I may be able to unplug my computer and things like that.
Oh dear.
Gather a few.
Well,
Yesterday they had plenty here.
well, I think they decided that they needed over in.
shouldn't do that. Damage your microphone. So they can hear you.
Test, test. Okay, that works.
Yeah. So I leave this here if they can wear it. That would be nice.
And how do we
Just clip it on.
and
Within
lock
this
here?
distance.
Is
It is
this
on.
switch to turn on?
That's the mute. This is the off and on button.
This is me. So switch just to the left to there. So we're webcasting using microphones.
Right. So what do people who ask questions need to use what? This pickup microphones, yeah. Okay, terrific. Let's get started. First of all, welcome on behalf of 3 organizations that are sponsoring the workshop, and they are the School of Public Health and the Dean, Steve Shortell, who's here, Cal Rio, and the Executive Director, Laurie Hack, who's here, and myself. And I run an institute, which I'm going to plug a little bit, called CITRIS. I'll just tell you a little bit about CITRIS. And before I do that, I just wanted to say CITRIS is sort of a 4-campus operation with Santa Cruz, Merced, and Davis. A number of our colleagues at those campuses requested that we webcast the proceedings. And so I just wanted to let you folks know that there are actually microphones hanging from the ceilings, and they're picking up everything that you might say. No, just kidding. It's not. But anyhow, if you ask questions, they'll pick up your questions for the webcast and so on and so forth. Okay, I'll just tell you, and then I'll let our co-organizer say a little bit. Let me just tell you a little bit about what CITRIS is. So CITRIS, Center for Information Technology Research in the Interest of Society. It is, it was set up by Governor Davis, then Governor Gray Davis, in combination with 4 other universities, to actually play the role of what has now become, a phrase that is bandied about more generally, public-private partnerships. We are supposed to be the arm of the university that works on trying to make sure that things that are done in the University of California certainly goes out into the real world. And at the time that these things were put together, there was a bio-institute, that's UCSF, Santa Cruz, and Berkeley, that's QB3. Cal IT2, which is joint between San Diego and Irvine, and the CNSI, which is the Nanoscience Institute, which is UCLA and Santa Barbara. At that time, there was a sense bioinfo, nanofusion, that's sort of the big technologies. But we thought it was more important to not focus as much on the enabling technologies, because sort of glamour technologies come and go. Needs of people are on the other hand, and needs of society are on the other hand constant. And so we called our institute the Institute for Information Technology Research in the Interest of Society. And just to give you I'll just tell you a little bit about this. I think that technology is just marching along. The structure of today's event, by the way, is really to mirror what we think is really important in these events when we think about societal scale problems. We really want to start in the very first session by the needs from the practitioner community, then move on to social considerations, legal considerations, and then move on finally to what technologies are useful. So it's not a question of here are some wonderful technologies, let's throw them over the wall and hope that something wonderful comes out of them. So all our focus really is to think about societal needs. And in the interest of time, I won't read through all my view graphs. And by the way, all the talks will be repositoried and posted on the website. Also, the whole event, of course, because it's a telecast, is also repository, so you can hear people in slow motion or perhaps speed it up at twice the speed, etc. So here are some of the things that we think people care about, are putting technology into our infrastructures. I really think that the infrastructure is sagging. There are new technologies that can help water, electricity, cyber infrastructures, oil and gas, renewable sources. We are partnering with a big initiative that Director Chu at the Lawrence Berkeley Labs is doing called Helios on renewable energy and what we can do about renewable energy, but also decentralized distribution and generation of energy. And of course, in the area of healthcare, this is a part of our focus here is, of course, on electronic medical records and more broadly in the better delivery of healthcare using information and communication technologies. But inside CITRIS, there's people thinking about the paradigms of electronic design automation, CAD, computer-aided design, to think about rapid identification of targets, this bug to drug, exquisite sensing and monitoring, pre-symptomatic sensing of diseases and pathogens, and of course there's prosthetics, and as you know, there's a stem cell institute which is loosely linked to CITRIS as well here, and there's a homeland security angle which also of course means this. So again, you know, other things is, you know, in the information business also we are all swamped with information. People again use this term about the semantic web. What the semantic web is, you ask questions about what you want rather than use keywords or key pictures. And the question about then also producing data which has the correct integrity and provenance, you know. So nowadays institutions will create news, you know, just by swamping, by just sort of putting 20 stories about some fiction that they want to make reality. And so when you do a Google hit, you know, you get whatever people want you to hear. So it's manipulation of the media, manipulation of search engines, and that's what data integrity, provenance, and privacy. So privacy, privacy, privacy. You'll hear a lot about it today because one of the big things in electronic medical records is, of course, cybersecurity and privacy. So I think to this audience, we certainly need not sort of harp on this, but this is the biggest sector of the economy, and it's the fastest growing sector of the economy. And we do want better health care, and we do need to respond. And I think we're very, very fortunate today, by the way, to have Dr. David Brailer, who will come and talk to us about sort of the perception from his side, from the Office of the National Coordinator of Health Information Technologies, about what he can do. And of course, Laurie will tell you a little bit about what we are doing on the Cal Rio front as well. Again, in the interest of time, I won't read through all of this. The other sort of pet idea, and I'd like to sort of introduce my predecessor and former director of CITRIS, Rujna Baichi there. So she has played a big role in really thinking about elder care, elder tech. And this is, you know, these are United Nations statistics about population over the age of 60. The details are really that by 2050, 20% of the world population is going to be over 60, and of course it's the care for them is very different from what you think about it. When Rujna first started thinking about this, she called it elder tech, and you know, we were told very quickly by consumers, technology providers, this is a bad idea. Nobody wants to buy elder tech. It's really technology for better and more productive living for longer periods of time. And I must say, we really deeply believe that it's important to think about it's a very different kind of population. You know, there's people leading productive lives, and really it's about support for being able to do more for longer. And that, I must say, is a pretty interesting and engaging problem. I think that some of the speakers will come to it. Let me just now tell you a little bit about the technology trends, and I'm going to also plug Dan Macy's here from Vanderbilt in a second. So as a techie, you know, something really exciting is going on in technology. So this, you know, everybody's heard about Moore's law, where computers and communications, everything doubles 18 months, and that's all true. There's another guy called Gordon Bell at Microsoft who had a slightly different law, which says that there's a new class of computers that shows up every 10 years, and going from number crunching to PCs. But the most recent class of computers are these small wireless devices, sensor networks, embedded systems, and they're showing up in all sizes, certainly from cell phones all the way down literally to smart dust, which is stuff that you can paint into walls around you. So the issue is this actually makes computers able to deal with streaming data to and from the physical world. So a colleague of mine, Chris Pista, actually got it down to 2 millimeters cubed. I think that it's really, really important for us to organize ourselves into conferences, and in some way I'd like to say that I'd also like to introduce Riku Bakela all the way in the back here, who really got us going, is from Tekesh, the Finnish version of the National Science Foundation. It's the Science and Technology Funding Agency of Finland. And he really pushed us in the context of their own planning for FinVel to really think about these issues in the form of workshops that he called Connections. And he and Mike Eklund, actually, who are the big impresarios here putting this together, really sort of said connections. And it was important to get participation from this body. So I told you a little bit about this. I think that the issue here in technology is that there are pretty interesting privacy and regulatory issues. And even though this might seem like a niche interest, it's actually a big, big and important part of the technology. And there's a sea change going on now with the changes in the electronic medical records. And and I want to give you a sense of the complexity of privacy, access rights, and policies. To do that, again, I've sort of stolen one of Dan's view graphs. This bullseye chart gives you a sense of the complexity of relationships in healthcare information access. Because, of course, the patient, provider, payer, society, in the inner circle are the sets of people that have access to that information right away. This is the immediate family, legally authorized representatives, and so on and so forth. Primary care specialists, public health, law enforcement, and certainly from the payer, there is claims processors, insurers. And then as you go further out of this, there's national security needs, there's bioterrorism needs, there's clinical trials. And so when you start, so one of the big things that Dan sensitized us to, and this is from a talk of his called The Nature of Biomedical Data, is that when you start thinking about electronic medical records, and you know, it really can cause some pretty substantial and sometimes unintended consequences of this data being available to multiple kinds of people who are all associated, of course, with the core patient, provider, payer, and society. So I think that one of the reasons that we have to really pay attention to access as well as to, this is a little bit about that, this is Dan's team to do that. But again, I know Dan's going to be the speaker in the first session pretty soon. But one of the things that he has brought to our discussion today is the My Health Patient Portal at Vanderbilt. I think the slide's a little old. You probably have more than 8,000 patients enrolled in this. 11,000. Oh, it's a 3-month-old slide, I guess, since you're growing 1,000 per month. And it is a wonderful, so not only is it a real live patient portal with data from the Vanderbilt Medical School, but it's also, he has certainly been pretty open to the idea of the research community actually using not the live data, but synthetic parts of the data, and in fact, some very substantial parts of the data for being able to think about some of these unintended consequences, also the security and privacy issues. So let me just give you an idea of some of the, you know, the issue, of course, in the technology is the technology, policy, law, and in fact, what you want to see happen and become so intertwined that I think it's important for the technologists certainly to understand what the issues are from the provider standpoint. So from the technology standpoint, access control. So, you know, who can look at what and who can mine what data in what form. So you think that, I think perhaps the practitioners say, oh, you know, the technology is out there, it's just a question of setting it up. But when we go back and look at the technology community, we simply don't have languages in a computer sciencey sense, programming languages or languages, expressive enough languages, which can sort of take a description of policies, and in fact dynamic policies, because policies do change over time, and to be able to express them in a formal way so as to get devices and software and so on and so forth to conform to them, and then to actually enforce them. Data privacy. So again, it should be possible to learn from data while keeping individual data private. So there's this notion of what are called encrypted searches. You know, it's really important in this data to prevent people from going on fishing expeditions, or for being able to only answer questions narrowly. And the questions of how you do that while maintaining the integrity of the data, incorporating background knowledge, these are technology solutions which are really not yet there. Other things, and again, I won't, the question of how you put together the architecture. So Cal Rio has been thinking about really information architecture modeling and analysis, and of course the commercial world is also thinking about this. and certainly the unintended consequences of that. So these are some of the groups that we are doing here. One other thing I want to plug is a project that Rujna and Mike and me have been thinking about, is about sort of using this new class of computers that I talked about for helping in assisted living in homes. So if we really do have these computers that you can distribute in the environment on people and so on and so forth, how can you take advantage of it for doing things like monitoring of things like fall sensors or chronic conditions and so on and so forth? And I must say we've gotten some pretty interesting records in the context of this, results in the context of this test bed called Information Technology for Assisted Living in Homes. It's a joint project between the Finns and the Alexandra Institute in Denmark to think about how you can use this new class of computers with PDAs, cell phones, and integrate this into medical repositories. So we've been actually thinking about using this for, so that's with Aarhus and Tampere in Finland, to put together a sense of fall sensors are the first things we're thinking about. The initial focus has been on detecting when people fall and to be able to sound off alarms. But even there, the privacy considerations are all out in spades. Security considerations are out in spades. If you're monitoring all this, people know whether you're standing, sitting, walking. You can actually, whoever has access to this data can actually come up with a pretty good profile of your activity, and the questions about who has access to this or what purposes it's for is pretty non-trivial. So already for a simple application, which is sound alarms when somebody falls and doesn't get up for a little while, the considerations are difficult. Also, you've got to learn the pattern of activity. Different people fall in different ways. It's not easy to get people to fall so that you can get data to learn about how they fall, especially not an aging population. And so these are all, I mean, we use this particular problem as a surrogate for really thinking about some of these issues. So, and it's, of course, got implications for osteoporosis and so on. So I just wanted to put all this up to give you a sense of, there's a pretty interesting nexus here. There's a nexus of technology, what society needs, what healthcare providers need, so industry, there's a huge market opportunity here. We are seeing this already, you know, at CITRIS. We have a very, very important relationship with our so-called founding corporate members. They're IBM, Intel, HP, Microsoft, so the founding corporate members, Marvell, I actually missed a few since I'm saying this, but all of our industrial partners are talking about how there's a lot of room for good technology solutions. Our point in this workshop, I know we are glad to have some friends from IBM here, but what we want to explore in here is how do we organize ourselves to start understanding some really sort of compelling and engaging intellectual issues. So, Laurie, let me turn it over to you, and let me get your presentation up. Save changes now. There you are. Oh, yeah, I'll give it to you. Sorry. No, I'll be.
Wireless technology is also the challenge. Thank you.
The hospital told me that this little clicker will work from across the street or advancing with slides.
Oh, okay, perfect. Good morning, thank you. I'm only going to take a couple minutes so that we can really get on with the program today, but I wanted to thank you all for attending and just note as Dr. Graham mentioned this morning, the balance of suits and backpacks today. So I think it's really helpful, and it's really what CalRIO is all about as well, which is that balance of stakeholders who are interested in advancing healthcare, improving quality and patient safety, with keeping in mind privacy and security. And there are several slides that I have, and I'll see if I can go back. Oh, I can. About CalRIO. And I just wanted to spend a couple minutes to let you know what CalRIO is on the private sector side, because it's a very unique opportunity that we have to advance healthcare information exchange in California, but in concert with what's happening nationally. Hi, Bobby. So CalRIO was started in the fall of 2004 by Dr. Molly Coy, who's the CEO of Health Technology Center. And she asked 15 of the healthcare leaders in the state of California on the private side to get together here in San Francisco to talk about what we might do with Dr. David Brailer's influence in health information exchange. And at that meeting, 35 people showed up because no one wanted to be left out. And these were leaders from health plans, from hospital systems, from large medical groups, the California Medical Association, CMA, everything ranging from everywhere you would think on the private sector side, and even some public sector folks as well. And we talked about what our vision was, and I'll just breeze through them because it really helps to ground what we're talking about. This balance of technology capability on the clinical side and increasingly on the health information side, really bringing home some solutions for what's wrong with our health system today. And all of you know that situation where you go to the doctor and you say your name over and over again and how old you are and when you were ill last. When you go to the emergency room, they don't know anything about you, even though they're across the street from your primary care doctor's office. Doesn't it drive you crazy? You think about the opportunities that personal health records have, and we'll hear more about that from the Vanderbilt folks and some others. But there's some tremendous opportunity that we see in healthcare to solve some of the basic day-to-day problems. And that's why CalRIO was started. And so when you couple that with the national efforts that we are seeing in public health, in the Office of Emergency Preparedness, as the natural disasters that we're seeing really bring home the message about the need for health information, those types of forces are what's driven CalRIO to be moving forward in its current effort. Nationally, we also will hear a lot more about that from David, but again, it's not just California doing this. It's a national effort, and we'll hear today from folks across the country who are working in similar mechanism. Excuse me. So CalRIO was started, as I mentioned, in 2004 with a group of volunteers, roughly 150 individuals in the state, working in work groups looking at issues of technology, looking at clinical issues, governance, and design for not only the organization of CalRIO, but also the challenges of trying to implement health information exchange specifically in California. And so we developed a 501c3 organization that started February 1st of this year, so it took us 1 year to put it together. We initially developed a board of directors of 12 stakeholders, which represented everything from consumers to physicians to hospital association leadership. And with that vision of 12 board members, we have a board of 23. So you can tell that there's a great deal of interest. No one wants to be left out, not even the garbage folks.
It's recycling.
So this is where we came up with our mission. We also have a very distinct purpose, and that purpose is not to take the place of regional efforts, but it's to help connect the regional efforts. In a state of our size, you can imagine that we have opportunities for connectivity that are beginning to be launched, that are in their infancy, all the way to efforts that have been in place for several years. And so we are trying to help serve as the umbrella organization to connect those opportunities with each other and really drive that change throughout the entire state. So we're acting as an umbrella organization. We're not intending originally to be operating anything, but I have a feeling that that might change shortly. And we're really looking at being all-inclusive and transparent, making sure that safety net providers, the underserved population, are served in this system. Our role is to really help with the governance, providing a trusted open source of resource for the regional efforts, and also that communication back to the national effort. So we work very frequently with other states to make sure that what we're doing in terms of setting standards or looking at issues or developing architecture is in keeping with the rest of the nation. Our core functions are to communicate, convene, educate, and provide resources for the local efforts for implementation. And I'll talk in a minute about a couple of the things that we've done along those lines. We really don't want to be out on the forefront or the frontier of what's happening nationally. We want to be right at the edge of being in concert with national efforts. So some of the standards that are being developed for technology, we're advancing our standards here in California, but we're doing it in conjunction with the Office of the National Coordinator, the foundation, CITRIS, and so forth. Another function for us is to analyze, to organize, and to assess what opportunities are available. So our technical work group, which was made up of around 40 of the CIOs, CMOs, and others in the state, have been looking over the past year at clinical messaging standards, at technical architecture, and really trying to analyze what would work best in California to help connect the state, as large as it is, what's scalable, what makes sense, what takes advantage of the latest technology. So that work group is what's come up with the recommendations that we've developed that we're sharing with the local markets to see what we can advance. And you saw at the bottom there, privacy and security is an issue with all of this, and I'll talk a moment about our participation at that level. This is our schematic of what we hope to see in the state, and you can tell that what we're trying to do, again, is to stay in concert with the National Health Information Network. Mendocino has already got a demonstration site and a direct connection into the NIN, so we don't feel like Cal Rio needs to be involved in that other than to share the learnings. But we are going to end up acting as a hub in a certain sense for some of the connectivity for the communities that can't do that themselves. What we're hoping to see in some of the communities here, Little Rio B could be Sacramento. Sacramento has their own effort that they're coordinating with their own provider groups in a public-private partnership, and we're very excited about supporting that effort. So you'll see Cal Rio's role in some cases to connect the communities, but in others, they'll be connecting directly to the NIN. So what we've done is try to identify some early wins for Cal Rio and for the regions, organized under 5 different projects. The first of which is the ED Linking Project, and in that project what we're hoping to do is connect 350 emergency rooms in the state to critical clinical information about the patients that they're seeing so that they can provide better care for those patients. So it encompasses a master patient index for the patient, a record locator service, and then 6 to 8 clinical bits of information that are stored within the emergency room or other providers that we can help bring in, and that would be shared then among the emergency room physicians within California hospitals. It's an ambitious effort, but it's, we believe, going to help us to really launch some of the connectivity that we feel needs to happen, and it's also an opportunity to share with the public sector, the Office of Emergency Preparedness, public health services, and so forth, the data that we might be able to gather or some opportunity to improve our response for biosurveillance, for pandemics, and so forth. And you can see the list of others, and we can talk about them throughout the day. So I don't want to take up too much time, but specifically in privacy and security, before I turn this over to Steve, I wanted to let you know that because Cal Rio had been organized in this manner where we represented stakeholders from all aspects of healthcare, we were very well positioned to work with the Office of HIPAA Implementation in Sacramento to respond to the national RFP on privacy and security for our state. So literally within 3 weeks of even hearing about the folks in this office, we had our response written and turned into the folks at RTI for California's response on privacy and security. And this will represent, as you can see here, roughly $350,000 in funding, which is about half of what you actually need to look at the issues. But it's a 12-month project that will look at what the state and national federal laws and HIPAA regulations are that are barriers to the health information exchange that we're attempting to implement. And then we'll develop an implementation plan towards solving those barriers, whether that's recommendations of business practice changes or it may be legislative changes. But we'll be working on that with the Office of HIPAA implementation and the public sector component stakeholders. So it's a very exciting first step in this public-private partnership around health information exchange in California. So we're very excited about that. So there's a lot of things we're working on at Cal Rio with a very limited staff, so we really rely on the volunteer work that we've seen around the state, and that's been phenomenal. And I want to just turn it over so that we have plenty of time for Dr. Graham and Steve. And I know you don't have slides, right?
Can people hear me okay in the back?
We need the microphone for the webcast.
Right, absolutely. Thank you. Okay, now we got it. And this is on, is it?
Yeah.
Okay, great. Let me just add my welcome to Lori and Shankers. I'm going to be brief for two reasons. One is we really want to get into the program. Secondly, I have class in about 7 minutes. And we take teaching seriously here at Berkeley, so I will be fairly brief.
Even deans teach.
Even deans teach, or at least some deans teach, the ones that can't figure out how to get out of it, I suppose. A couple of things. First of all, just to elaborate on what Shanker had said, but to underscore, one kind of analogy or metaphor, whatever it is, that we use to think about our health system in this country is this three-legged stool, looking at access, cost, and quality of care. And he has shown the slide earlier. We're actually at $2 trillion now, about 16% of GDP in the U.S. That's on the cost side. And yet for all that money, we still leave about 46 million Americans without any insurance coverage at all, and any other number that you can cite, perhaps underinsured. But we always used to pride ourselves that, yeah, that's true, we're costly and don't have universal financial coverage, but boy, do we have high quality of care. And that just is not true. We have extreme variations in quality of care. There are now national studies that indicate most of us here in this room probably get recommended care only about half the time. And on the provider side, we've done work, Tom Randall and I and others here at the university, indicating that providers, physician practices in this country, only use available evidence and ways of managing patients with chronic illness about half the time. So we know better, but we do not do better. And so these are part of the challenges we want to examine today, is how can IT fit into this equation? It is not the solution. It's an important part of the solution. But as Shanker has underscored, it needs to interact with a whole variety of other things to get to the tipping point of changing some of these realities we just talked about. It has to do with financial incentives for providers and maybe patients and the public to engage the technology. It has to do with external reporting and transparency and accountability, so the American public knows what's happening and can exert the political process or other means to change things. So it's part of a whole ball of wax. One way to think about it as you go through the conference today, it sometimes helps me, and it's oversimplified to be sure, we all use our shortcuts, is incentives and capabilities. Incentives that are needed by various stakeholders, okay, to change their behavior, and on the other hand, the internal capabilities to be able to respond to the incentives. And IT can be a very powerful enabler, very powerful on the capability side, but it's going to be dead capital, if you will, unless there's incentives for its use. And we need to talk a bit about that as well. The last thought I want to communicate at the beginning is to recognize that the slide Shanker had up there about the age distribution and the work Rosina and others have done here on the age distribution and how that's going to be one big fat continuous bar graph as we go forward in the future. 20% of Americans will be over the age of 65 in the next 10, 15 years. And chronic illness is just going to be huge. Right now, 3/4 of people over 65 have at least one chronic illness in America, and of those, 50% have more than one. What this means is that we are going to be interacting with a delivery system of multiple providers and care settings. There's some studies that show on average, if you have more than one chronic illness, on average you're seeing 7 different physicians in a given year. And if you're hospitalized, that increases to about 13. So this connectivity, exchange of information, interacting with privacy and security issues is going to be huge. And I'm just going to end on my own personal little story, which bears out Laurie's point and Shanker's as well. I lived in Evanston, Illinois for about 16 years, and we had a next-door neighbor. Dorothy Johnson was her name. Dorothy was probably in her 70s or so, and she came down with bronchial pneumonia, usual cold, and then it just kept getting worse and worse. But to cut to the quick, she had, her primary care physician. She had to be hospitalized. She went into a nursing home for a while. She came back out, went back into the hospital. Finally, she came back home, and she was being seen by home health care. So Dorothy told me this story a few years ago of the home health care nurse that comes to see her after about 6 months of in and out and copious medical records and so forth. And she goes up to Dorothy and says, "Mrs. Johnson, are you allergic to anything?" And Dorothy couldn't take it anymore. She screamed at this nurse, "Am I allergic to anything? Yes, I'm allergic to sulfa. I've told that 15 times. Don't you people talk to one another?" And the answer is no. No. And I remember relaying this example to my class. And my class, there's a nurse in back raises her hand and says, "Oh, Professor Shortell, that home health care nurse did the right thing. That patient shouldn't have yelled at her. She did the right thing." Oh, and this was a nurse now. "You're supposed to ask, and double check and so forth." I said, "I understand that, but how could that communication have been different?" She could have gone and said, "Mrs. Johnson, I see here you're allergic to sulfa. Is that right?" Changes the whole ballgame, right? But did not do that. And in fact, the home health nurse did not have that information at hand that she was allergic to sulfa. And those stories can be repeated, I'm sure, by all of us. So I'm off to class, but I'm going to rejoin later, and I know it's going to be a terrific day. Thank you for coming.
Thank you. I'm Mike Eklund. Just to introduce myself, one of the organizers of the event, and I'll just in summary what the main organizers were saying. What we're really hoping for today is a lot of discussion, a lot of ideas coming from all the different sides of this issue, so that we all get a chance to learn.
Some logistical details, maybe you could tell people that bathrooms off.
Okay. And logistical details, I'll pass on too. Through the panel sessions, we've left time in each one, and also at the end of the presentations for questions and discussion. We're really hoping to generate a lot of discussion between the different areas. I'm representing, of course, the technical side of things, and we're very excited about learning all that we can about the implementation. And we're really hoping that the people that are on the ground doing this sort of thing can get some ideas from us about what is possible with technology today. So in terms of some logistical information, there's bathrooms outside the door here. There's the men's bathroom is on the near side of the staircase. The ladies' bathroom is on the far side of the staircase, off to the right. We will be having coffee and snack breaks during the day, so you shouldn't fret about that. Is there anything else that I should? That should be good. And then, in the interest of time, I will just very briefly introduce Dr. Justin Graham from Lumetra. And there is a handout with his bio on, and I please ask you to refer to that and read his very detailed biography there. Welcome.
Thank you. So I did my informatics training at Stanford, and so every time I come up to this campus, I'm worried I'm going to get eaten by a bear. But you guys have been tremendously hospitable and so far, and nobody's waved a blue and yellow flag in my face yet. So I appreciate it. Well, yeah, that's right. I'm in disguise. Didn't even think about that. Well, thank you so much for having me. And we heard a great series of introductions to the problems that are being faced in healthcare. Actually, before I start, just out of curiosity, how many people in this room consider themselves more or less in the healthcare field or pretty expert in healthcare? And how many people are pretty new to understanding the issues in healthcare? A couple. So it's a mixed audience, as I thought. So some of the issues I touch on, hopefully I won't get too deep. So hopefully we'll get some basic grounding for those of you who don't haven't really thought about problems in healthcare, and hopefully we'll have some good discussion at the end and figure out, bring some new opinions into the equation. I am medical director at Lumetra in California, in San Francisco. I'm also a practicing infectious disease physician in San Francisco. Now, for those of you familiar with funny names in healthcare, you may think Lumetra is some kind of medication. We have nothing to do with pharmaceuticals. We're not Levitra and we're not Lunesta. And so please don't get confused. There's a lot of sound-alike medications out there, and that's one reason why we have a lot of drug errors in the hospital setting. But Lumetra is none of those things, nor do we make light bulbs. We are a independent, nonprofit healthcare consulting, analysis and education organization. And we are California's quality improvement organization for Medicare. And we see our mission as being dedicated to improving the quality, safety, and integrity of healthcare. And we really see ourselves as being the main, being really focused on quality improvement in healthcare here in California. And our CEO, Joellen Ross, has just joined us as well. So some of you may not have heard of the QIO program, and I refer you to the excellent report that was recently co-authored by Dr. Shortell on the QIO program for the Institutes of Medicine. But the QIO program is a network of 53 organizations, one for each state and one for 3 different territories, enacted by federal statute to improve the efficiency, effectiveness, economy, and quality of services to Medicare beneficiaries. So we have contracts with Medicare federally to work with providers of Medicare services across all settings to help improve the quality of care. And Medicare, for those of you who aren't in healthcare, Medicare is really the largest purchaser of healthcare in the country, providing essentially insurance services to virtually everyone over the age of 65, as well as many who are younger, who are disabled or, for instance, on dialysis. So our contract with Medicare from 2005 to 2008 is to help healthcare providers providing right care to every person every time, following with the 6 aims for quality medical care that were outlined in the Institute of Medicine report from 2001, Crossing the Quality Chasm: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. And we're trying to transform healthcare. That's what we see as our goal. Because where we are today is we have to cross a huge quality chasm, as was written in the report, to get to where healthcare really ought to be, based on what we know, based on evidence, and based on our understanding of how healthcare should be delivered in the right way to the right people at the right time. And we're using 4 key strategies to deliver that level of quality improvement. Now, we work across a wide variety of settings, and I'm going to focus a little bit on the challenges I'm working on in healthcare IT, but I wanted to let you know a little bit about all the wide variety of programs that we work on. In hospitals, we're trying to support improved acute care for myocardial infarctions, which are heart attacks, congestive heart failure, pneumonia. We're trying to reduce complications of surgery by using evidence-based methods to prevent infections after surgery or other complications of surgery. We're also supporting healthcare IT in the hospital setting. I won't talk so much about that today, but that's another area of healthcare IT that we're very interested in. We're working with our Medicare beneficiary and Medicare providers in nursing homes, where so many Medicare patients are, preventing preventable complications like pressure ulcers from patients who are bedbound, using overuse of physical restraints for demented patients. In home health agencies, we're trying to improve home health care by reducing repeat acute hospitalizations for patients who are at home who really shouldn't need to go back to the hospital, improving immunization rates, which are really quite low, much lower than they ought to be for preventable diseases like influenza. And of course, in the physician office, where we've been doing a tremendous amount of work on information technology, but also on other issues like improving cultural competency so that all patients, regardless of their ethnic or cultural background, are getting equitable care. Now, Dr. Shortell referred to this study earlier. This is a groundbreaking study and one which really raises many of the issues that plague healthcare today. Only 55% of outpatients get what's recommended evidence-based care. And this is across a wide variety of disease states where we have really good evidence about what's the right thing to do for patients. Yet if you do the review of medical charts and you take a look at what patients are getting, you'll see on average it's 55%, and in some cases it's as low as 22 or 24%. Even in the best case scenario, coronary artery disease in this study, you're looking at 68%, and even in medical school, 68% is an F. So that's really not good enough. This is a study that's, you guys all have these handouts, and you really should, if you haven't gone to the New England Journal and looked at this study, it's a pretty eye-opening one. But there are other similar studies as well. You know, one quarter of all outpatients have adverse drug events in any given 3-month period, and many of those, if not all of those, are preventable if you knew that the patient was already allergic to the medication, or you knew that the 2 medications that the patient were on were incompatible and potentially caused a drug-drug interaction. And clinicians are missing essential patient information that would probably change what they do, about 14% of all visits. How many of you have gone to a physician's office where they said, well, I'm sorry, I don't have your lab test back, or I don't have your data, or could you call your hospital or your previous provider and have them send me that information? I bet you at least 14% of the people in the room have had that experience. And as a physician, I've had that experience again and again. It's actually personally quite embarrassing as a clinician to have someone come to you after expecting to hear some words of wisdom, only to be told that, sorry, you'll have to come back in a week or 2 after we've repeated those tests because the lab lost the results. So a lot of players in healthcare have really started to think about healthcare IT as a potential means for solving some of these quality problems, or at least enabling the solutions to these problems. And that's why we've seen a lot of momentum nationally, statewide, and locally towards implementing healthcare IT. And I've just put a sampling up here, and we'll be hearing from our National Healthcare IT Czar from the Office for the National Coordinator of Healthcare IT. Dr. Brailer will be here a little later today, and his office is he is to be credited with really driving the national agenda forward. But many other organizations have recognized healthcare IT as a potential means to solving some of these problems we have with quality of medicine. And that's because people sort of see healthcare IT perhaps at the foundation of really all the efforts that need to be done to drive quality improvement in, particularly we're talking here about primary care and outpatient care. The understanding of the care models of disease care have been well elucidated, particularly by people like Tom Bodenheimer at UCSF for years, but it's only recently that with the emergence of improved healthcare information technology that people have begun to think about how to bring the technology in and actually use technology as an enabler to drive these quality improvement goals. So it's not just the technology itself, but it's taking the technology and putting it in place with the quality improvement techniques. And to be able to use the technology to do things like managing your population and using data to drive how you practice medicine. In the same way Walmart uses data to drive what to put on its shelves and where to open stores, or the same way your bank uses data to figure out what services to offer or how to reach out to you about offering you a new mortgage, your providers should be using their data to look at their populations and figure out where they're making mistakes or where they could be improving around these 55% areas of evidence-based care where they're not, 45% of the time where they're not getting it right. They should be able to look at their populations instead of one patient and one piece of paper at a time. We also think healthcare IT could be important for delivery system redesign, thinking about teams of care so that there can be, as we talked about, where care can be coordinated among 13 different providers. How do you redesign the system so it's not every provider on its own thinking about the patient without the context of what's been going on at other visits and other places where care is provided. Decision support is extremely important. That's where we've seen a lot of evidence for potential improvements in care with alerts and reminders at the point of care when that drug is prescribed for the provider to get an alert or a reminder that this patient may be allergic to the medication, this patient is due for an influenza shot, or that you've forgotten the evidence says that this patient is actually due for cancer screening or should have a particular lab test done. And these decisions, you can do these things on paper, but it really doesn't make sense to set up these complex systems on paper when you could do it so efficiently with information technology. And lastly, of course, self-management, involving the patients more and more in their own care through personal health records and patient portals and patient-provider communication. We'll be hearing a little bit more about that later today. And so we've got this as the tool, but as Dr. Chotel mentioned, what we need are incentives, and that's why there have been these pay-for-performance programs to try to drive clinicians towards using this technology and towards actually adopting it. Medicine is really a cottage industry in this country. We have many hundreds of thousands of providers, and most of them are separate, individual small businesses. And so it doesn't matter what the federal government says, it's what individual small businesses decide to do, driven by market forces or driven by other forces. There's no national, even no matter what the national czar of healthcare IT says, it's your individual provider, if he or she is a solo provider, makes their own decisions about their business. And so we have these pay-for-performance programs where health plans that pay providers are trying to create financial incentives for providers to implement these systems so that they can improve care. And we're seeing that in a variety of programs that are being rolled out both here in California and nationally. The hope is that we'll get to the tipping point, but you can see in this survey, which is a year old, but it's still pretty recent, it's still pretty up-to-date data, and it's probably the best data, that we're not seeing a majority of providers interested in implementing electronic health records anytime soon. The numbers in this slide are really, even in the best case, are even providers who are under 35 who may have been done all of their term papers in college on a computer and have had email since they can remember. Still, only 27% of them are interested in implementing electronic health records. And if you look at the small practices, less than 10 providers or even solo providers, it's only 18% of providers who are thinking of implementing electronic health records. That's more than 70% who aren't even planning to buy an EHR. The reason is there are tremendous barriers. There are tremendous barriers in this sort of disorganized cottage industry of healthcare that we have right now. The number one reason is financial. You hear this from providers all over the place. The costs of implementing an electronic health record in a small practice can be overwhelming. And when a small office has pretty tight margins as a business, and they look at the cost of buying the hardware, buying the software, getting the IT support in a practice where they specialize in healthcare. They don't specialize in IT. They don't understand how to do backups or how to set up a wireless network, and they don't understand about software vendors. Those costs are very daunting to a small practice. And when it's a solo provider or a few providers in a practice, those costs end up coming out of their pocket, out of their take-home pay. And you can understand what their reluctance might be, especially when you realize that the benefits from implementing these systems financially typically do not accrue to the practice. They may be delivering better health care, and they may have noble interests and professional interests in delivering better health care. But if you get better health care and have fewer complications and fewer repeat tests, the party that ends up saving money is actually your health plan in most cases, or your purchaser, because they don't have to pay for a repeat test, they don't have to pay for your hospitalization. The small office ends up financially, doesn't end up really getting that much out of it. So the financial business case, unfortunately, does not favor the implementation of these records in the small office. There's a very uncertain return on investment in implementing it, as I said, and there's a lot of time cost of the physician who really is pretty maxed out on seeing patients, in some cases every 10 to 15 minutes. There are technological barriers as well, because the technology's only recently gotten up to speed. We're seeing there's data fragmentation and poor interoperability, which is why an organization like CalRio has developed, but CalRio is still in its infancy. And really, if your provider has an electronic health record, there's absolutely no guarantee. In fact, it's most likely that health record can't talk to any other electronic health record anywhere else. It's usually a standalone system that doesn't have any interoperability with any other system. So your provider may have the most advanced electronic medical record system in the country, and your hospital across the street may have a similarly advanced system, and they probably can't talk to each other. They probably can't talk to each other. There's a tremendous amount of customization. Well, the reason why these things can't talk to each other is because the standards, the slide says lack of standards, but really one of the great things about healthcare information technology is standards is we have so many to choose from. And that, of course, is the big problem, is that you don't want so many standards to choose from. You want one set of standards that everyone agrees on. But there's a lot of problems with standardization in healthcare IT. It's beyond the scope of this talk, but it's an issue that still has not yet been resolved. Cultural issues and cultural barriers are enormous. Providers are really used to using pen and paper and a little uncomfortable about changing the workflow to using a computer. They're worried that when you as a patient come see them in the office, that you're going to be worried that the physician or the provider is focusing more on a computer than on you, and that's been a big concern of clinicians. And there's also inadequate technological competency. Medical school really doesn't focus on healthcare information technology. It doesn't really focus on anything other than medical technology. And so it's quite easy to come through 4 years of a top-notch medical school and really have very little understanding of how computers should be used to drive improvements in healthcare. And lastly, there are a lot of organizational barriers. Practices don't have project managers to do implementations. They don't understand who should be a leader in these kinds of things. There's no real understanding of how to migrate from having a paper-based practice to a paperless practice, and what do you do with all the faxes that keep coming in, and how do you train your staff, and how do you deal with all the legal and regulatory barriers, which are quite formidable both federally and statewide. So as you might imagine, with all these barriers, and if you're running a small office that's running on very tight margins, you can see why maybe you may not want to be implementing one of these EHRs so quickly. And the other problem is, as I said before, small offices may have the hardest time of all rather than a large office, yet the vast majority of practices are in small and medium-sized offices. This is data from 2001 from the AMA, showing of all the physicians that they have registered that are self-employed or employed in physician groups. Over 140,000, over 33% of the physicians in this country are solo providers, and really the vast majority of providers are in the under 10, practicing groups of under 10. And the smaller the practice is, as I said, it's a cottage industry, the fewer marginal resources you have, additional resources you have for marginal gain of hiring IT support staff, dividing up the cost of ownership of this system across multiple providers. So we're really dealing with a problem where if we're going to bring healthcare IT to the masses and achieve the president's vision of every patient having healthcare IT, having an electronic health record by 2014, we have to deal with this huge problem that the vast majority of patients are seeing their providers in small offices where there aren't the resources for implementing these systems. Medicare sponsored a pilot project that Lumetra was the national leader on called Docket. It's Doctor's Office Quality Information Technology, and you may have heard of it. We got a little bit of press while this was going on, and it was a pilot project to help small, medium-sized offices overcome these barriers and implement electronic health records. We were the lead quality improvement organization. There were 3 other states that were involved as well. Trying to implement EHRs in about 150 to 200 practices in each state. It had a primary care focus, and again, focusing on practices that's on Medicare patients. And it was a national model that was to be rolled out to all of the quality improvement organizations. And we developed tools to overcome each of the barriers that I talked about earlier. These tools were in the form of templates that could be filled out, workshops, presentations from local and national experts, workshops, peer-to-peer networking, and online communities making use of some of the latest in networking technologies such as web forums, and trying to help these small to medium-sized, essentially small to medium-sized businesses, these physician practices, overcome these barriers and implement healthcare IT, and then use this new technology as an enabler to drive quality improvement. We enrolled 123 practices representing over 700 California physicians, and we had a great result. And we had ultimately 42% implement an electronic health record. This is approximately triple the national average now, almost triple the national average. So very successful program, pilot program, and we're very excited about it, and we had some really very positive feedback from the practices we work with. We think that this represented a scalable model that hopefully we could scale up to larger and larger groups of physicians as the financial incentives from the pay-for-performance program start to drive them into being more interested in these programs. Hopefully we can provide them with the tools to be able to actually overcome the barriers to EHR adoption. And hopefully be able to, because we can't go out one by one to 150,000 practices in the country, hopefully we have a program that can scale up to large numbers of clinicians. Our latest task is to scale up to 400 practices in California dispersed throughout the whole country, rural and urban settings, again focusing on Medicare primary care providers. And our goal is to take more than 80% of these 400, so that's about 320 practices who have no existing healthcare information technology, and have more than 75% of them go live, and really set a very high, it's a very high bar, a very high threshold to cross. But our goal is to really set the mark so that we can really then even scale up even further and really start to look at the big picture of really tens and hundreds of thousands of practices that need to implement electronic health records if we're to achieve this vision by 2014 or even come close. The next few slides are just a brief introduction to what sort of the elements are of the program, and I'm going to go through that pretty quickly, so you guys can take a look at the slides if you want. I do want to leave a little bit of time for questions and discussion at the end. But essentially, we feel that we can drive EHR adoption in a 9 to 12 month period. We think of this as sort of a guided tour to EHR implementation, or an EHR university course in 3 semesters. With peer-to-peer support, using doctors to talk to other doctors, which we think is a great way to drive EHR adoptions, because doctors are a notoriously ornery bunch and only like to hear things from other doctors. They don't really listen to people who aren't doctors, so we like to use doctors to talk to other doctors, and that seems to work well. And we have online collaborative communities. We're using some of the latest in networking technology so that, because we're so dispersed throughout California, so that these providers can talk to each other in our online forums. We have workshops, teleconferences, and a lot of personalized assistance, and a library of about 150 downloadable tools and templates so that providers aren't reinventing the wheel every time, and they're not having to do things like choose from among the 200 plus vendors of electronic medical record systems. They're not having to do that completely on their own. At least they have some guidelines and some help. We kicked this off in November. It's free for Medicare primary care providers. Medicare's foot in the bill, which is great. And this is our sort of our course curriculum and overview, and we've divided up the roadmap, as it were, from having nothing in your practice to adopting technology in phase 1, implementing an EHR, going through the project management tasks of action and workflow changes and redesign, practice redesign tasks of implementation. And then finally, after you've gone live and you can stop and take a breath and you've actually done the complicated change management tasks, then how do you take this system and actually drive some quality improvement and actually demonstrate that it's not just that you've put in a new fancy computer system that maybe you've gotten rid of your dictation system and saved a little bit of money, but how do you actually then implement all those other things that we said that the healthcare IT system was foundational for: decision support, population management, patient-centered care. So I'll just breeze through these topics, and the milestones for each segment of our curriculum are in your handouts and will be available online, and you guys can certainly take a look. And much of this material is available online for download if you want to contact me. A lot of what we do, virtually all of what we do, is in the public domain because it's paid for by the government. Here's an example of what our web portal looks like that our physicians are using. It's similar to what many of you, I think those of you who are in the academic world and are pretty familiar with using sort of the latest things that are going on with blogs and web portals and wikis and those kinds of things. Physicians are a little out of the loop on those things, but we're getting them more in the loop, and they're really responding quite well, and they're really excitedly being involved in these kinds of technology. We think the benefits are tremendous to our physician offices. They get assistance with their assessment of what their needs are and their requirements in their office. guidance for vendor selection. We advise them during implementation. And we hope that we see improved chronic and preventative care and increased patient safety. And hopefully we'll prepare them for pay for performance, which we talked about earlier. And I'm not going to go into great detail about that, but needless to say, if providers are going to be paid a little bit more, some bonus payments for providing higher quality care, there's going to need to be data collection or collecting around those measures of how they've been doing. And to collect that data, you're going to need better information systems, and you're going to need better tools and better techniques in your practice. And we think the practices that work with us to implement these healthcare IT systems, they're going to be better prepared for this new way of healthcare financing, this new wave that's coming our way. We're not providing any grants or capital funding, and we're not implementing EHR systems directly. We're not doing one-on-one consulting projects. Again, we have a scalable model that is an assistance education model, and it's a peer-to-peer networking model, but we're not doing one-on-one assistance. We're not giving grants, and we're not a help desk, and we're not going to negotiate on behalf of practices. So we're not a one-on-one consulting services in that sort of traditional mode. That's not scalable to 150,000 practices. So as of most recent statistics, we've had over almost 500 practices request applications, and we have 284 active practices divided up in our different semesters of our curriculum. We've had 20 teleconferences in the last couple months, 2 large workshops, and we have over 152 active practices on our web portal. So we've been pretty excited about it. And we're going to tie this in with a pay-for-performance demonstration project that's coming out from Medicare that's going to be linked with work with our project, and those practices that work with us will hopefully get a little bit of a reward from Medicare. Medicare, which has moved a little bit slowly into the pay-for-performance realm, but has some demonstration projects that were part of the Medicare Modernization Act that passed a few years ago. And we're hoping those will roll out soon here in California, modeled on some of the other programs that are going on nationally. And we're pretty excited about it. And as you might imagine, the practices that are working with us are pretty excited about it as well. Not only are they getting free assistance on implementing healthcare IT, they're also potentially getting some bonus payments for being a part of the program as well. So I'm not sure that any of you represent any practices, but if you do, or you have a primary care provider who you think might be interested, let them know. We'd be glad to sign them up. We still have a lot of slots available in the program. Those of you who aren't from California and want to learn more about the Quality Improvement Organization program, and maybe want to look at what the QIOs are in your state, which every state has one QIO, so what your state's QIO is, you can look that up at aqua.org. And if you want to contact us about partnership or working with us, I've put the contact information for one of my colleagues, Glenn Moy, or myself, and I'd be happy to take any questions about any of the issues I've raised today. So thank you.
Can you go back one slide?
Sure.
Didn't get that. Good.
Oh yeah. And my understanding is these will all be available on the website too. These slides will be available on the website. Sure. Tom?
Yeah, Justin, I have a question regarding those practices that have implemented EHRs. What is their exposure as we've now moved into the wonderful realm of certification of ambulatory care health records, which, interestingly enough, precedes the adjudication of interoperability. So I just wondered how many times people are going to have to be recertified. What is going to happen to those folks who've installed a system that does not get certified?
Well, that's a great question. Let me just back up and give people the background on the certification process first. Some of you may not be aware of that. One of the barriers to implementing these electronic health records is that there's at least 200 vendors selling to the primary care audience. If you went and bought a car, how many car vendors are there? You probably couldn't. I mean, even if you were really wide open, you'd be looking at maybe 20. And an EHR is tremendously complicated, has as many features and functionalities as a car, yet you have to choose from among 200 vendors. And right now, anyone could just go out and put together a spreadsheet based on Microsoft Excel and try to sell it to your physician or to you and say, well, this is an electronic health record. This works as a health record, and why don't you buy it and we'll gussy it up for you. So anyone could sell an electronic health record, and as a provider who might know a lot about healthcare but little about technology, the overwhelming number of choices and the dubiousness of some of the choices has been a real barrier. So there's been a recent public-private-led consortium called the Center for Certification for Healthcare Information Technology, led by Dr. Mark Levitt, who that have put together with some federal grant funding, have put together a certification process for vendors' electronic health records, so that ultimately, at the end of their process, a vendor would submit a piece of healthcare information technology software to them, and they would put it through a series of tests, and at the end of the tests, that software could get a sort of a good housekeeping seal of approval saying that it's certified. It would be a voluntary process, but the idea is that because there would be a publicly agreed upon, well elucidated, it's not a black box, it's a very open process of what constitutes a certified vendor, then all of these pay-for-performance programs would be based on it, and ultimately everyone in the marketplace would be driven towards certified vendors. In the same way, you may not realize it, but when you buy any kind of electronic equipment, it's often underwritten and certified to meet standards so that, for instance, when you plug it into your outlet, it's not going to short out your whole electrical grid. So there's a certification process. It's under development. The certification functionality criteria and so forth have only recently been released, and the process is moving ahead, but it's quite exciting. And the idea is to really drive the marketplace forward with some ideas so people can buy things and feel safe about it. The question I think we had in the back was, what are people going to do today if they buy from a vendor in a product that's not certified, and where are they going to be, and also how can they have certification when some of the issues that we're worried about, such as interoperability, haven't fully been elucidated? How can you have certification? And I think there's been a widespread agreement that this has to be sort of an iterative process. I think if we wait for everything to come together, and this is you'll hear more from Dr. Brailer later on because this is really his philosophy. If you wait for everything to come together, you'll get nowhere because everyone will be afraid to take the first step. And the idea is to at least begin with something that's good enough. Don't let the perfect be the enemy of the good. And start off with something that's good enough that may not have all of the criteria yet specified, that may not be perfect, but is good enough to at least get the ball rolling and iteratively improve. And at least from a functionality standpoint of what an EHR should offer to a physician office in terms of the functionality, I think those criteria are quite reasonable, and they're all public. You could go to cchit.org and download the huge list of criteria. There are many, many items, and they're I think pretty reasonable, and they've spelled out where they're going to go in the next couple of years. The functionality criteria are a little more vague. I mean, the interoperability are a little more vague because that hasn't been specified on a national level. But you need to start with something, and at least so that the people who are building the networks, like CalRio, at least know what they're building towards. And these criteria will iteratively build upon each other. Now, for a physician practice that wants to buy an EHR right away and not wait for certification, some have already purchased, and hopefully they'll have purchased from reputable vendors who are following this process and fully intend to upgrade their systems to be compliant with the certification process. For those that are ready to purchase today before certification goes live in 6 months, our recommendation is that in the contractual negotiations that you get your vendor to contractually agree to meet the certification criteria and to upgrade your system until it meets that certification criteria. So, and in fact, even hold back some money until they've done it at some point. So there are contractual ways to go about doing that. There's a question here.
Yeah. To what extent are the providers you're working with using an application service provider strategy as opposed to purchasing a standalone hardware and software option?
Well, it's a good question. I don't know the exact breakdown, but it's increasingly moving more and more towards the ASP side. And it's only recently that model has started to make a little more sense. First of all, more and more vendors are starting to offer it, particularly the vendors of some of the better, higher quality pieces of software. Additionally, the financial models are such that it makes a little more sense for a consortium of physicians to get together. Even though we have physicians are sort of cottage practices, but if they can find a local organization, whether it's a physician group, independent physician association, or a local hospital or a local medical society that wants to be the provider of the ASP provider, and so that they're not necessarily contracting with the vendor who's going to be the ASP host, but it would be a local, trusted third party, whether it's usually groups of providers together. And they can often get some efficiencies of scale and save a lot of money that way. And it also offloads from the individual practice the responsibility for backups and networking and hardware updates and software updates, and they can sort of push that off to a third party who has the resources to do that. So I don't have the exact breakdown, but it's increasingly getting to be a more and more popular model. I know that. Question over here.
I know a physician, a relative actually, in a small hospital in New Hampshire, and I've talked to him about electronic health records, and he's been extremely resistant to this, and his concern has been that it will increase the amount of time he has to spend doing, quote, clerical activities, and he's already sort of stressed out at the end of the day. And so my question is there any empirical evidence yet as to what the impact of EHR are on physician time? And has anyone found ways to deal with this in the user interface to reduce the amount of time the physician has to spend there? Because the perception is that it takes longer to enter this stuff on a computerized medical record than on just writing it down on paper.
No, it's a great question, and the literature is replete with studies on time motion studies and studies on these information systems. The problem has always been in the informatics literature is how reproducible is this data. You're talking about systems that have tremendous variability in their user interfaces from place to place, even from time to time as there are upgrades. And similarly, you have tremendous variability in workflow and individual physician expertise and technical ability and leadership. And it's not even clear that what's published in the literature about what happens at practice A is necessarily applicable to B, C, or D. Additionally, the vast majority of the studies in literature are those that have been done at high-powered academic medical institutions which aren't necessarily generalizable to those 150,000 small practices I talked about. I think there's widespread agreement that these information systems probably do require a little bit more time on behalf of the clinician. And they do require some new skills that clinicians may not have, and that may be typing and using a mouse, which are not necessarily skills that particularly for clinicians who've been in practice a long time, have a lot of experience with and have a lot of facility with or comfort with. And it probably does slow clinicians down a little bit. There are resulting gains, though, in productivity that if you are implementing these systems correctly and if you are able to really leverage them, you probably ends up being a wash, if not maybe a slight improvement. You get reductions in repeat testing. You get reductions in these running around the office looking for lost charts. You no longer get these frantic phone calls from pharmacies about they can't read the handwriting on your prescription. You can offload a tremendous amount of the work that you as a clinician used to be responsible for directly to your office staff, to your medical assistants, and often you can just approve it with a click of the button. You do have to do a little bit more typing, and sometimes the dictation is not as good, and sometimes you have to do a little more pointing and clicking, and particularly the early days of implementing the system, the first 6 months to a year, it actually can be a little bit more work. You have to get all those old paper records, and someone has to be in charge of putting them into the chart, and sometimes some of that data is just so complicated it has to be someone with the expertise of a physician. So particularly the early years of implementing the system, you do lose some productivity. I don't think there shouldn't be any doubt about that. But the long-term gains for the practice hopefully are such that you end up seeing a tremendous rise in productivity. And anecdotally, and I think that's the best we're able to get right now because there's so much variability in systems, we do hear of a number of practices who, after a break-in period of 6 months to a year, are seeing a lot of efficiency and are able to go home earlier, which is a big win for physicians. Physicians often are working till like 8 o'clock at night, and it drives them nuts, and they get to go home earlier. Even in some cases, that means they go home earlier, have dinner with their family, and then stay up at night doing their charts on the computer. But at least they don't have to carry a big thing of charts on the computer. So there was a question there.
One more question.
Oh.
How have organizations like yours prepared for the movement towards RFID some technology experts predict would be ready in 5 years? 5 years.
Well, RFID, this is another area where the technology is moving far faster than the culture and the changes that are going on. I think the first place you'd see RFID have an application might be in the hospital, where you have lots of patients and you need to keep track of where they are at any given time. But in the outpatient setting, aside from one enterprising CIO at the Boston area hospital who had his own chip implanted into his arm, you're not going to see a lot of that. We're still having problems where we can't even, we're having trouble. 70% of physician offices are still using pen and paper every day, and we'd be happy just to get them up and using some very basic information systems, let alone asking patients to have RFID or using RFID in the outpatient setting. So I think we're I think in 5 years, if we even have half of our physician offices using computers on a regular basis, I think that would be a huge achievement. RFID, I think we're many, if not decades away from using, I think, for patients.
For patients.
Yeah.
Well, there is wide applications of RFID, not just for patients, but also for identifying people with the current consciousness on terrorism and stuff like that.
Oh, yeah.
So they're finding ways, and RFID is one of those.
Well, if the national debate moves to a point where our nation as a whole is willing to accept sort of a national experiment in implanting chips in people's skin to identify them, and with national identifiers, might have, we could really leverage off of that for much improved health care. But I'm going to leave that to the national debate in Washington, and I'm not going to suggest that today. So.
Anecdotally, there was just an article in this week's Annals of Internal Medicine where they had a barcoding thing, and a patient in the ER got the wrong ID bracelet and had terrible things. He got the idea of a diabetic and was going to get insulin. So that even once we get fully technologized, we still have problems.
That's a good one. I'll have to pick that up. But yeah, the technology is not foolproof. It does not immunize you from human error. So.
I think we will have to move on. We'll have plenty of time for more discussion in the next panel sessions, and the same questions
Thank you.
will be directed elsewhere. Please join me in thanking. And we'll take a short break now, maybe about 10 minutes. If I could ask people to sort of try and be back here by 5 after 10, we can get almost back on time. And thank you. There is a coffee and snack there in the hallway. This way. Whereabouts are fire yeah, because that was they want to introduce a number of they want to certify the checkout process, and they're going to lay off clerks as a result of doing this. And so labor unions are going to do it. People are concerned with privacy of someone who's in jail that's reading people's books. And with the what you call US paper, be done. But they're trying to put RFIDs in static cars, and DHS wants to read more 25 feet from inside a car. And so I think you're actually going to get more systems. It reads RFIDs and reads paintball guns. And I think there's a great demo of why you don't do this. I think that's really cool. I work on medical with people from medical.
kind of working on something.
Right, but edition 3 is getting very slow. Edition 3 is much more efficient than
Version 3 is a totally different ball.
This man.
And the problem is the cost of the software cost is only about 80%. The 80% of the cost is either hardware or systems
But for our purposes, since we're not doing this for production system, but for demos, you should use it.
Very helpful.
I'm surprised. I'm surprised.
That would be preferable. I'll go on to, we have a pastor on my phone.
Well, welcome back. Let's see what I'm doing here to this. Thank you for coming back from the break. Our next section is a panel discussion about EMR implementation requirements. And what we're going to do is start with an overview from Dan from Vanderbilt. And bios are available on the website, so I want to make sure we have a lot of time for discussion and interaction. I know we had a lot of questions after Justin's session, and so I think we'll have as many with this as well. After Dan, we're going to hear from Karita, who was working at Stanford University now, and prior to that, Helsinki University. And she was very integral to a process at Palo Alto Medical Foundation's web portal for patients. So we're looking at these issues from the consumer side a little bit. And then we'll hear from Tom Rendell from the Center for Healthcare Research. And he's got some viewpoints and some information about Kaiser's implementation. And I think that'll be very interesting because Kaiser, of course, has taken the leap ahead of most of us in the healthcare world in health information exchange and web portals and EHRs. They're the early adopters on the bleeding edge, so to speak. And then we'll have Robbie wrap up with some comments about privacy and security in particular, and then we'll take your questions and so forth after that. So without further ado, let's have Dan get started.
Thank you. And let me begin as a segue to sort of put a face on Justin Graham's excellent discussion to show you the current state of EMRs. We don't actually have to start from scratch. There is not only a 40-year literature on this, but there are a lot of existence proofs that you can actually do this sort of thing in settings of various types. Some of the lessons learned the hard way along the way over the last 30 or 40 years in the implementations of EMRs, and you'll see in there elements that Justin has already referred to. And then lastly, sort of prepare the ground for the next speaker after me to talk about patient portals as, I think, really a new force in the 21st century in electronic medical records. So I come to you from Vanderbilt University Medical Center, one of those big academic institutions, one of only about a dozen in the country that has a full academic department of biomedical informatics. We have 45 faculty members who, make their livings and get their promotion and tenure based on development and testing of these kinds of technologies. You see we have an Air Force associated with this. If you get a ride in one of those, it means you're having a really bad day. This is our web-enabled, secure, developed by the faculty electronic medical record system called Star Panel. It's got the appropriate redactions because it is a live record. It is a Googleized record. That is, any record, you can search on any word contained in any of the documents. It has observations going back now almost 20 years, 1.3 million patients, about 600 gigabytes of data across about 60 million structured observations and an awful lot of text. The important aspect of this, though, is that it isn't simply the recording of things that gives you the payback in electronic medical records. An accompanying faculty-developed application called WizOrder is the clinical decision support system that helps guide clinicians to do the right thing at the right time, and as Clem McDonald, one of the pioneers in the field, refers to, provides guardrails to keep them from doing things that represent a mistake. And so this is an example of an order entry web page that guides providers to do the right thing. It is, however, not the case that you can't buy similar functionality. So this is a snapshot of a slightly older version of the EPIC system that has won a number of major national awards by virtue of its effective implementations in healthcare systems. And it as well it gains its power primarily by sets of decision rules
that alert providers to things that are going on in the environment. The system monitors data flows. It has so-called event monitors that use medical logic modules that look for things that represent trends or can prevent providers from making mistakes by, for example, prescribing a drug for which there's already a known drug allergy. Now, those products, and they're growing in number, are deployed in environments that are quite complex. And there have been a number of lessons learned. But I wanted to give you a sense of what it's like to actually build and try to insert these technologies in healthcare. And for this, I think the best example is actually a little movie that some of you will recognize from a different context.
This man right here is my great-grandfather. He's the first cat herder in our family. Herding cats. Don't let anybody tell you it's easy. Anybody can herd cattle. Holding together 10,000 half-wild short hairs. Well, that's another thing altogether. Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here. If you look at his face, they just ripped to shreds, you know.
You see the movies, you hear the stories. I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost to one of them, ain't a feeling like it in the world.
So any of you who are involved in EMRs will actually recognize that that's about what it's like trying to insert a technology. And the lessons learned are summarized, and I think were highlighted by Justin as it isn't really for a lack of attention or resources that we don't have widespread use of electronic medical records. It is a very difficult problem for both the technical, economic, and sociological reasons that he cited. It is clear, however, that the power is in the data architecture and in the data itself, and not so much in the application. And this is one of the fundamental principles that is often lost by practitioners who are swayed by a pretty screen and like a particular function. But in fact, the power to society and the power of improving the quality of healthcare comes from the data itself. And it's almost always the case that if you take a vendor product, you buy it off the shelf, you contract with somebody, you get about 80% of what you need done. But then what do you do about the other 20% where it doesn't fit? Do you modify your workflow to try and fit the software product? Do you have the software product to try and fit your workflow in your healthcare system? And over 30 years, we have learned that in this time-pressured environment, bad systems people will simply walk away from. And there are some very large investments made by very large healthcare organizations that have nothing to show for it. That is, after many millions of dollars and lots of planning, nothing runs. Not a single line of code is ever implemented. With respect to the question about time, it is a very common presupposition that doctors will say, I won't use that unless it saves me time. But in fact, a growing literature says that users actually do accept trade-offs. And although, as Justin observed, it does take a little more time to use an electronic medical record, the clear payback in the sense of empowerment, that I actually know I'm doing the right thing and I'm a better doctor for doing it, is actually a countervailing force in that regard. It's also the case that we don't have to wait for the Nintendo generation or whatever, the Xbox or whatever, because it's clear that attitudes towards the use of computerized systems are in fact not age dependent. They actually relate much more clearly, and there's a literature on this, to openness to change as a character feature, and that occurs actually throughout people's lifetimes, or it isn't there, but it isn't related to age. As seen by users like doctors and increasingly patients, the major utility appears to be accessibility. If you're a healthcare organization, however, the big payback is in cost and quality, and that almost all of that accrues because of patient-specific clinical decision support, which in turn impinges on workflow and autonomy. So if you went into healthcare because I'm smart, I'm the world's expert, and I want to do what I want to do, these systems actually they collide with your very basis of what you think your scope is as a professional. And Reed Gardner, one of the grand old men of our field, has often quoted, and this number varies perhaps 10 to 20%, but this systems implementation is almost always just a little bit technology, 10 or 15%, and the remainder is the sociology of technology insertions. So let me shift gears then to pave the way for the next speaker with respect to patient portals. They're not an entirely new idea. When I was on the faculty of the University of California, San Diego for a decade, and in the mid-1990s we built a system called Picasso, which was a secure web interface, a wrapper around an electronic medical record system that had a high assurance architecture, all sorts of security implementation details that brought it to the level of a high assurance system back when even having digital certificates was not something you could get on the open market. And it had a Java-based web client to it that is now pretty ordinary, but 11 years ago was a testable hypothesis and an interesting innovation. You've already seen a slide that shows our operational system at Vanderbilt. The My Health at Vandy portal has quite a bit more design elegance to it. And like many of the major portals being provided by major healthcare systems like Kaiser and academic systems, it allows patients to communicate directly with their providers and includes those communications in the electronic medical record as an integrated component of the record of care delivered, which is what's lost when you try to do it with email and these, just a cacophony of unsecure methods of doing it. Allows patients to request prescription refills, request appointments, view their results online, a very interesting new innovation that has a measure of information toxicity associated with it, because it turns like information, like all technologies, has and all interventions, has a therapeutic index. That's a term used by clinicians to talk about the difference between the good effects and the side effects. And so when you give patients lots of information, you get both good effects and you get side effects. And that's an issue that is in play now as more and more patient portals are giving patients direct access to information that previously was reserved only to their providers, allows them to do more mundane things like pay their bills online, and importantly for us, allows, because the system knows who the patient is and what their diagnosis codes are and those things, to create patient-specific educational materials that are linked to just the conditions that they have and not just general advertising, which is the case of probably 98% of the websites of healthcare institutions right now, and allows us to deploy via the web structured data capture instruments that help contribute to the patient's input into their own health records. Now, all of this is actually going to become more important for some big sea changes that are occurring in our environment, typified by this slide and the Human Genome Project, which has yielded the draft sequence of this instruction set for what it is to build one of these things. We still don't, we're pretty far away from knowing that, but it is clear that we are already seeing very high dimensionality, data-intensive impacts in the sense of having single nucleotide polymorphism, SNP markers, that is little unique aspects of your DNA that predict whether you will get a bad reaction to a drug, and incorporating all of that data, numbering in the potentially hundreds of thousands of facts about you, simply transcends what's might call the Oslerian model of medical reasoning, where your doctor looks at you with this very concerned stare and says, I think it's probably measles. And those kinds of clinically based, phenotypically based observations are actually not going to be ever sufficiently predictive and strong in an era where we are seeing convergent evolution, where you have hospital information systems and rules engines, but at the same time are having this growing tidal wave of molecular biology and human genetics that are converging to have a clinical bioinformatics, as we call it in our neck of the woods, where you have personalized healthcare that is increasingly informed by molecular events, not simply the recording of what medicines or what diagnoses were made at a phenotypic level. So with that, I would say that the big questions, as you've heard them actually already intimated this morning, that we can talk about today, and hopefully people can get their arms around, are first of all, how to overcome all those technical and sociological and economic barriers to the interoperable health data systems. And then I think the really big question for the dawn of the 21st century is how to use individuals' interest in their health and their intelligence. You know, we've largely ignored their intelligence, and I think it's time to have, you know, systems that like Google PageRank, they really essentially take advantage of community intelligence with respect to refining our understanding of improved healthcare systems. And that will come via a variety, potentially, of technology initiatives such as personal health records, patient portals, and other interactive systems. And so with that, I hope we're on time and that we're ready for speaker number 2. And I won't take any questions until we all take questions. I have to give you this, or you have to take it.
And the other part is, there we go. Oh. F1. Okay, there we go. All right. So I will give you a few points from a researcher's exploring point of view. I thought a presentation with some graphs and figures will be exciting. Turns out I should have brought video. I will tell you a few points from my research with Palo Alto Medical Foundation and research that I'm now doing with Kaiser Permanente, talking about patient health records, which have obviously, like we've heard today and we'll hear over and over again, received major attention from government, state, private levels. PHRs, however, have not received similar attention yet. Due to the very fact that I will argue today is that you actually need fully integrated EHR to build a PHR. Love the acronyms. There has been a huge upsurge on PHRs. You see them at Vanderbilt, Kaiser, Palo Alto. Blue Shield is working on the payment with them, and they're, I think, going to be everywhere in the next 5 years or so. While EHRs serve the function of the healthcare provider, PHR provide the information for the patient on their care and capture data that they may enter at home, which I think allows them to become more empowered with their care and more informed on what's going on with their care. They definitely motivate people to take better care of themselves and follow what's going on, i.e. a more active role in their health care. Especially, I think this is valuable in chronic patient care, and it's probably one of those patient groups where it's easiest to argue the efficiency of having a PHR system implemented. There is an interesting study that was just recently published by the Mayo Clinic that says 62% of patients didn't know the purpose of their medication, 86% didn't know the side effects of their medication, and 58% of the people leaving the practice did not know what their diagnosis was. These are issues that can only be responded to by EHRs. Having the patient go home, open up the portal, or whatever it is in the future, and just take a look at what exactly was it that the doctor said without having to call back, take the 15 minutes to get a hold of the doctor, and just have all the information on their care available. Physicians, as many of you will probably say today, and we already heard, are feared of being overwhelmed by the messages. They're feared of this taking way too much of their time. And there's lack of evidence
on provider efficiency and the actual business case of PHRs is still missing. So this is I thought this will be very exciting part. So who actually uses PHRs? Messengers are older than we think. From the Palo Alto study and Kaiser study and some of the other articles that are already out there, we can see that these are not the young hypochondriacs who are online all the time and playing all the games available. These are actually middle-aged. In Bay Area, they're predominantly male, believe it or not, which was a surprise. They are patients with chronic illnesses. They usually have a lot more problems on their EHR records than the rest that choose not to do PHRs. They consume a lot more healthcare resources with or without the PHRs. And, surprisingly, they'll start consuming less after adopting the PHR, which is very interesting. This can be seen both at Palo Alto and at Kaiser with large patient cohorts. What's on the top is the kick the tire effect. We're all very excited to try on the new technologies, and we'll take advantage, especially if you have to pay for the service like some of the providers will have us do. You do tend to kick the tire several times and then go down to sending an average of 6 to 8 messages per year, which is not doctors being overwhelmed by patient messages. All of this is here in order to say that building a business case for PHR is really tricky. I did move that up. It's very tricky to gather all the information about these patients without having fully integrated EHRs. So this is kind of call out, please do them quickly so we can do the valuable research and improve the business cases. It's very time consuming because the data is not available. At Kaiser, we had to go through 6 different databases in order to collect just the demographics of these patients. Frustration. Having EHR implemented will also enable more intellectual studies on chronic disease management and how these systems actually affect the patient care. And this is something little besides the point, but I do want to show you this. PHRs have tremendous implications on how patients use the services. This is my analysis of a patient 12 months before and 12 months after PHR implementation, which is the red line. What you can see is that we're moving away from the blue stacks, which are phone calls, to having no phone calls in the entire 12-month period, right? This is an older diabetic male with severe diabetic problems or problems related to his care. He moves away from the gray bars to more specialist visits over on this side. So it changes the way patients get their care. It moves the communication to different channels. It obviously results in a lot of purple ones, which are messages of either lab results, i.e. no more time-consuming phone calls, contacting your physician more frequently. You actually get more frequent care with the PHRs in the best-case scenario, that is. So a lot of effect on the patient care. Mike and I just got a laugh about it. I actually thought I was in the security panel, so we're changing the presentation as we go. So, as I said, messaging intervention stops the growing demand trend on doctor appointments. And with implementing these, there are several challenges. First of all, you have to have the patient information in electronic form. It has to be available for this kind of system. There has to be standards that can have these two systems connect. Authentication becomes a huge problem, especially when integrating with interoperable EHR. And before, I lost my thought, sorry. Designated caregivers must have access to, so proxy is the next thing that we're seeing with the PHR. All that sums up to EHRs must not only exist to have PHRs in place, but they must also be able to communicate with these systems. So what's happening in the future? Ideally, these systems should have as much information as possible from many different caregivers and providers, especially problematic in Europe, where you have a lot of the private and public mix in healthcare. People jump from one provider to another almost on a monthly basis if they're chronics. Becomes very, very challenging. We will see highly customized interfaces. We will probably see pages with specifically information directed to you, and none of that general information. Education and research focus will definitely help to facilitate the adoption. We're trying our best to build up the business case and build more proof on these systems being efficient. We'll probably see automated algorithms as we get more and more use out of the patient's data that they enter at home. We can catch the early warnings of, say, diabetics living at home, taking their own measures. In case there is a third Hurricane Rita striking after Katrina and Rita, these systems will definitely increase patient safety. As we have to move out of the facilities, go wireless, having all this information online is probably what's going to help us tackle the next disaster far better than we did this time. PHR overall will function as seamlessly integrated and interoperable part of the EHR and other health systems in the future. I should hope in the next 5 years. I think we can move on to Thomas. Thank you.
Mac users and PCs. This is an interoperability problem, and so I need help with this. I'm a Mac user. That's it, yeah. Well, I'm going to give you a brief early progress report on a study that I'm involved in with colleagues who I'll present in a moment. And the study is of the implementation of a new electronic medical record in the Kaiser Permanente Northern California region. Kaiser Permanente has a long history, as someone has already mentioned, a long history of involvement with health information technology, and is a national and international leader in this area. And so they have a good deal of experience with both the technology and with implementation. This new implementation is of a system that they call Health Connect, and it is a system that is commercially available from Epic Systems located in Wisconsin. I see Brian Raymond is here from Kaiser, and he knows a good deal about this and has his own expertise in this area, and we may draw on that before we're done today, Brian. And there may be others here as well. Are there any Kaiser physicians here or others? Yeah.
Users.
Users, great.
Even
Kaiser
more
user, even more important, yeah. Here's the research team. You can see a large, complex implementation requires a lot of people to analyze it. And the PI of this project is Dr. John Hsu from the Kaiser Permanente Division of Research, and then there are these people involved from various organizations here at Berkeley and elsewhere. The primary aims of this evaluation are to determine the impact of HIT on quality, safety, and resource use. And we also want to focus on patients with chronic illness, the importance of health information technology for the care of patients with chronic diseases has already been mentioned by several of the speakers today. We agree with that, and so we want to focus on those patients. We believe that if you're going to see beneficial or harmful effects of health information technology, it's probably going to be on patients with chronic illnesses who have complex disorders, require multiple interactions with various providers in different locations, and have the need for multiple medications and other lab tests and other services. And so those are the kinds of patients for whom HIT should be very helpful. And the question is it? And if so, in what ways? So we're going to try and understand the structure of chronic disease care in Kaiser Permanente and apply what's called the chronic care model to our understanding of the services that are provided there. And we certainly want to examine interactions between HIT and the structure of the organization, and in turn the structure's impact on the use of HIT by physicians and other clinicians and caregivers. This is a 3-year-long study, so we have the advantage of being able to look at changes over time, which is a great advance over many studies of the implementation of HIT, which are more or less cross-sectional, looking at what's happened at some point in time after the implementation of the software and hardware. I think I've already addressed some of these issues, as have some of the other speakers. We're filling some holes in the knowledge base by looking at an ambulatory setting rather than an inpatient hospital setting. We're looking at a commercially available system rather than one that has been uniquely created and tailored to a particular system. Then we're looking at a community setting, not a academic medical center, and we're actually going to look at patient outcomes in addition to process measures. And I believe this may be a first. If I'm mistaken, please correct me. Our basic conceptual framework is that health information technology can affect outcomes directly, but, and I'll describe more about what I mean by that in a moment, but also that health information technology will influence the structure and care processes that affect outcomes, and so there's this, might call indirect route to patient outcomes as well, and we want to look at both of those. The integrated delivery system that is being studied, Kaiser, has multiple potential health system agents for chronic diseases, medical centers, primary care teams, the primary care providers, the specialists, the care managers, and many, many other caregivers that make up the provider system for patients with chronic illnesses. There are multiple levels, as I've already described, the medical center. There's the clinic, there's the team, then there's the individual provider. And this all requires coordination. Again, something that typically is improved when we implement health information technology. This figure here simply documents what I've said. These are different levels. We are not studying inpatient care, so we'll just set that aside for the moment. We're really focusing on the outpatient care that's provided in the clinics that are associated with the medical centers within Kaiser. And we are going to be looking into patient self-care as well, which is an important component of the chronic care model. In the interest of time, I think I'm going to move quickly along to a few figures that show our big plan for doing this analysis, and I won't have time to go into these in great detail. We can talk about them in the Q&A later, perhaps. We believe that HIT implementation is going to influence the way in which the office visit is used and the substitutes for that, and that in turn is going to have an impact on the point of care as well as the system integration. Those will have an impact on drug use, lab monitoring, and office monitoring of blood pressure, for example, as a direct effect. And then there are some intermediate outcomes that we're going to be looking at, such as drug adherence, the lab results, and the awareness of levels and changes in lab levels, and, for example, blood pressure control. And then we want to look at resource use, such as emergency department visits, hospitalizations, repeat office visits. And we are not measuring patient self-care in this particular study directly, but that remains on our list of things to get to. If there are any funders in the room, please take note. Just briefly, the point of care practices will be influenced by simply the ease of access to information. You're sitting there at the single screen. You can look at labs, you can look at medications, you can look at the patient record, patient history, physician notes. Just the information is easily available, and you don't have to look through a paper chart. Or even in Kaiser's case, if you have access to an existing HIT system, it's probably not very well integrated, and you would have to close screens, open screens, go to different applications, and it's not as good. And there is decision support built in, automated, and integrated into the patient's record. Then the system integration issues have to do with performance feedback, being able to easily provide physicians individually and as teams information about how they are treating patients and the effectiveness of those treatments over time. Care coordination, making sure that information, orders, and other information is in fact shared among those who are caring for the patient, and being able to strengthen the team-based aspect of care. And then there's a certain amount of care redesign that we think will be stimulated by the implementation of health information technology, especially, for example, the use of teams to care for patients with chronic illness. There are, I think I'm listing 4 aims for you here. Very briefly, the first one is just to look at the baseline data that we collect before the implementation. We've just finished that, and I'm going to give you just a sliver of data from the baseline survey data we've collected in just a moment. But we believe that there will be substantial baseline variation in the structure and organization of care, even in Kaiser Permanente, which has this history of HIT implementation. If we see variation in Kaiser, we know we're going to see it everywhere else, basically. Aim 2 is to examine the impact of HIT use on quality and safety. We have a number of constructs here, the quality processes, specific safety processes, and quality outcomes. And we've got our specific hypotheses listed here as examples for you, and some examples of the specific measures. I'm particularly excited about this bottom right-hand corner. As I said before, it's very unusual to see an evaluation of a information technology implementation actually examine whether or not that implementation has affected patient health status. We look at structures, we look at care processes, we look at satisfaction, we look at levels of use. And the reason that this isn't very often done is that it's extremely hard to do. Simply matching patients to physicians, to teams, at the time in which you can document whether or not the information technology has been implemented is a Herculean task. And we have many, many people working on that. And it's becoming apparent to us why it hasn't been done before. Aim 3 is HIT use and resource use. We're going to look at outpatient visits, for example, and downstream visits to emergency departments and hospitalization rates as well. And aim 4 is the effect of HIT use on the structure of chronic care management. I keep coming back to that. It can't get lost in all of this. If we don't do a better job of treating patients with chronic illness in this country, everything's going to come unraveled in the next 10 years, because we're all struggling with that financially and in terms of processes and resources. So we're going to be looking at things like the extent to which performance feedback reports for chronic disease patients are provided and used by physicians, and the availability of information between providers and care sites. That's that interoperability word again. And, for example, we'll be looking at the use of patient self-management plans and many other things. This is a very brief list. I've indicated to you it's a 3-year study. It's a longitudinal design. For those of you who are research methods wonks, quasi-experimental in nature, using a pre-post test analytic design with concurrent controls. That's my exciting slide. We have the first baseline data that has been collected through telephone interviews and surveys, examining these domains: organizational support, decision support, self-management, HIT support, and the delivery system design and care management practices. This survey was done on primary care team members, physicians, nurse practitioners, care managers, pharmacists, etc. About 1,100 of these clinicians and patient care support staff were surveyed, and we got about a 60% response rate, which in my experience is very good for this type of survey. We think we can bump it to 70% in wave 2. I think what I'm going to do now is, because I think I'm using up too much time, is to simply remind you that we're going to be going back into the field to collect 2 more waves of data, one approximately a year from now, and the third and final one a year from that. And that will give us the opportunity to do some time series and more complicated analyses to really establish whether or not the implementation of the technology at time 1 had some impact on our process and outcome measures at time 2 and 3. But for today, hot off the press, here are some preliminary baseline data on physicians' use of HIT in Kaiser Permanente. And I've got, I think, 5 tables here for you. And what we did was to ask the clinicians for what percentage of visits did they use HIT tools for a number of different kinds of activities. And we thought they could reliably estimate whether they did it for none of their patients or these percentage levels. Probably they can estimate reliably within 20% whether or not they use HIT for patient visits in these types of activities. So, for example, 88% of the physicians said that they viewed lab results with the existing HIT system. This is the old system that isn't very well integrated and is a little archaic and slow, and that 88% used it for viewing lab results for 81 to 100% of their patients. That's the way to read these tables. I think that's pretty good for an integrated healthcare system of any sort, and much better than you would see in a non-integrated healthcare system. But there's still some room for movement is kind of the message there. What about entering lab orders? Well, you can see 25% said that they did for that top category. And for using disease-specific lab order sets, well, it drops way off down to 17.5%. You see the majority say for none. So we've got a lot of improvement that we can hope for as a result of the implementation and the training that the clinicians receive with respect to Health Connect. A few other activities, prescription drugs. Everybody is now understanding that this is a problem area for all health systems. What about viewing the current medications list in order to treat patients with chronic illness? Well, you need to know what drugs they're taking before you make any prescriptions for them. And you can see a very small percentage claim that they use HIT for this 81 to 100% of their visits, but a very large percentage for 61 to 80%. And looking down here, viewing the current drug allergies, here they do better overall. Entering new drug orders, also they do well, I would say, overall. But again, ordering disease-specific drug sets, these are sets of drug orders that are complementary and supportive of one another. They don't do very well. Table 3, what percentage of visits use HIT tools for messaging and consultation? Here we're getting to this, excuse me, this issue of coordinating with other providers, the specialists and the care managers, nurses, and other primary care providers that might be involved in caring for patients with chronic illness. A lot of room for improvement here, and we hope to see that. Sending messages to patients that Karita was talking about. We see that there's a lot of room for improvement here. Most of the distribution is down in this none to up to 20% category. And then requesting referrals. We see 65% say that they do that for 60 to 80% of their patients. Room for improvement in the use of this to achieve efficiencies, to make sure that the referral is accurately understood, and so forth. Table 4, what percentage of visits do they use the computer to document and chart patient notes, for example, is a tricky thing with HIT. It's come up a couple of times because it can be time-consuming to do that, and you need a system that makes it easy and transparent. In many cases, physicians would really like to be able to do this orally, so voice recognition software is coming into play here. And you can see that we need to do much better with respect to documentation and charting than is currently the case. and then using standard note templates is fairly unusual at the present time, although that will improve. Those standard note templates makes it much easier for someone to review the chart or for analyses to be done on the content within the chart. And I think this is my last one. Patient education, using educational materials on the internet. Well, it's actually higher than I expected to see, but still we have a long way to go here in terms of the kinds of things Carita was talking about in interacting with patients, reducing the demand on the inpatient visit capacity by using educational materials and interacting through the internet with patients. Oh, I did have one more. Population care management, using the population care registry to understand the health characteristics of the population from which your patient comes, which might be informative for you in terms of understanding the care that you might want to recommend for that patient. We've got a long way to go in terms of using that. And of course, that's important for public health purposes as well during crises of any sort, epidemics or natural disasters, for example. And I think that's it. In summary, I simply want to observe that there is a substantial variation at baseline in Kaiser among physicians in their use of HIT tools to manage the care of patients. Further data analysis will examine whether the introduction of Health Connect reduces this variation and increases the use of these tools. And we're also going to examine whether Health Connect influences the adoption of the chronic care model and improves care and outcomes of care for patients with chronic diseases. And I hope we have this conference in a year and I can come back and tell you more about the second and third bullets. Thank you very much for your attention.
My name is Ravi Namana, and I should probably start by talking about where my allegiances lie. Some of you know me from the Health Technology Center, and I've made the move here to Berkeley, although I still have an appointment at the Health Technology Center as senior advisor. I'm part of a program that has been started by CITRIS, and I'm the executive director of what's called the Services Science Management and Engineering program. This is a new science that's starting looking at the configurations of people, technology, and business processes and what it takes to make change possible and to accelerate change. It's not the standard innovation alone. It's an innovation combined with technologists, industrial engineers, social scientists, everyone who's interested in moving these sorts of things forward in service industries. And we, of course, have a very strong interest in healthcare, which is, of course, my interest as well. What I'm going to talk to you about today is this dichotomy between security and productivity and what hospitals, I'm going to specifically focus on hospitals, although the same problems that Justin spoke about, you'll see the parallels here, in EMR implementation. In other words, how does the security-productivity dichotomy play out in EMR implementation? And I'll end with some of the interesting lessons that came out of the Hurricane Katrina and Rita and Wilma episodes in our recent history. So I'll quickly go through this section of why we put it in EMR, because this actually has plenty of relevance for how security plays out. One of the biggest issues, of course, is trying to drive new productivity and efficiency, and because of this productivity and efficiency, you're interested in coordinations of care, the reduction in hunting and gathering that happens with information in clinical settings. You want broad access to the chart by oftentimes more than one person at the same time, and there's some standardized presentation of information that's already been addressed in today's presentations to reduce the redundancy in data that's entered and data that's available. And what these do is they allow you to get some other benefits, most notably cost reductions, sometimes enhancements in revenue, and improvements in the quality of care. So in terms of cost, there's some direct costs that can be reduced from this. Sometimes you can reduce your transcription costs. Oftentimes it's somewhere around 11 cents per line of transcription cost. And if you can farm out the production of the electronic record, you can actually reduce that cost substantially. You can reduce labor costs because of the reduction in hunting and gathering, although there's some evidence that this could be shifted toward IT personnel to make it happen in the short run. You reduce your internal and external copying expenses, of course, in medical records. Or malpractice insurance costs that may be reduced because of better evidence-based care, and certainly pharmacy costs. And this is sort of the broader issue of pharmacy for medication management and inventory control, narcotics control, those sorts of things. In terms of revenue enhancement, there are significant gains that result from billing accuracy. Or coding accuracy, if you will. And this is directly impactful for productivity. And then finally, there are the quality of care issues that have already been spoken about, so I won't dwell on these. But really the big one that's interesting nowadays is this issue of improved care coordination that can affect people both internally and externally if you're participating in regional health organizations. So the idea is that if you have this body of knowledge internally, you can open it up to the outside world and coordinate care and hopefully reduce some of the redundancies and gain administrative efficiencies. Some basic information here. The New England Healthcare EDI Network was set up as essentially the first RIO. They've been able to reduce the process of eligibility and authorization from roughly a 6-hour process to something that takes about 15 seconds. And it's a pretty significant improvement in administrative efficiency. And they're now working on clinical issues, as are other people around the country, and I think there's a tremendous amount to be gained there. So if all this is happening, what's the role of, why is it so difficult? And I'm going to focus mostly on security problems. And the real issue here is that there are many sources and sinks of data. And every time you put in an EMR, you essentially are tying together these vast bodies of information into a conclusive whole, and that leads to integration, interfaces, and really a big security mess. Skip down to the, may I borrow your pointer, Tom? I'm a little short, so I can't reach up that high. If you skip down to this statistic here, the average 300-bed community hospital has roughly 200 plus systems, and academic centers have a lot more, as David Harry will attest to, who was in charge of Davis. And about 20 of these can be termed life critical. In other words, if those systems don't work well, patient care can suffer. And some will argue it's probably a little bit more or a little bit less, but roughly, if you'll allow me some latitude, it's about 20. There are many versions of these systems. There are many patches, operating systems, and data formats that will need to be tied together. And there is an intellectual property tension here. The organizations that produce these systems need to recoup a profit, and they like to maintain a proprietary hold. Although many of them are moving toward standards-based systems that in effect commoditizes their product, and they think lately the competitive ground is on user interface, ease of use, and applicability to a wider variety of data sets. So this tension, intellectual property versus seamless operation, is really the problem. You have a body of information that has a proprietary boundary around it, but it needs to integrate and be, in order to be able to give you the full data set you need. So if you're in the ICU, you need to get access to the medication that might be in the pharmacy system. But to get both of those things interoperable in the same system, in the same particular screen, may be a daunting problem. And the second component of this, of course, is to preserve the clinical productivity. This is paramount. No clinician will use a system, and they'll tell you this, if their productivity is impacted for the long term. They may be willing to make their short-term investments, but they want to make sure that there's a gain there. And this plays out in security in a number of different ways. The survivability of the systems through malware, spam, and a whole bunch of other problems is a big issue. One notable hospital in Massachusetts put the figure at $750,000 for 1 week of malware remediation in one department. In one department. So malware basically took out the respiratory therapy system. All the bills were lost, and they were able to recover many of them after a while. And even after all that remediation, it was $750,000. And that didn't include the people's time that was spent on trying to recover. So this is a substantial problem. There are poor audit trailing and tools to integrate security across all systems. Many people log in many times into many systems. And it's a big HR problem. Somebody new, a new per diem nurse comes onto your unit, they may need access to 7 systems. It takes probably 2 to 3 days for one individual to get them access to all those systems. And so people try to automate, and again, the automation tools are not particularly helpful, and this sometimes leads to propagation of error. The final issue is the cultural impact on the chain of trust. So, of course, what this means is that workflow is key in any clinical environment. No one wants to spend their time logging in, logging out, hunting and gathering for the information. And the security models that have been put in place today, the most advanced ones in clinical settings, have been role-based access. I am a physician or I am a nurse, I have access to certain things. But depending on the disease, depending on the patient, I may need access to other things, and giving that delegation is cumbersome. People simply don't have time for that in clinical settings. So giving and revoking rights takes too much time and too much effort. And there actually have been some advances in computer science that need to trickle down to have more adaptive workflow or more adaptive revoking and assignments of rights that are more disease-specific and more patient-specific. And finally, there are organizational issues and HR incentives that simply don't support security. Following good security practices is difficult in non-clinical environments and in a chaotic clinical environment. As you'll see in the next slide when I talk about some lessons learned from the hurricanes, it becomes really difficult. Single sign-on and automated context-sensitive security is not perfect. The idea here is that if I walk up to a machine and I am a particular physician and on that floor are certain patients, that information will be shown to me simply by walking up without having me log on. I would authenticate against the tag would then authenticate against the machine and give me the information I need. They're not perfect, but they're pretty close and they're headed in the right direction. Again, these cost a lot, so they probably won't happen in outpatient settings. They'll happen in inpatient settings first. And they'll probably happen with web services first, because those are the ones that are most amenable to this sort of thing. And essentially, people will use web services to wrap around the more legacy systems to provide that functionality to people. So I mentioned this is a difficult path to EMR. The patients are quite interesting. They largely trust the healthcare system. And they assume and expect that security is, in fact, being delivered to them, and the privacy, confidentiality, and continuity are maintained, although this trust has been eroded in the last few years because of some notable breaches by both healthcare and non-healthcare firms. In healthcare, there was a major academic institution that had some problems with offshore transcription where they were posted on the internet, and there were other breaches around the country. There's a tremendous problem in data here because a lot of people don't like to report it. It opens them up to litigation. And of course, patients have demonstrated they will sue if their rights are violated. And these same issues are facing RIOs and personal health record initiatives. Really, the issues between selective disclosure, disclosing information to people who actually need it, incidental disclosure, in other words, avoiding disclosure to people who don't need it, and break the glass disclosure, or disclosing information to people who absolutely must need it but don't have rights to it at that time. And there are, again, some computer science, hopefully we'll hear about them this afternoon, some efforts to look at selective incidental disclosures in one architecture, and those will hopefully help the process for electronic medical record systems. There's one wild card here in the security area for healthcare and electronic records, and that is what's going to happen as biomedical devices and IT are converging. I was going to say start converging, but they are converging. Any new biomedical device that comes out today is digital, and it has a computing platform in it. And many of these things, like smart infusion pumps, have wireless devices, wireless connectivity built into them. And no one knows really how they'll be treated in terms of security. There are no host-based security on there. In other words, there's no spyware or antivirus built into these devices, and they're open to worm attacks. And many hospitals that are early adopters of these are simply turning them off, even though they offer a significant productivity gain. For example, an infusion pump can be programmed by the pharmacy to avoid the transcription error that a nurse has to do to program the drip rate on a pump, right? Tremendous value. You simply pick your drug. It gives you known rates and drip rates. You already know in your electronic medical record system how much the patient weighs, what their body surface area is, and what their mass is. You can figure out their dosages, you can figure out the drip rate, you can program the pump remotely without any intervention, and the nurse simply can go about his or her task of managing the patient's care and monitoring the pump. But if this opens it up to a whole new world of malware and problems that result from the general computing world, what hope do you have then of making sure that that rate can't be modified, altered, or just blocked? And there are some hopes. Certainly the VA, the Veterans Administration, has put out some information on risk profiling, and that generally works. But risk profiles have this tendency to grow over time. They don't shrink. You get many, many profiles over time. So will it scale? And that is an issue. Now, finally, I'll end with the lessons from the hurricanes. One of the things they discovered is that biometrics actually fail when put under stress. And what happens is that, and this is a little on the gory side, but blood and body fluids get in the way of fingerprints. They foul the readers. Oftentimes you realize that you have this surge capacity, meaning that you get this massive influx of patients because of a natural disaster, and you change the settings in which you start using your hospital care. You move to the parking lot. Well, there are no computers in the parking lot, so the information infrastructure needs to move to the parking lot, and so does the security infrastructure. You get help from other countries, or you get help from other cities and other medical personnel who are not part of your security paradigm. They're not in your HR database to give them access. So what happens? Right? These are very large problems. And things like voice recognition, after a while of working an 18-hour shift, you get a hoarse voice. Voice recognition fails. And of course, we talked about this problem of new personnel that simply aren't in there. And then finally, there are new applications of continuity and survivable systems where, given a flood, the system will in fact adapt. But there are some things from which you simply cannot survive, like an overwhelming flood that is 18 feet deep. And so what can you do? And there again are some computer science answers to continuity and achieving the mission of the information system. And some of these simply are knowing that there is a problem, they archive the materials. Sometimes this has simply to do with the placement of where IT is. Oftentimes it's in the basement. And now people are thinking about moving IT to much higher levels and putting generators on the top floors. There's actually a big field of facility redesign that deals with security of electronic records that also follows this. So my whole point here is to show you that that electronic implementation, electronic record implementation has a much larger context, and security is a big component of it. And with that, I think we can take questions or...
Thank you, Ravi, for that sort of conclusion to all. Let me start with questions from the audience. Do we have some questions? Justin?
I have a question for Tom. Thanks for everyone had great presentations. I have a question about the really impressive experimental design that you guys put together for the massive rollout just in California, Health Connect and Kaiser. Two questions. One is one methodological problem that plagued many of these pre-post quasi-experimental designs of looking at electronic medical record rollouts. The two issues are, one is how do you account for secular trends where people are improving anyway and would have improved over time with or without electronic medical records? And secondly, the bias that's introduced by the post study where you have much better access to data because you, of course, now have an electronic medical record and you have much better data collection than you had pre, which obviously introduces biases into the data.
I'd add
and then the second question, and then I'll be quiet, is have you thought about any adjustments to your study parameters, your outcome, in light of the recent article that was in Pediatrics about increased mortality associated, not attributable, associated with CPOE implementation? I know you're not looking at inpatient studies, but are you thinking about looking at mortality?
Well, let's talk about the last question first. For those of you who don't know, in pediatrics, about 5 months ago or so, there were there was an article published that reported an evaluation of the implementation of a computerized physician order entry system at Children's Hospital in Pittsburgh, and the investigators found, surprisingly, that mortality for patients who had serious illnesses, children who had serious illnesses, increased from something like 2.6 to 5.2% post-implementation. That has been a very controversial report, as I'm sure you know, and in the subsequent issues of Pediatrics, which now has an online sort of open community of practice post-publication peer review site, there were a number of critiques of the study by both researchers and clinicians, and it turns out that the CPOE was implemented during only a 1-week period in the hospital, and that users of the system were given at most 3 hours of training in the use of the system. And thirdly, there was simultaneously an independent second study going on of this CPOE implementation at the hospital by other investigators that looked at drug order errors and other possible effects of CPOE in the hospital, and found that in fact those kinds of measures demonstrated that the implementation of the CPOE was very beneficial and had reduced adverse drug events among children in the hospital. So I think that picture is very muddy at the moment. I don't draw many conclusions from that study, and it has not significantly influenced our design or our view of CPOE at the moment. But it certainly is a yellow light, if not a red light, and we need to start paying even more attention, I think, to potential adverse effects of these interventions. Let me pause there. Is that responsive, or do you have something to add to that?
That was the. I wanted to see if we're looking at mortality.
Yeah. Now, on the first set of questions, I would even add another complicating factor to deal with in our design, which is that Kaiser is a very large system that has a strong commitment to quality improvement, and independent of Health Connect, they're frequently rolling out new programs or efforts to try and improve quality. And so we have not only the possibility of a secular trend, but we have additional programs and interventions being implemented over this 3-year time period to somehow adjust for. And we are keeping track of those. We're keeping a log, and we will be factoring those into our analyses, both visually with graphs showing when various interventions took place and might have influenced trend lines that we will be producing, but also in our multivariate analyses using dummy variables and other techniques for adjusting for the implementation of those kinds of other interventions. Secular trend. Well, we have substantial before and after data, and it's a staggered start design. So we will be able to look at the trend prior to the intervention and the trend lines afterward to see if there appears to be a secular trend occurring. And so I think we've got a handle on that one. But the issue of the post-intervention improvement and measurement is tricky. By and large, the physiological measures are as good before the intervention as afterward. They're just harder to get, and so we just throw more resources into getting them. So I'm not sure that that's a significant problem, but now that you've alerted me to it, I need to go back and worry about it with John and others a little bit. Was there another point there? That's it, yeah. But thank you for the suggestions, yeah.
The Pittsburgh article also got a lot of Monday morning quarterbacking, but it was clear that it highlighted a sort of dichotomy of technology insertions that places like Kaiser and Vanderbilt and Regan Streif have known for 25 years, and that is that organizational change management is the major component of preparation for technology insertions. And if you try to slam these things into workflows, you'll get Simpson effects. such as, for example, in these infants who were critically ill were transferred to an ICU setting where previously the drugs were in a cart and someone could go over and get the medicine immediately. The new system moved the medicines to the pharmacy, could only be released if the patient had been registered. You couldn't even enter an order unless the patient had been registered, but many of them came in red lights and sirens, and there was no ability to register them, so no orders could be entered. And so it was the sort of thing that it was not subtle. There were multiple sources of workflow-induced error that even a reasonable consultant who'd ever done one of these could have said, don't start there, you're going to get into trouble. So it is the case, though, that unfortunately in our arena, we have a media that is so hungry for stories, counter-intuitive and counter-culture stories about how technology is bad and it's killing people, because it just makes such juicy controversy in the press. So one of the risks of any institution of any size doing this is to having the message lost by its sensationalization, as opposed to looking at it, the way that in the background, although airline crashes get sensationalized, the infrastructure for looking at methodologically what's the source of the error and let's just correct it the next time so the whole industry doesn't make that mistake again, does not yet exist in healthcare.
Yeah, Laura. I have a question for Dan again. I was interested in your stat that EMR implementation is 10% technology and 90% sociology. And you read the same old statements about, get people involved, get an opinion leader, da-da-da. Well, those are really vague, especially when these people are on the line producing services. What are the critical points of intervention in terms of physicians, nurses, in terms of different points of design and selection?
So it is the case that healthcare organizations might be good at healthcare, but they're often amateurish at other things they do, such as change management. And there are lots of PowerPoint slides out there about getting ownership of users and all that kind of stuff. But it turns out that the organizations that are quite good at this have made a science of change management and technology insertion. As you might imagine, it's to develop measurable goals that affect important outcomes, and make sure that you have surrogates, you have biomarkers in a sense, for whether those processes are heading in the correct direction or whether you're getting an opposite effect. And so creating a very detailed implementation plan that has measurable attributes so you'll know how you're doing as you go is the scientific and much more methodologically rigorous approach to doing these sorts of things. And you see it in the mature organizations. You don't see it in the ones that are where too much of this is invested in one or two people who are expected to do all of this. So I think one of the messages about EMR implementations that we heard in this morning's keynote is that there is this critical mass that's needed of people and specialties and providers and people involved and resources. And if you're below that threshold, there really isn't a very good pathway for organizations and single providers who lack that critical mass of the needed disciplines in order to have a high certainty that the money invested will get the return on investment expected.
Question in the back.
We talked a little bit in the earlier part of the panel about patient portals, and I'm going to just ask a general question and I'll clarify why I'm asking it. Do you have any expectation that the patient portals discussed, either the Vanderbilt homegrown or the Epic commercial, will become true personal health records? Now, why do I say that? Because I'm a Kaiser patient. The San Rafael instance is not yet done, but when it is, I presumably will have a view of my Kaiser information. If I happen to, slip on the corridors at Stanford, which is putting an Epic, or the Palo Alto Clinic, which has it, and get data down there, I would have two patient portals. I wouldn't have a personal health record. In other words, I'd have two views of two separate systems. What we've really done so far is we've invited the patient into the silo. We haven't created a personal health record. So do you have any expectation that that's going to happen?
Well, so the answer is yes, and it's actually the union of two ideas you heard this morning. One is the patient portal, and the other is the Rio. And interestingly, RIOs have in their early instances have had a very provider-centric view. You know, it's how can we get the doctors talking to the doctors and pooling this data for purposes of, say, doing benchmarking and such. But the natural place to put the portal is actually at the RIO. Even now it is the case, however, and an early observation we made that was quite unexpected about the Picasso experiment back in the 90s is that patients were taking they had their digital certificates on a floppy disk in those days, and they were actually taking their floppy disk to their competing provider across the street and giving the keys to their electronic medical record over the internet. And so this, the fact that we have web-enabled technologies now gives us a kind of pseudo level of integration in the sense that the patient can actually give the keys to any provider of the access to their portal view of their own records. This is obviously a kludge. It's a workaround for the much more useful solution of having the records be a personal good that is in a neutral third-party repository, but that really has an awful lot of sort of economic and social barriers of mistrust between competing health systems and all that sort of thing. And I think it calls the major question of the 21st century compared to the 20th. And that is healthcare for doctors or is it for patients? Because if you develop systems for patients from scratch, from a clean sheet of paper report, they would clearly be electronic medical records that somehow were out there in a neutral repository. But we have this legacy of 5,000 years of healthcare, which was pretty much put the advantage on the provider side.
I can add to that from the Calrio perspective. We have initiatives which I briefly showed you looking at the personal health record, and very quickly we're discovering that the value of the personal health record, and I know you know this, it comes not from what the patient itself can enter in, but also what we can integrate from other facilities, providers, and so forth. And that's not just hospitals or large medical groups, but it's the chiropractics, it's the personal care providers, it's the folks that you don't even think of, the pharmacies and so forth, that make up the true healthcare delivery for the patient. And so it's going to be very interesting to see where we currently have around 60 to 70 different personal health record vendors, ranging from Bob's personal health record supplier to very good quality systems. Which ones are going to have the features that really create the success for the personal health record for the patient, not for the provider?
My quick comment to your question, Tom, is that from the technological standpoint, portals will soon probably be an anachronism. I mean, the issue is that they're going away, and if you sort of look at what Google and Yahoo and some of the websites have done, they've been able to take a portal and individualize it, where you can take RSS feeds or whatever feeds that are coming from various sources and webify a data source. So if you have 2 providers or 5 providers, you can simply take those sources technologically today. The political will isn't there to do it yet, but you could take them and build your own health record page where your full record will be represented. The issue of the portal is today largely to track activity. Who's using it? Where is it? And if you were to open up that portal, you wouldn't have this problem. But the political will to open up the portal so that you can be a commodity and compete against someone else in the same way is still not there.
My own technical background is more so-called semiconductor kind of area, not in this area. But in that area, we have a kind of roadmap, not only 5 years or, but much longer, maybe 10 years, 20 years. It provides quite success, sometimes risky. But my question is, in this, we have very distinguished speakers in this room. So my question is, do we have that kind of roadmap in these specific topics so that we can share your view or our view as a part of that roadmap?
Actually, we'll be answering that question with the next speaker. Which is the problem at the table. Yeah, but I think that that's a very good point. In many of the other industries outside of healthcare, there are roadmaps, there are standards. In banking, it took a while, but that's what ended up developing. Yesterday, I was in Washington talking to the Health Authority of Washington, who's looking at that issue for their state. and we were talking about how is it that we ended up with interstate highways where there's a literal road map. Why can't it be that easy? And as it turns out, that wasn't all that easy to begin with to develop. So I think there is a roadmap. It has been led at the national level. It is being propagated at the state level, and that's really why, at least I believe, I won't speak on behalf of the panelists, but I think this time where we're headed in interoperability, we may see it become a little bit more successful than past attempts, because we are working towards the roadmap. And as Justin said earlier in answer to one of the questions from certification standpoint, how can we certify vendors when there aren't complete standards and a complete roadmap in place? It's what we have to do to get there. So we're working towards it, but we will hear from our next speaker on that a little bit more than I can. Robbie or others on the panel, did you want to touch that one?
The interesting thing about roadmaps is that they need to be adopted by a wider body. There are people who actually are working on roadmaps. Institute for the Future has put them out. The Health Technology Center has. I think IFTF has about a 15-year time frame. But they're not widely adopted, and they're not micro enough to be actionable. I've seen the semiconductor roadmaps. They're very detailed, and they have roadmaps that come from those roadmaps. And I think what we have today is sort of the beginnings of a roadmap, and largely the work that David has done has set the tone to do it. And the docket work is taken to sort of the physician level and pushed it there. But your point is very well taken.
Yeah, on the macro level, the National Institute of Health has a broad roadmap on which smaller institutes can pattern their mini roadmaps.
If I could return momentarily to the question of personal health records, there's a current blind spot in all health records that has substantial societal impact, and that is it's known that about 2/3 of people are taking nutritional supplements and specialized things. In the Bay Area, it might be higher than that. And almost no electronic health records actually record that or do drug-drug interaction checking on that. So actually at Vanderbilt, as part of our what used to be called complementary and alternative medicine, now called integrative medicine, is to actually enhance our portal with the ability of patients to enter the things they're buying at GNC and the other kinds of things that may be bioactive and interacting with their drugs, and be able to do drug-drug interaction checking on that. There are surveys that have shown that the reason that those elements are not in electronic, or not in any form of health record, either written or electronic, is not because the patients are unwilling to tell their doctors about what they do. It's just nobody ever asks them. And so it never makes its way in there. So I think that would be a qualitative improvement and would bring some thematic unity and value added in personal health records. In fact, we have a video that we've shot at Vanderbilt where someone uses their cell phone to scan the UPC barcode of whatever this is, and the web portal tells them whether they should buy that or not, because it might interact with some medicine they're already taking. Now that's futuristic hyperbole at this point, but in fact the technology, actually all the pieces exist to actually do that now.
Yes, you can.
I'd like to, if we step back and just look at how to make the integrated health information a reality. And what do you think was the top three obstacles in making it a reality? Is it
all the hard questions.
Okay, this is deep too much.
So your question is, what are the top three barriers for health
Right.
information?
Well, the cost is one, and I'll tell you briefly a little story about California when a health plan offered to subsidize the implementation of health information technology in private physicians' offices because they knew it was good for them and good for the patients and ultimately would be good for the physicians. And they offered a certain amount for a subsidy, and the physicians basically said no thanks, and they offered more, and the physicians again said no thanks, and this went on for a while. And finally, the CEO of the company figured out that for physicians, 0 is too much. And that's because of some of the problems that have been identified by the speakers today. It's disruptive to the practice. In the short run, you're likely to lose productivity. And there is some anxiety and fear about this technology among people who are not computer literate. And so you need to find some way not only to overcome the monetary cost, but to even go further and provide incentives that go beyond simply compensating them for the hardware and software costs that they will incur. And that's why we need pay for performance, and why that turns out to be successful. In the other studies that I've done separate from Kaiser on physician organizations throughout the United States, and that others have done as well, the single factor that repeatedly appears as important and most important is the presence of external incentives in the physician's environment that rewards them for going in this direction. In addition to the cost is the problem of training and the implementation hassle, and making sure that that is done well so that the early experience of the users with the system is positive and rewards them and their patients for adopting health information technology. And I think there's kind of a cultural barrier that has been alluded to several times, that somehow you've got to get people past the, this is the way we've always done it, this is the way that works for me, and I'm the physician and I know what's best and I'm not going to change. And you really got to work on attitudes, beliefs, and cultural values.
And I have a following question. You mentioned about funding and the cost. And we know this EMR or something is good to save life and save cost. Is there any study done on to quantify the Medicaid, or so you can convince all the provider and the payers to participate in? Is there any study have been done before?
There's been a number of studies, and I can answer from the Calrio perspective. The challenge, and I think Dan mentioned it earlier, and some other speakers did as well. The benefit, of course, to the patient, to society, for lives saved, for quality of care, for safety, and so forth, is something that's immeasurable. The challenge is when you do a business case analysis around an actual implementation, and you say, for this entity to spend X amount of money, where is their financial return? That breaks down in the business case analysis. It takes a long time to get the return unless the entire system that's supporting care for that community is involved, and eventually you see the returns coming back to that system. There's no hard data. It's hard to convince. So for the most part, at least in California, the communities are doing this for goodwill and for the hope that they will be able to prove through studies like the ones that Tom's beginning to conduct and others have, that there is an actual financial return at the end of the day, much beyond the value that we all know is there for the patient.
Well, it's a great question. Have we demonstrated the benefits of all this for physicians, for patients, or payers? And it's a complicated answer, and I don't know if I'm going to be able to do justice to it here. There is a substantial literature on it, and it's not as overwhelming a case as we would like. The most frequently studied types of health information technology are CPOE, computer physician order entry systems, and the decision support systems that accompany those frequently. And there is a solid case to be made there that there are reductions in errors and improvements in the processes of care when those types of health information technology are implemented. But you can add to that particular capability many others that are part of standard electronic medical record and health systems now. And have we demonstrated the cost effectiveness of every one of those? I think the answer is no. And to some extent, we're flying on some reason and rational thinking here more than we are on an evidence base.
I'm going to because we have our next speaker here, and we definitely want to hear from him.
And I also want to give a break to our panelists who've been up here for the last hour. You can join me in thanking our panelists for their presentation. I'll excuse you, you can go back and sit in your normal places instead of on display. Our next speaker almost needs no introduction, but I'm going to provide one that goes beyond the one that I explained to my daughter, who is the same age as Dr. Brailer's child. And that is, well, for her, he is the man that the president hired to make my job easier, or miserable, I'm not sure which. Dr. Brailer comes to us as having just recently left the position of the Office of National Coordinator, where he was the first appointed director by President Bush. And prior to that, he was the chairman and CEO of Chair Science. So his background in this whole area of health information exchange, his leadership in it has been phenomenal. He's combined his experience or his work in education with an MD from West Virginia University and a PhD from Wharton Business School. So we've got a very good background from an educational perspective in talking to you, and hopefully he's not afraid of the blue and gold of Cal Berkeley. It's Justin, who dressed to blend in, did. So with that, I'd like to maximize our time with Dr. Brailer and turn the floor over to you, David.
Great. Thanks, Laura. Thanks. It's good to be with you all. It's good to be with really smart people. It's one of the reasons I wanted to come out and be with you. Just maybe in contrast, I spent the entire day on the Senate floor yesterday. I'm still having this kind of out-of-body experience, trying to get re-equilibrated with you all. And I actually brought you some homework assignments. Some of you who I've worked with in the past know that nobody leaves the room with me without getting a homework assignment. I learned that when I taught at the Wharton School. That it's a great way to keep the students from coming to see me very often. And it seems to work in the private sector too, and in government. But I guess just one comment. I actually am still in my job. I resigned, but it's kind of like working for the mafia when you work for the Bush administration. You rarely go out standing up, and so I've got quite a tail to work off. In fact, when I was visiting members of the House yesterday, they had reminded me that I'd made a promise that if they moved the health IT bill, I would stay to see it through and to be there when the president signs it. And I think now, despite me, they're determined to move a health IT bill. And so we're still negotiating all that. Actually, I'm going to stay just whenever I do finish the job to be vice chair of our coordinating body. That's a public-private coordinating body. And also, I've been spending a large share of my time on an initiative that actually takes health IT to another abstraction, which is called the President's Transparency Initiative, to try to push more consumer forces in healthcare. I'm not going to talk about that very much today, but it's certainly something that's, I think, really trying to speak to some of the more core and fundamental issues in the healthcare system. Boy, it was, I actually was just thinking on my way over here, which has, bigger egos, Capitol Hill or, UC Berkeley's campus. And I actually concluded it's got to be Capitol Hill. The egos there are so big that, if egos had gravitational pull, they'd be like a black hole, sucking all matter and energy into it. But it's, I think we've got health IT to a point where there's going to be a really good transition and really taking things to the next step. Just maybe to give you a couple of timetables to think about. We are on May 16th bringing forward very detailed and specific recommendations from work groups about how to move forward parts of the agenda, and I'll talk about that. These are really going to be, I think, from the drafts that I was reviewing on the plane this morning, very hard-hitting and very pretty far-reaching, quite specific. And so that's coming. We've got a STARK section, which is an economic incentive regulation coming out soon. Got a number of standards issues, and I'll refer to a variety of those. But needless to say, I'm actually pretty eager to come home. So I live not in Berkeley. I'm not smart enough to live in Berkeley. I live in San Francisco. But I realized I had to do that because things were just starting to make sense to me in Washington.
That's really it's a dangerous position to be in, but it's really what's amazing to me is how quickly things change. So I announced that sometime over the summer I'm resigning. I was in the airport this morning, and some guy was looking at me, and he said finally, "Didn't you used to be David Braylor?" I'll have the joy of pure anonymity here within a couple more weeks, which is great. Well, we're 3 years into our effort. I actually spent most of the year in the White House working on this policy, and I spent actually months working on the President's State of the Union sentence on health IT. And it was expertly crafted. And then the afternoon before the State of the Union address, the speechwriters called me and said, we're cutting 5 minutes out of the speech, health IT's out. And I said, well, you guys can't do that. The President approved it. It doesn't matter, it's out. So we negotiated actually another sentence that was shorter, but I realized then that speechwriters set all the policy in Washington. It had nothing to do with Congress or anybody. But the funniest part of that State of the Union, we've now been mentioned in 3 State of the Union addresses the last year. There's only terrorism is the only other topic that's been in all 3. But here's the funny thing, how the government works. Sometime about March each year, after you're in the State of the Union address, you get a budget charge from the General Services Administration for the support costs of the State of the Union address. And it's largely a function of how many words you had about your topics in the State of the Union address. So this year we got, actually, as you heard, 2 sentences. Actually, it was 1.5 sentences and then some garbled ending that got messed up. But, I'm going to go back and negotiate on that. But, and we got charged $37,000. So I'm thinking, this is like Google, it's like word placement, and so that's how your government works. Truthfully, they would have given me a paragraph, I would have chipped in $1 million. I don't have any money since Congress last year didn't give us any appropriations, so it's really interesting to see how that plays out. You probably know we are. Okay. You want to get a word placement to say that? We're well along. I'm going to just kind of give you a quick snippet about kind of reminding you where we're starting from and what we're doing. And then I've got, as I said, some really interesting dilemmas I'd just like to present to you. If you want to talk about those, great. If you want to talk about something else. And I apologize, I'm on a very, very tight schedule today. Typically, by the time I land, all hell's broken loose and I have to go fix some things. So I do have to run out a little bit ahead of my schedule, so let's use the time appropriately. We laid out 4 goals, and one of the key things we tried to do, which caused the IT community to be a little alarmed up front, but then actually has led to, I think, one of the real resurgences of this issue, is tried to say, it's about the information, stupid, not about the technology. In fact, one time I was briefing the president, and all these big senior executives, and it's not just in government, the private sector, when they think about health IT, they think about computers. And they think about the technology. And we keep saying it's about who gets the information and how they use it and how it shifts the market. And I just wasn't getting through, so finally I said, look, it's about the information, stupid. Realizing that I was paraphrasing a former president's "it's about the economy, stupid," when he beat his dad. And so I got really bad looks. But the point is, it is about the information. And so we laid out 4 information goals. Number 1, to make sure information goes to clinicians. That we recognize that over the course of time, the standard of medicine means that physicians are in a relationship with the patient and with an information appliance of some form or another, that we're beyond the processing capabilities of clinicians. We know that. If anybody has any doubts, wait for genomics to start affecting medicine and drug dosing. When the concept of the 100 milligram pill goes away, I think you'll recognize you simply can't keep present all the different formulary modifications that genomics would bring forward. And in doing this, I think the concept really is pretty straightforward, and then it gets pretty interesting. Straightforward is what I call a widget today. An EHR, an appliance, a PDA. These are things that are not revolutionary anymore. I think to some doctors, maybe in some places they might be, but in general, we're trying to bring to most of healthcare what's happening with some of healthcare. And that's one of the reasons we have a real success factor. Most doctors who are going into practice now, were born after the IBM PC came to market, and they're going to bring these tools forward. But the interesting piece gets to not the widget today, but the remote service tomorrow. Because the real thing that this stands for is allowing the same thing that IT has done in every other industry, which is allowing remote interactions between participants in a transaction. And this is something that is quite threatening to the very core of medicine, because still today, Medicare and most other insurers, largely, without saying so in so many words, say legitimate care is only delivered when the doctor and patient are within physical proximity of each other. I personally believe that's an obsolete concept. I think many doctors do. On the other hand, we have a reimbursement system that is caught up in its design in the 60s, and it still does not come forward to start recognizing that prevention is all about what happens before you get to the doctor's office, that chronic care management is about what happens long before you get into the slippery slope to a hospitalization. And technology is going to be the piece that calls the question on society, because before we've never been able to do it. Telephone calls are not free, disease management, home nursing, they're expensive, they're labor burdensome. Technology is a whole different ballgame. If we can monitor people in their homes, if we can monitor people in their workplaces, if we can monitor people in their cars, you can do that, right? I visited in Michigan a place where they're creating a driver's seat that can weigh you whenever you sit in it every morning. You guys know about this, right? I visited, and I got in a lot of trouble because I said at a National Governors Association speech that my thinking was we could go further. Not only does your car weigh you, but we have a GPS and a decision support system that prevents you from turning into a McDonald's. It's the solution to obesity in America. But this is not kind of a theoretical future. This is coming very quickly, and some of the recommendations we're dealing with that create major issues on the May 16th meeting are about the degree to which we will betroth real remote services. And we're starting small with secure messaging, but the precedent that's set is about very large things. And from a technology perspective, that's when it gets really interesting too. Because it's not about a doctor using a keyboard, it's not even about a database of electronic health records, it's about a streaming set of information that's flowing from a patient's home, body, etc. Things that allow people to be empowered and autonomous at home and not in a nursing home. But who does it go to? Doctor's not sitting there in a command center watching stuff screen by. It's not just outpatient. Look at inpatient with ICU services, the remote ICU. They're transformative with respect to death rates and costs and capacity utilization. We're looking at these as a major part of our surge capacity plan for pandemic flus, because surge capacity is the solution to managing pandemic. We can't change the rate or the number of cases with a pandemic event in any computer simulation we've done. We can change the death rate by trying to suppress the maximum rate of cases and surging the healthcare system. And ICU services are number one in line. So that's a big thing that we're really focused on. Secondly is obviously interconnecting data. The concept in the end is data is patient-centric, it's not provider-centric. And technically this is something that's quite easy to do. Maybe because it seems quite easy to do for people like Calreal, which are struggling with the reality where I don't have to because I'm at 10,000 feet. It seems easy to me at my level. I don't know what the problem is there, Lord. But the point is that it does expose the real barriers, which have to do with how medicine's organized and the regulations that create functional, purposeful silos. We, for years, have benefited from a regulatory perspective by constantly playing doctors and hospitals off of each other, and making sure that they're at war, making sure that they're not seen as collaborators, making sure they're not allowed to collaborate. And I'm not saying that that's not correct, because protecting from abuse, which could happen if the doctor could have an undisclosed financial relationship with a hospital and get a kickback if they're admitting somebody someplace, is not a good formula for good care. But it's created these silos that keep collaborative care and team-based care from happening. And so this is an area where technology, again, is going to call the question and say, are social policies ready to move forward and start thinking about what that looks like? But this is a major initiative that we're underway with the Nationwide Health Information Network to begin really delivering that architecture. And the idea is very simply that if you have a widget or an appliance or a monitoring tool or a remote service, rather than everybody wiring up custom services and having very high costs for maintaining and supporting those, we want a ubiquitous, more generalized, multi-point technology, not unlike cellular telephony networks or things like that. I would give you the BlackBerry example, but yesterday, in the great wisdom of the government, we upgraded both of our BlackBerry networks, and I still can't get the other one to work. So this is the government that's leading you into the future of technology. I can't even get my BlackBerry to go through some upgrade from some security software or something. But it's really obviously a big issue. Third is to make sure consumers get in the game. If there's anything that drove our agenda, it was bringing consumers directly into information relationships and decision-making into beginning to not be paternalized, but to be an equal partner, not the deciding partner of what happens in healthcare. Older consumers are going to demand it, but the issue is ultimately, this is the classic economic view of the market where information asymmetry is at play. Consumers simply don't know as much about what their options are and what they can do and what's going on with who's delivering care as the people on the other side of the equation. And I'm not arguing that there's a conspiracy to do that, but I would argue that inertia and the professional centrism that's built up in our industry is incredibly profoundly biased against patients. And I think that's something that seniors going into care now are going to confront. But we do have this paradox in that people who are consuming most healthcare services are old enough that they do not necessarily have a high aptitude with information using the web, browsing, and people that are good at that don't consume much healthcare services. So, there's kind of an interesting thing playing through over the course of time that we very much want to see consumers be able to get their information. And then finally, be able to protect against public health threats. We hopefully will not have a bioterrorism event. We certainly will have a pandemic event at some point. Early detection, capacity management are the keys to having a lower death rate. If you look at pandemic, I mentioned this, the death rate in typical modeling is 0.3 to 0.1%, kind of an average death rate, if we kind of play it out like other pandemics. Where the healthcare capacity is surged, we're beyond kind of peak capacity, death rate 7, 8, 9, 10%. And this has been consistently seen. So we're talking about a huge multiplier death rate in our ability to manage and predict this. So the point is that the government's thinking has switched from trying to detect the event and say, wow, pandemics are happening here. Our sense is, we'll read about it in the New York Times. We'll know that it's happening. The issue is managing the capacity of the system. And it's not an event in time. This will happen across the course of a year, 2 years. And that is a very difficult challenge that I think what we're revealing is the public health apparatus in the government is in both all levels of government, federal, state, local, is really out of condition. And if you look historically, public health tools become obsolete, and then something happens and it causes a massive spend up, whether it's a big epidemic or it's going back in the past, other threats that have happened. So we're spending about $3 billion on pandemic, or $2 billion on pandemic surveillance, $1 billion on bioterrorism surveillance. But that money's not really being spent on surveillance because of the same thinking that came with the interstate highway system. The brilliance of that was design it for military need, right? So we can protect our cities or evacuate people, but use it for peacetime. And that's largely what's happening. The smart thinking here that's happening is don't build a specialized tool for when the pandemic comes and we turn on the control center and fire up the electronic circuits. Use it every day for managing salmonella and E. coli and sexually transmitted diseases and all the other traditional purposes for public health, but build in the capacity for it to become the event management system. And that's well underway, and that money's going to be translating into a substantial shift of public health towards data mining techniques and techniques that are really building direct data feeds. But the agreement that we're coming to, which has never happened before, is that federal government and state governments get the data at the same time. It's always done from local to state to federal. It's 26 days to get data to the federal government. And that's not exactly a very good idea. We want it simultaneously. And that's going to be a recommendation coming to the American Health Information community. It's unprecedented in the level of collaboration. Still, states will be first responders and all that, but again, information is causing relationships to shift and historical assumptions to occur. So let me talk about a couple of fault lines and I'll stop. So one of the enablers of all this are information standards. We have a very inadequate capacity in the U.S. for standards. It's always attributed to me that I've said that we have so many standards you can choose as many as you want. I never actually said that, but it's pretty cool. Unfortunately, it's true. But it's not just that standards are in conflict and they're semi-overlapping, they're incomplete. There are agreements to agree. They don't get down to the level of detailed guidance such that two software engineering teams could implement them in a reasonable way that could end up being compatible. Two engineering teams working in the same production environment, and I know this from my past experiences with my company, end up producing completely different solutions. So our solution, our need is we need standards, no question about it. The question is, how do we do that? And so we've spent a lot of time thinking through two different approaches. The so-called de jure system, right, where we have experts come together and sit and think their great thoughts about standards and birth these groundbreaking solutions and design the schema. Or we take more of the de facto approach and say, you know, we're going to give weight and credence to what's being done, and it's going to standardize over time. Given that we have tried to bring pragmatism to this issue, we've weighed in on de facto standards. So rather than telling everybody, don't do anything with standards, wait for the federal government to promulgate them, don't worry, your government's here to help you, we're telling people, go pick your standards. Go do it, because the more people who pick and start weighing in and gravitating towards certain standards, we get benefit from. It's like voting, because there is a momentum and a direction. And I say that because we don't think the journey is a stair step. Well, we will go from unengineered, non-standardized to engineered and standardized. That's not an event. That is a journey. And that journey will happen over the course of many steps. And the point that I'm ultimately making here is it's much easier to go from one standard to another, to harmonize them, than it is to go from nothing to any standard. And so any step in the right direction, given the journey we're taking, is right. Now, it's controversial. Some people would say, no, we've got one chance to do it right, let's do it. But, my answer to that is that's HIPAA, right? So HIPAA has standards in it for electronic transactions. You may have heard of HIPAA, I don't know. I wish I hadn't. But, HIPAA has many, many known defects in the standard. They were known at the time. It's now been updated twice in the private sector, and we can't figure out a way to change the regulation in less than 3 years to review, which means by the time we do it, it'll be out of date again. Regulation and the sclerosis and the slow, deliberate process that sits in with that doesn't fit with technical innovation. So that's why we wanted to do something more de facto. That's an interesting challenge. Secondly, we tried to go further and say that standards are not about data, they're about problems. If you look at all the standards that you see in your life, Wi-Fi, DVD, VHS, various formats and standards that might affect you, all of them are aimed at solving a problem. Nobody says, geez, I've got a whole bunch of media, and gosh, I like the standards. You say, no, I'm going to listen to music on a device that's this big, and a standard's created for that. And so we're trying to do the same thing in healthcare and get people out of this kind of boil the ocean type thinking of, let's fix lab data, to say, well, what are we trying to do? Are we trying to fix it for public health reporting, for patient portability to the ER, for complex decision support? Those are different problems, and the standards, complexity, and detail depends on the problem. So we're trying to take people to a use case driven approach so we can start piecemealing this and make it move along in an incremental way, yet hold it adherent to the global standards. In fact, I've got a 2-day summit with my global peers here in San Francisco next week to talk about, in part, global standard structures and how those work together to ensure that we have a coherent solution. But this is somewhat controversial. A lot of the standards community are like, this is boring to us. We don't solve problems. We're here to articulate, standards. And we've had a lot of back and forth, but it's been a very interesting direction that we're going. Application-heavy versus network-heavy applications. We have a very application-heavy world today. Everything resides in the EHR. If you think about a broad, generalized connectivity, like the NHIN is moving us towards, most of the things that sit in the EHR are not going to have to sit in that level of periphery. They can be much more centralized. In fact, I think we'll spawn a market of modular tools, not unlike things that happen on the internet, to allow public health surveillance to be an attribute of the network and not something we're trying to literally go out and collect out of the EHRs. To allow decision support or various other things to filter itself in other places. This is still a question about how far it goes, and largely because it's going to change the structure of the IT services market. So it's really been an interesting kind of debate and fault line as we go forward. Unique versus relative identifiers. There's constantly calls for, we can't do this being all this health IT stuff without having a unique identifier, which I don't know how much time you spent talking to any consumer groups, but those words would largely be your exit from any degree of public influence. American consumers don't trust us. They don't trust government. They don't trust their health plans. They don't trust their employers to have their data. Unique identifier equals breach of trust. Now, is that right? No, it's probably not. But that's the way consumers believe, and that's where we have to start. Because if we try to push technology faster than social consciousness, which we could do, right? It's happening all over society, then we'll just end up in the middle of a really brutal civil war about civil rights and health information. And I don't think that's where we want to end up. So we have to move ourselves incrementally. This is why we've tried to push more of a federated or a relative identity measure, recognizing that many systems have different identifiers. You don't have to have one global. They just have to mean something in truth as opposed to not mean anything. And there are ways to do that. All your financial information that behaves that way. The technical infrastructure is not ready to do that yet. It's something that's a challenge that's out there. And then finally, there's a very interesting fault line about privacy versus accessibility. We live in a world that has a lot of privacy rules. They're inadequate. For example, personal health records are not covered by any state's privacy rules. So if I put my information in a personal health record, that entity would not be breaking any law, except for maybe in 2 states a generalized privacy rule that has nothing to do with health information per se, if they sold it. They might breach an agreement with me through a license agreement, but our laws are inadequate for the digital era. There's no question. We've got a large project that we're working on to try to really model what those things look like. But the point I'm trying to raise is that the more subtle issue underneath this is that it's not as if we're just going to lock all this information down and everything's going to be protected. So here's the case in point. Most states have, for example, mental health rules that keep mental health-related information or HIV-related information from being disclosed, meaning that the drugs and other things, which is good because that's protecting those people from stigma. Now, part of the reason that's so important is because we don't have non-discrimination rules. And one of the things I thought the Senate did very intelligently, and they do something like that occasionally, is they passed a bill to call for non-discrimination around genetic information. I think is really a good model for health information in general. But one of the things that's interesting is that most of the dangerous drug-drug interactions are around HIV drugs and mental health drugs. They have a very long list of high morbidity drug-drug interactions. And it's not as simple as us just denying that data filtering into a decision support system. If we do that, we're going to implicitly give mental health or HIV patients or others. It's not just those. Chemotherapeutics are, in California, for example, you can't even really, chemotherapeutics and whether or not you have cancer is considered similar to those other high stigma diseases. We're giving people the unstated choice of do you want stigma or risk of death? And clearly, neither is correct. So this becomes a policy design around technology where we have to figure out a way to make this information available in a black box or some way so we can parse it against another prescription and make sure we're not giving somebody something that's going to kill them, yet not let it be disclosed. And the level of kind of grossness of, oh, we'll just lock it away or we'll just make it available is not even a starting point. And this is something where we've been working very much with the mental health community and other disease advocates to start raising consciousness around, in the health IT world, things that seemed right in the paper world could be quite dangerous. And there are many other examples of that, but I won't dwell on it. So those are just some of the fault lines that I'm worried about, things I think we'll be talking about for a long time. Again, it's not about the technology. I know there are major technology questions, but ultimately this is about how we redesign healthcare and using this. So with that, let me stop and say thanks, and I hope we've got enough time to have a good discussion because I'd really like to hear your thoughts and see where we go. Thanks. Do we have time for discussion?
We have plenty of time. Probably 15 minutes or so. Dan?
So as you talked about the fault line with respect to privacy, it seems we have a society where maybe one view is that the privacy fundamentalists have actually held the rest of us hostage. And the rest of us are dying at somewhere 50,000 a year because the privacy fundamentalists will simply not budge about any issue related to unique identifiers and the benefits that would accrue at a systematic level in terms of coordinating healthcare. Where is the tipping point? How does one move a society off extreme arguments to understand the cost that we all incur as a result of strongly held opinions by a very small number of people?
Yeah. Well, just I guess 2 comments. I don't know that I have the right answer, but first, the interesting thing to me is that Everyone loves fighting about HIPAA. And I've been spending a lot of time trying to get the privacy advocates on both sides, the pragmatists, the zealots, to say, you know, HIPAA's a great fight, it's great fun, it's like, you know, mud wrestling, you know, people get splattered and everyone's kind of damaged in the end. And it doesn't matter because the bill's not going to change. It's, you know, one of those things that's just now part of our legacy. But what I see is everyone spends all the time fighting about HIPAA, and no one's thinking about what privacy rules look like for the future. And I really do tell the privacy community, I feel like they've dropped the ball in not being the leaders and forcing this debate about what's happening with personal health records, or how to begin thinking about tightening up the accounting rules in the digital era, where the excuse that hospitals appropriately use that it's too expensive to keep track of paper for accounting purposes is no longer relevant. So that's the backdrop. In terms of how to move it forward, I can tell you what not to do. Don't move it from the national level first, and don't move it out of government. So that means it moves in regional projects, it moves through voluntary consensus. I'll call that opt-in. You know, it starts at the state and local level. One of the big flaws that people in Washington have somehow forgotten, and I'll tell you, you know, my view, and this is very much filtered in my entire experience, is that Washington is so detached from what's really going on in healthcare, and the level of IQ about healthcare in the government is just really decidedly low. They don't even know that federal policies largely aren't the things that drive healthcare. Most of the things that affect healthcare are reserved for the states, except for Medicare and a couple other big things that are attached to that. But if the federal government isn't acting as a primary insurer of elderly people, it really doesn't have much of a stake in this battle in a lot of ways. And so what is therefore forgotten is the states of the laboratories. And if you look at what's happened in lots of other areas with privacy, if you look at privacy of electronic information and electronic protection acts that are now kind of coming to Capitol Hill, e-commerce sales taxes, they've all come out of the states for 10, 15 years. There's been huge experimentation at the state level. And there's natural laboratories. The best ideas start filtering up, and states copy from each other. And, you know, we get this body of law that actually is very intelligent and very practical. And that's what we need to do. And that's one of the reasons we've been so strongly pushing RIOs to really engage and to develop privacy regimes that go beyond state law, to say, here's our operating policy, because it's a test case for this. And we're going to be cataloging this in this next exercise. But I think a privacy scheme where you say, you can opt in and use some kind of an identifier that will allow your information to be portable in this way, or you can opt out and here's what we can do, but we're never going to allow some statistical inference about who you might be to put you at risk of us mistakenly classifying you or of someone else seeing your data. And I think the early thinkers of this, the consumers that would be kind of interested, will think it through, and it'll begin developing something that I think ultimately will lead to a default condition of more like an opt-out, which is, you're in, just tell us if you want to get out of it. In Santa Barbara, we actually did something we call two-tailed privacy, which is you could do opt-in and opt-out. You could tell any provider that they're allowed to see your data or not. And despite that, you can tell any provider that no matter what somebody else says, you're not allowed to send it to them. It's two-tailed. It gave two levels of protection, and it turned out that opt-out was of much more interest than opt-in. So that's at least, I think, the starting point. I hope those would come to the federal government. Congress, I don't think, has the capacity to really process this, and I don't think it would come out the other end anything like what we want it to be anyway. Please.
Debbie, you're coming back.
The states have, in the past, have been the incubators and the experimenters with a lot of different laws like that, particularly with privacy of medical records. But what we've seen in particular in the last couple of years is Congress preempting the states in order to have national standards. We've seen it. It's happening with medical records. It's happening right now in Congress with data breach laws. What is a mechanism that we can use to return some of that power back to the states so that they can be those experimenters as they were in the past?
Well, I don't think that's going to, I think it's a true observation. It's really been remarkable how much the federal government has been preempting states, given kind of the stated orientation of the government now towards states' rights and more federalism. But in this area of privacy, I see little, if any, interest in Congress in taking it on. I think they see it as a loser. So I think almost by default, the states have some larger domain here. But there are two ways for states to act to be able to create privacy rules that are more ubiquitous across the U.S. One is for them to come to consensus and recommend to Congress that they do that. They develop the model policies and take it to Congress. Or, now use e-commerce sales taxes as an example, states could develop a model policy and each state replicate the same policy without congressional action. And that's now in 32 states. That's also what was proposed for the medical licensure standardization in 1989, a model policy that allows standardized reciprocity of licensure. And it never got off the ground, because it never got past the first state. So I think there's two methods. We have a project underway called the Health Information Security and Privacy Collaboration, where next week we're announcing contracts with 34 states, where each state will develop an in-state consensus discussion about their model privacy policies for the digital era. And then all the states will come together and do cross-state consensus. They'll find the least common denominator where they agree, and then they're going to talk about implementation. Should they do some state pilots? Should they try to do e-commerce sales tax type harmonization, or should they go and pitch it to the hill and see if they're willing to bite them? So this is uncharted territory, but we're forcing the dialogue about these privacy rights questions so that we can move that discussion along and it doesn't happen under an urgent crisis, which is bound to happen at some point with a privacy breach.
Do you see any potential collision between the posture of de facto standards development and the movement for certification of first, now ambulatory records and then inpatient records? In essence, will committees doing the certification be interested in applying standards as part of the certification?
Right. Yeah, so what he's referring to, for those of you that don't know, is something that we launched called the Certification Commission for Health IT. And it started with ambulatory electronic health records. It's certifying on 3 different aspects of the electronic health record: privacy and security features, standards and interoperability features, and decision support features, largely hitting the 3 dimensions of consumer utility and value. We are very, very supportive of that effort. We're going to move on to the inpatient electronic health record, personal health records, other things. On Monday, that group came to consensus on its ambulatory electronic health record criteria, and it's going to recommend those to the federal government for recognition on May 16th. So, you know, it will be, I think, in the de facto state at that point. Is there a collision? I think there is to some degree, because you know, standards, I think, are dealing, the standards process, what we're doing in the Health Information Technology Standards Panel, which ANSI convened for us, is trying to deal with the very root substrate data implementation integration guidelines. And it's incredibly technically complex, as you know, and it's quite detailed. It's slow-moving. And certification is happening here at a market entry level. And just like, I'll give you an example. In fact, what it's doing is ratifying the standards work of various groups. I'll give you an example that is maybe a little more obvious and take it back to interoperability standards. It has a number of recommendations and what the basic decision support features should be in a product. Well, it didn't make those up. It looked at guidelines recommendations from various medical societies and others who have been developing recommendations for what are the kind of minimum, obvious, high-value clinical guidelines that doctors should adhere to. And it's incorporating those. But it's making a different kind of decision. It's making a business decision about commercial readiness. Therefore, what it should be doing is taking from a bigger universe of things that are in formation, that have been around for a long time, somewhere in the middle, and picking the ones that are ripe and ready to say, this is what the market should be bounded on. The issue with technology standards, where it's doing the same thing by being fed up, is to date we've never had much consensus or much process to birth these standards. It's been kind of a free-for-all. So it's going to take a couple of years for those to get worked out. But luckily, there's been a number of standards that are so obvious. They've been pretty much agreed to in a de facto way, but never in a formalized way, that they've had a starter kit to work from. E-prescribing standards is a good example. There's still some mop-up that needs to be done on those, but they're pretty much there. Lab standards, I think, are very close. Some imaging standards. So, I think what they're going to do in the first couple of years is take some obvious standards, but what they're doing is promulgating through their roadmap guidance to the Health IT Standards Panel to say, here's what you guys need to queue up quickly. And so, what we'll have soon is the Health IT Standards Panel out ahead of them, mowing down the standards that this group could come along and say which of these are ready to say this is kind of a market definition for. So it's a little bit tedious to figure out that, but it's moving in the right direction now, and I think it's going to get a life with some. With inpatient, it's going to be pretty straightforward because some of the inpatient systems have had very powerful de facto standards for years around lab and other things, and so it's just going to codify some things over there. Soon we'll be getting out into really new stuff that there's not even a standard definition for, and that's really where it's going to be the real test. Please.
My question is on telehealth and reimbursement. What is the current status on reimbursement for telemedicine, and how do you push for it if there isn't a reimbursement for Medicare, Medicaid?
Right. Well, with respect to telemedicine, there's the Telemedicine Act that was passed in 1988 and then renewed in 1995 that allows in underserved areas, certain rural areas, and certain other definitions of access for minor reimbursement. It's so complicated, except for if you're in a really rural area that has certain obvious characteristics, it's just too complicated to worry about. But it was kind of Congress's first attempt to try to think about how to modernize those rules. Plus, we've documented 18 health plans that pay for some form of remote service or telemedicine, and they're not all in the same place. They're all kind of experimenting with this. What does it take? Well, it depends. There are a couple ways it could come to be the law of the land. Congress could act. Probably unlikely. They don't seem to be that interested in bigger health care things right now. Maybe in a few years they might be. I think my view is there's going to be a big health care debate at some point, and then we're going to be putting all these cards on the table, but not right now. Health plans could keep pushing. They're seeing a positive pro forma because the experience that's been reported so far is telemedicine is not additive to other inpatient or in-person services. They seem to be a substitute for them, and they're cheaper, and that means it saves money. And that's been a pretty good experience. As private plans do it, at some point that puts pressure on Medicare to do it. Why? The answer is because the statutes that guide national coverage decisions, which is the policy by which Medicare decides what it will pay for, requires that Medicare treat as precedentary the coverage of private health plans. And at some point where private health plans are doing this at a level of breadth that is considered, I would say, not quite mainstream, but kind of a step before that, Medicare has enormous obstacles in not providing coverage for that. That's a pathway. Or Medicare could decide to modernize its reimbursement schema to look at those transaction services. I'll tell you the whole of Medicare more than any other single thing. It's not that the leadership isn't there. I mean, it's a very progressive, very thoughtful leadership. It isn't that people don't see the opportunity and the problem. It is that the actuaries, who are incredibly conservative, are convinced that telemedicine services are additive. They're not substitutes. And that what we'll be doing is paying for email, remote monitoring, and all these other visits. And they just have this view that frankly, is not altogether untrue, that no matter where you push down on this, if you cut prices here, if you do something here, volume goes up. And that's their fear. And so, it's, luckily, the actuaries have a lot of autonomy to keep kind of the political process and turning Medicare into kind of, an earmark factory. And so, their determination is quite binding. And so, it's hard to present evidence, and that's why there's a number of good studies going on. But unfortunately, those studies are at the level of what I call economic evaluation, not actuarial evaluation. You know the difference between an actuary and an economist, right? An economist looks at his own shoes when he's talking to you. Never mind. So it's a challenge. But while I recognize it's a challenge, it is so obvious and so inevitable, and the benefits are going to be such that the other pathway of coverage decisions could be made, which is Medicare coverage also allows for a patient to appeal that their coverage is denying them a technology that could benefit and improve their health. And those kinds of patient appeals, if pushed appropriately, are incredibly hard to resist if they're appropriately done and they're legitimate. And that could be the process. Please.
It's my understanding that we do not have a public standard terminology for drugs. And there was some work going on under the VA on NDFRT, which seems to have it's not quite clear what's happening to it. But in any case, it would seem to me that now that we have Medicare reimbursement for some drugs, that it's prima facie, well, it's extremely difficult to even begin to compare coverage of these things unless you can tell which drugs they're covering and at what cost with some sort of standardized nomenclature. And the question is there going to be any serious initiative to address the question of standardized drug terminal? It's also critical for almost any clinical decision support for drug dispensing and things like this. And to my understanding, to date, all this stuff is built essentially off of proprietary or very local drug terminologies.
Your observation is right. We certainly have at the manufacturing level, we have the NBC codes, but they're not parsed at the level of clinical detail. They're more formulation dependent and packaging dependent. And they're not even kept up to date. They're voluntary created by industry, and then the FDA has a process that's kind of Byzantine about how any of those ever come to be. There are a lot of collisions that have to be worked out. There's been a call for here and in other countries to have a standardized clinical terminology that refers to the chemical formulation and the uses and indications of the drug. It's one of the components that the UMLS project tried to do, but it's only in a prototype stage. It would take the FDA's action to do that, and I agree that it does have value. But it's, I think, to be very candid, standards are always about economic warfare. And I think it's fair to say that some of the things you can do with the standardized formulary, there are a number of interests that don't want to see being done. And so, the question is going to become how do those interests weigh against the broader public interest of having better decision support and better scrutiny and evaluation of drug coverage and less errors. This is an issue that will be on the top 3 or 4 issues when I meet with my peers next week, because it's a global interest, and all of them are looking to the U.S. for leadership on this. And I was actually hoping they would take the lead on it. But between all of us, the one thing we're sure of, we have a global pharma market, so we're not going to create country-specific vocabularies. We need a global vocabulary for drugs, so that it can be, the cost of it can be spread around the globe. So I'm hoping to get an initiative launched. It's pretty, frankly, easy to do if we have the will to do it. But
it seemed like Hurricane Katrina took the wind out of the legislative activity around funding health informatics. Do you ever see that growing again, such a wind? And what about the extent of the uninsured? Do you think that's going to overtake funding for health IT?
I'm not sure about your observation, only because just if you look at our experience, our appropriation was cut to 0 by Congress a year before Katrina occurred, and we'll see how they do post-Katrina here as we come into this appropriation season. For those of you that don't follow, we have an appropriation of $61 million for the year we're in, so we have the fastest growing budget in federal government. But starting at 0, we're going to go up unless taxes or something. But I think, if you look at the dynamics of Congress, there's clearly a growing concern about the fiscal priorities of the United States. And, it's despite the huge groundswell of support for health IT, this is not on the tongues of most, constituents when they fought for congressmen. It's, people don't think much about health care, let alone health IT. And so, it's an easy target, I guess I would say. But, I think that's countervailed against a huge interest on Capitol Hill on these initiatives. And, what's happening with Rios, for example, they're educating their Congress people. They're hearing it not from the consumer level people, but from the professionals. And so I think the direction is going to be quite positive, but I would never extrapolate that to say that unless there's a major change in thinking that our government's going to advance the health IT adoption for the U.S. I'm personally very opposed to that, not because I don't want somebody to spend money. I'd love to have billions of dollars to throw around. But the truth is that money's not free. It's not free in terms of how the taxation works. It's not free in terms of how the bureaucracy mismanages it. And it's not free with respect to the strings attached and the regulations that it brings. And I don't think you can fund innovation and things that are necessarily going to be evolving over time through those kinds of kind of one-size-fits-all, top-down, non-moving kinds of things. And so, to me, the obligation of the government is to use its purchasing power and other things to prime the market so it sucks in a lot of this capital. And I think that's probably the more preferred way, but the government's got a lot more spending to do on the R&D and a lot of the other things that needs to be done. So I'm actually pretty positive about the direction for this, subject to the overall tenor of the economy and government spending. I can tell you that some of the people that are quite influential in the Hill are very supportive of health IT spending. They see it being one of the few signs of promise they see for the healthcare industry of the future. With respect to the uninsured, I largely do not see people making a trade-off between those two. I've never been in a discussion where it's been, that those are either or. Neither have I been in discussions where there's been this sense that, health IT can create such savings that it helps the uninsured issue. I think, Washington falls into two kinds of thinking, demand thinking and supply thinking. And the interesting thing about health IT is that for years, when Washington thought about healthcare spending, it always thought about the demand side. How much to raise copays, how much to lower copays, how much to create subsidies for populations that were disenfranchised, how much to change eligibility requirements. You're changing how many people get to go through the system and what their burden is as they go through it. And they leave the whole system alone. And health IT is one of the first times ever that official Washington says, we're looking at how the industry operates and the supply side and what it does when a dollar of benefit goes through there and whether or not value is created. So, these are two different brains that are operating. And so, uninsured constantly gets traded off against other kind of supply side things like expanding benefits or, changing eligibility for other things or, research spending for new drugs. That's the debate that always, because those are kind of demand-based. But, we're really trying to legitimize not just IT, but there is a fundamental obligation the government has to fix the state of the industry and the market conditions because they result from very, very old government policies that have just been left alone for years. How we pay for care, these regulations that create silos, professional licensure, all these things. And I think the groundswell ultimately is to say it's time to do something about it. But it's not going to quite happen yet. Please.
Let's see. My question goes to Medicare mostly. My background is Japan, so we have same problem.
Right.
But the question is, just as you said, there are so many players on the supply chain, from government, service providers, insurers, and also patients. So if you think, see, which point is the sweet spot to start with? I mean, among those supply chains.
Yeah.
So, and if any, let's see, I'm asking the role of IT, especially on that specific sweet spot. How IT technologies can work to help the sweet spot.
Yeah, you're asking about the transparency initiative because our thinking is that the underlying failure of the market that drives all of these concerns is how we pay, why technology is not being taken up, why we have uninsured issues, is that the fundamental primal market forces that have for years insulated consumers against the cost of care, taken away from them the ability to have choice or to recognize they have choices to make, have caused doctors and hospitals to be rewarded for volume completely over quality or anything else, create a market condition that creates an unstable market. And it's a market failure in a very classical economic sense. I mean, look at healthcare as an output. There's no other industry that creates life expectancy. I mean, think about it. You might have more fun, if you spend money on, movies or go to a cool place in an airplane, but, none of this just rearrange the quality of your days. So healthcare not only can increase the functionality of your days, but the number of them. So who would not want an infinite supply of that? And so, there's a lot of fundamentals that are broken. We can't change human nature. We would never want to. I think the goal of our R&D apparatus is to make sure that, if people want to live longer, that we've got the capacity to do that. But we do have to change those fundamental forces, and that's the sweet spot. And our transparency initiative is aimed at getting employers to begin being smarter purchasers of healthcare, so it puts buying pressure down the system, asking the questions of what value do we get in life expectancy for our money, and putting consumers in a position where they've got to make trade-offs. They have to be able to have some economic exposure. They have to be able to get good information so they can make choices about doctors and hospitals and treatments for themselves. Not overnight. This is not like tomorrow we're going to wake up and do this. This is a 20-year phenomenon recognizing that the consumer who's going to be Medicare eligible in 20 years is somebody that is information literate and makes choices today around information with lots of things, and they're going to be a healthcare consumer the same way. And so that to us is the long-term fix. Now the real challenge here is, unlike going to Kmart or whatever people do as consumers, it's kind of a really simple retail consumer market. Healthcare has two really dangerous characteristics. One, we don't want it to become something where if you've got a lot of money, you can go to Neiman Marcus, and you don't have a lot of money, you can go to Target. That's not how the healthcare system should operate. That's kind of how other countries operate, right? I mean, look at Britain. If you're in the system, unless you buy your way out, you can bypass the queue. It's a very explicit kind of British approach. That's how British society has worked for years. And we don't want that here. We have implicit kind of rationing, I guess, in that sense. And we don't want it to be something where people are shut out. So the art of trying to construct enough incentive that people feel the trade-off, but not put them in a position where it's creating economic differentials is really hard, and I don't know that that's going to work out. The second challenge is that we recognize that in general, I'm being very sweeping hand now, that as people need to make tougher and tougher and more complex healthcare decisions, their capacity to make those are more compromised. They have more and more chronic illness, they're not able to keep up their work, whatever it might be. And so we lack a health advocacy infrastructure. Again, I'll take this back to payment. For years, doctors and nurses have been asking for fees, like a care manager fee, something to help them just support the patient in their life, not treat their disease or fix their prostate or whatever it might be. And, we've never legitimized those. And, Germany's way ahead of us. They recognize the social component of care. We haven't. And so over time, we've got to build and fund advocates who can help consumers be good consumers, even when they're compromised. Because somebody might not have a son or a daughter or a husband or somebody that's functional. But I personally believe that whether or not you believe that the government should control it, we should have single payer, or we should have what we've got now, that's a separate debate from the fact that no matter what we do or say, consumers are going to want more and expect more and have more control, and we better prepare for it. And I would comment, by the way, everyone who's calling for a single payer, we're going to have it. Very soon it's going to be called United WellPoint Aetna Care, right? It just won't be in the government. Okay, I think we have time for one more comment. Lori? Hi.
How are you?
Good. How are you?
Can you comment on the sort of personal health record space? And it seems to be a really white hot topic at the moment. And I'm particularly interested in your comments on the health plan role, and that, with respect to the transparency initiative and really being able to recognize that there's a claims to clinical information framework we need to evolve to with respect to health plans offering services to patients, but then the barriers that presents in terms of, patient-protected behavior and fear of underwriting and fear of privacy and all the reasons why health plans perhaps shouldn't have that role.
Yeah. So personal health records are the Wild West right now. There are no standards. Even there's not standards, we don't have certification for EHRs, but there is, again, a standard of practice. It's been so many years and iterations, we kind of know what we're talking about. We're just trying to formalize it. We're not even anywhere in that universe with personal health records. You can call it a portal at a hospital and say, well, that's our personal health record. And people they believe it. And, or you can be a health plan and put someone's claims up online and say, that's your personal health record, and people believe it because they don't have any reference. Or you could have a really detailed, clinically rich, supported, interactive staff information engine like Kaiser does and say, that's our portal, our personal health record. You're getting really close there. So, it's a wild west, and you know that. So one thing that we're going to do is start an initiative, begin developing standards for what it is. And I'm certain that where we think about standards, it's going to include business transactions, sure, explanation of benefits, which is a major issue that consumers have about what actually happened to them when they had their care, but their lab data, their pharmacy data, their imaging data, real clinical data about them, and the capacity to ask questions and put it in context and make treatment comparisons. So that's going to happen, but what's happening obviously is people recognize strategically that controlling health information is a key lever to control the market. It's happened in every other industry. If you look, on the peninsula here, the peninsula down there, I guess it's kind of happening up here too. This is the hotbed of people understanding the incredible leverage that information control brings to the market. It's starting to happen in healthcare. Health plans are clearly recognizing that, and so I think they're much more strategically enlightened than the rest of the market. I don't believe that claims data will be sufficient. In fact, I think it could lead to massively failed consumer expectation So I think that the health plans have three challenges that they really want to be the purveyors of consumer information and become legitimate players and protect their franchises, consumer interests. One, they have to develop a portability standard so information can seamlessly go from plan to plan as patients switch. If it becomes a proprietary tool that if while you're here you get all this cool stuff, but if you switch you're dead, that's just gameplay. That's not acting on behalf of patients. Secondly, it has to be clinically rich. It has to have those kinds of features. It can't just be claims and say, well, we know you got a lab test. We're not sure what it was. We have no idea what the result was, but hey, you got a lab test. That's not going to cut it. And third, health plans have to recognize, as you pointed out, the inherent conflict between the information they need to do what the consumer wants is exactly the kind of information the consumer does not want the health plan to have. They have a trust issue. I can say that because I work for an entity that consumers trust less than health plans, which is the federal government. So, they don't want us to have their data, and we have to recognize that. So, to me the question is not maybe should health plans offer these products. It should be, should health plans drive the market to offer those in a way that is integrated and coherent and clinically rich? And the answer to the latter question is yes. I don't know about the first question. So, if you stand and look at it, who's positioned to be the integrator of person-centrism in healthcare? Hospital can. Kaiser maybe can, but even there's a little bit of a trade-off because people don't stay in Kaiser for life. And, even when they're in Kaiser, you get outsourced depending on services and procedures. Same with the VA. It's a system for life once you're a vet. But there's a 20% in and out flow based on procedures and events and geography. So, is it provider? Is it someone that you trust? I think this is one of the big problems. And I'll use this as a finishing point that overwhelmingly, what we ended up having to do in the work I've been doing is not focusing so much on what we need to do. But we're spending all of our time figuring out who should do it. We know we need to fix standards, but who's supposed to fix it? That's why we created the standards panel. We know we need to be able to push architectural solutions that are low cost, but who's supposed to do it? It's the same thing here. There's a big who question. Who is responsible for this? And I don't have an easy answer. I know it's not government. I know health plans have challenges, so they want to become the ubiquitous provider of that. But I don't know easily who it is. Folks, stay tuned. Thank you all very much.
We're on to lunch next.
Yes.
Is that it? Great. So please be back right at 1:30. Lunch is outside in the foyer. But our panelists at 1:30 are going to talk further about the legal issues around privacy and security. It should be really good. Thank you.
I've worked on a lot. Yes, they take a long time to do, but just a lot. I mean, things which people think were organic, like the web. I've worked on a whole bunch of those standards. They get a very good thing. Working with Timmy too? Taking care of my two little girls. Out in the today.
Oh, we keep them up. That's
How did you get working that without being considered something?
Right.
We in another room?
Yes, out there.
I'm a database researcher at and I work on IT and we're doing a lot of stuff right now on metadata.
On the inside of healthcare.
I actually was on the NC Healthplace and
Design a lot of the inpatient
I don't think these things without significant institutional knowledge. I mean, the notion that you've got $100 million a year pharmacy benefit.
Yeah, well, it would be
terminology.
How are you?
Just bizarre. But
I didn't realize you were right behind that. That's why I asked you for 100%.
I've worked on standards.
She's looking right at the air quality right here.
They're really hard, they're very slow. It's really hard. That's 3 years of work the price tag, which was distributed over all these organizations, was in the tens of millions. But there's very little government funding for this, or engagement is small.
Yeah, that's why I've spent probably the last 3 months every single week in Sacramento. Special advisors. I think that's what Russ is.
But I think that and that's a problem which it's not a trivial problem. I mean, because there's chemical technology and all these other things. This notion of these standards are easy to use. I have been brutally acquainted with the fact that oftentimes these guys will sort of skim over the surface, and they're tripping over serious intellectual problems, which in many cases half the people on the panel don't even realize what they just stepped into. But the problem is some of the compositional terminology includes in the message. How are we going to deal with the compatibilities between the terminology systems that are in the messaging system?
Right.
Hi, how are you? Good.
Anyway,
Well, good.
nice meeting you. And I have to run off to another meeting, but I'll be back later in the afternoon.
Okay, thanks for coming. Great.
So I think having,
I gotta run off to the meeting, so I'll be back. I mean, it's insane.
I know, like, what can I eat? Oh, sure,
I'm just going to grab a sandwich. Yeah. So,
You want to grab a sandwich? My office is next door. I'm just
I've got to go. I can't stay the rest. Do you want to grab a piece?
You really can't.
Because of the economic interest
Drug or health insurers, or who knows?
Yes.
I mean, I can't believe they put these drug plans, the patient is committed for a year, the It wasn't committed to sustain the same level of coverage. They could change their prices or coverage. They just amended it. They said that they can't change the price. They can't change the price on the drug that the patient is already taking.
So how are you going to work your life? Are you going to be here most of the time?
I am here most of the time, and I still have an appointment at the Technology Center, but I wouldn't spend a lot of time there. It's more to help them with but, you know, it's still nice to have ties to healthcare. They have anything really good ties to something like because I think the science is so exciting. What is a lot of the very specific disciplines in engineering look at the investment engineering people look at it.
Consulting services?
No, we're actually looking at it as a pure science. A curriculum and a research program. And my goal is to actually set up some sort of public-private partnership with the state to help healthcare, which is very strong service innovation.
I walked in last week and something for nothing but time. It turned out I consent to whatever injections you do. You do not. I don't know. You know, my initial reaction was, well, I've had tetanus shock before, I'm not worried about it. And then when I realized my mom getting this thing,
The longer conversation is, I think Kaiser's really
and this is the room, and people expect this room to be standing on this. So, yeah, so it was a good stuff.
One of the things sounds like a lot of good things going on here. Is there going to be a lot of involvement in
standing meeting flip the chairs too?
Yes.
So we're
the interesting thing is CITRIS is more of a convener. My blood pressure is way down.
oh good, you're going to do great, and it's sort of
to be here. We are
oh, are you guys inside there?
Do you want to see on the screen here?
Well, I was going to talk to Justin for a minute,
Good.
but
Go ahead.
all right, you guys are
You
okay.
I'm discussing these two items on the right.
Okay, perfect. So we're making good progress. We just sent out a first report to the board. I wanted to have the board members look at it first and then send it out to the general distribution. But I think most of the emphasis is on the CED linking project now, and we're making really good progress there with looking through the RFIs and coming up with ideas and so forth.
You didn't get one buried underneath yours.
That's a good trick. Even looks real.
How many responses did you guys get?
We ended up with 30 responses. And, you know, unfortunately, it didn't even occur to me that the folks who issued it never really issued an RFI before, so I didn't look at it before it went out. And when we started coming back, I said, why are these so big? And why are some really big and some not? Oh, no. That's usually. We didn't put one on. What was the font size? What? So we literally have some that are 200 pages, some that are 30, so it's just been a nightmare. And then maybe next time we'll chat about what RFIs look like.
Right, exactly. I mean, it's new, for your staff, that's kind of new. It's not what healthcare used to do, right?
Well, and with these folks, yeah, I don't know. I just laughed, so I thought, okay, lesson. But we had 30 responses, and they're really interesting. They range from true community concepts with Sacramento, Long Beach, and San Diego to just pure vendors complete solutions to spots. I do this piece of it, okay, but I can't really solve the whole business. So it's going to be interesting, and I think the technical work group, the subgroups looking at these are going to be prepared to have the clinical work group, the technical work group look at it. I think we're going to reconstitute folks from the clinical work group that we're going to, well, they're not understanding what they told us. Take some of the technical work group people and have them really specifically dive into the ED Lincoln project. So, there's some good things happening. Laura, she's the woman that's in the table. She's from Sacramento.
Have you broken ground? Yeah, have you been there?
And they're one of the respondents on the RFP. And they've already gone past the RFI. They've gone past the ED to their key clinics that are across the street in the state all the time that are already connected.
What I'd like to do, I'm going to come out there to Davis for probably around a month or so. If you come out here before then, definitely drop me a line. I'll send you a note. And if not, we'll let when I come out.
Hey, you guys are still sort of digesting our platinum strategy.
I need to sort of slowly make the rounds to all the health tech partners and let them know health tech is really doing what I need to do. It's kind of slow in the announcements.
Part of it is
there's probably a little
the
bit
financial
structural problem in health tech too. They're dealing with, but they'll come through.
We have the information, we can say which ones we think are good ideas, but then
Again, it's a fun one.
how fast we can implement something is how fast I can raise money to do it.
She's done it. She was
We don't have any money. So that's where I've really been working with state level people, trying to get David was saying that the Department of Public Health interested because they're, I've been talking to these individual offices, and they each have, well, I've got 500,000 to do this, 7 million to do that. Put your money together because what you're creating is your own little thing that doesn't, and the agent on the call, on one call, under Mark Starr,
Yeah, actually, I do. I'll certainly see you.
was kind enough to pull this called
I'll definitely drop you a note.
Department of Communicable Diseases
what you're up to.
and then Preventative
Are you liking
Health,
your
who's
role
doing
now?
immunization industry. So tell us what you're doing. Well, very confidential thing. You guys, no, you're doing the same thing. Talk to each other.
And I've heard them each speak, each of those groups, the NEDs and the decision, I can help you. Portal disease, and I've heard the immunization, so speak separate regions. And they're willing to talk about it without other people sitting in the room.
Exactly.
They're very supportive of their fiefdoms and their fundings.
And just the whole spot in my typical lesson tackle way. So in this industry, how many people are signed up? Well, it's somewhere between 5% of the Medicaid, healthy family, blah, blah. It's nothing.
You probably know him from some of the negotiation meetings.
Stephanie Olivier's in the hospital emergency room, that it takes weeks before it ever gets to your department and you get that call to the patient. Yeah, that's still true.
That's if you want.
I remember that from my UCLA days years ago, being down in Tijuana, picking up something, E. coli. Then I get a call at the office on the voicemail. Hi, we're calling about your communicable disease. What? And it was months later. And tell us where you got this, where you read it. Oh, I don't know.
It's a huge barrier to detecting and doing outbreak tracing. A lot of it has to do with county lab, county infrastructure, county public health infrastructure.
Yeah, and to not help the county level people work together. And then when I spoke to some of the county people, they said, oh, ED Lincoln, $1 million a year emergency preparedness. What $1
is the idea now that Calveo will actually be the organizing body and the not repository but the conduit for these things, or have you thought about taking the approach more like Frailer's office approach?
These
Saying
frenetic
these are the tools, these are the standards, this
from
is
one thing
model.
to the other.
Yes, everybody can set up around these.
I think it'll be a good factor to that. In the case of Long Beach and Sacramento,
I just wanted to find out. I mean, it's all so nice to listen to, but who is going to pay for this?
yes, we were just talking about that.
Development. That's great. It's former office. Where the, I mean, White House doesn't have money, so who pays for all this?
We were just talking about that, and in this, when I'm finding through the ED linking project, where I'm going from town to town, the emergency department, depending on where you go, there's enough money being spent on similar things that if you just put it together, then you could do this. So,
see, NIH is $29 million.
yeah.
Okay? But they will support only basic research. And if there is any technology involved, it's only that supports that basic biology research. This is not of that kind. This is really the kind of technologies to make people live more independently and economically doesn't matter. So there should be some other place.
But if you think about it, one of his example of the highway is exactly the excuse that they used to get federal funding was for military protection and this and that. So what I've been doing in terms of talking to people in Sacramento is there is no way for you to securely handle healthcare in a pandemic or biosurveillance, and yet you have any no ability to track immunizations, any no ability to do that, and yet you're spending money for an immunization registry and emergency preparedness, and WellPoint spending money mailing out PDAs to doctors, and there's this whole sequence of disjointed money being spent. So what we're trying to do at Calveo is come to the community and say, in Sacramento, luckily, the top 3 of the 4 hospitals are installing Epic EHR, the same one. So now I'm not asking you to do anything except pull a little bit of information off for the ED linking project and to the public health department. Spend some of your emergency preparedness money on the ED linking. And at the end of the day, everyone's put a little bit in, and you have that community linked according to standards and available for the rest of the
But you see, that is not helping the individual people living longer independently alone. This is not in their home.
But you've got to start somewhere.
Yeah, I know.
So then, as we move, now that the EDs are linked, the clinics across the street that do the post-emergency care link in and have that data. Then personal health record can be fed, because now it's this whole business of, well, I want a personal health record. That's great, but what are you going to put in it? My doctor has papers. And so my immunizations for my kids are on 4 different scraps of paper because I keep losing them and have to handwrite it again. So eventually, if we help build one side of this, then the other side will eventually be able to fill the personal health record, and then we've got that system built. So,
all right. So
it's a long road.
It's a long road. Okay. So that answers my question. Thank you.
So that's where we're doing this place by place. In some places, they're so organized that, yeah, all we have to do is say, here's the roadmap. Good luck.
This might
In other
be
places,
yours.
It could
they
be
don't
yours.
have
Yeah, right.
There's no place to go. They don't feel like they can develop this on their own. They don't. This hospital doesn't want to talk to that hospital, so it requires us to step up a little bit more. And I have a feeling that the personal health record piece is something
got to be something that goes with the patient, about the patient, that is a window on all the different data sources. Not you have a personal health record while you're with Blue Shield, but when you change your job next month, then you lose all of your personal your health data.
Yeah, and they don't have half of the stuff anyway, because the point about the nutritionist and the chiropractor and
what a good lunch.
Oh, really?
It's delish.
No, and so
I felt like
I
a VIP.
but when is Quest Labs and they don't have stuff? Or Altius Hospital gave me a big stack of MRIs that when you were mentioning this, where you literally, I had to go to CPMC for this eye doctor visit with their retinal specialist. And so they were using my MRIs from, because I had an episode of carotid dissection. And so I called them up, they said, sure, yeah, come by and pick them up. So I'm literally taking Bart with this giant folder of my MRIs. And then they said, we're coming back in 30 days. I said, okay, because you're going to know they're fine. Oh, yeah. That was a year ago.
Still have them.
They're on the floor in my office, in my home. My kids were kids. And of course, they have no idea they're gone.
That happens all the time. I mean, physicians walk out with them all the time. That's the most common thing. Physicians' offices are full of MRIs and CTs, and no one knows where they are, and no one knows how to get them.
And I was laughing because the way they made it sound, like they're going to know. They don't know. So, and they had accidentally slipped some guys, because I had, full brain CTs or MRIs. They had slipped a couple of this man, Lewis, somebody or other.
The wrong person.
Yeah, a couple of his, it looked like some sort of esophageal something. I'm like, what? Okay, that's not even mine. But great.
Yeah, that's the awful thing. Some poor guy then goes to get care. They're like,
they don't even have them at all. Yeah, it's like your luggage.
It's not even, there's not even a chance that they know where they are.
Mm-hmm.
Right.
I have to throw them like in my bedroom.
Right, because they're in your bedroom. I mean, at least with yours, there might be a chance to say, yeah, she checked them out a year ago. We never got them again.
Yeah, that whole folder's missing.
Right. But then they're like, wait a minute. There's no reason. Have you thought about which ones of yours aren't in your folder?
I know. That's because I was going, after that I started counting through it and I thought, wow. And the other stupid thing is,
happens all the time.
My record, my brain MRIs were there, but a year before I had some really excited orthopod look at this lump on my leg. And, MRI right away. I know exactly what this is. So they did one. He was embarrassed to find it was like fungal instead of a ganglion.
Cyst or something.
And so it's nothing. Those weren't even in the folder. Just, you can't even keep my stuff together. It's the same place. So.
Happens all the time. It's the same thing. I mean, all you need to do is spend a little bit of time in the healthcare system, and those things happen all the time, every day. Everybody. I mean, it's unbelievable. It's unbelievable what people are willing to tolerate. I mean, because the mass majority of consumers are totally ignorant, and so they don't see what goes on the inside. Or that the people who are active or healthy and are sort of consumer advocates or voters or constituents, in general, don't pay attention, or if they're healthy, they're not aware of this stuff. Yeah. And when you're sick, then you're not aware of it because you're sick. So it's terrible. It's the reason I went into this field. Yeah. When I was in medical school, when I sort of came to medical school and I started in the wards, I realized this is the most inefficient, clueless, poorly designed system ever. No one's,
It's a delusion.
And I was like 24. I can fix that.
Yeah. I know, we're all so excited. But that's really the challenge is to get it fixed, you have to expose how horrible it is. But then when you it's horrible, they don't want to hear about the solution to it. And then they're just focused on the solution. Is it really the solution? Or, it may almost call 50%, so it's not good enough, so let's not do it. But,
well, yeah, the purpose comes in.
Yes.
But and also
So people end up blaming the messenger and blaming, you know, the problem isn't the radiology space or wherever it works. Although that is part of the problem. Part of it is the leadership there, not solving the problem. But part of it is the healthcare milieu in which we get care. That's the downside of having this sort of consumer-driven, you know, whatever this cottage industry health plan. You know.
Well, that's the thing. It's even, you know, now they do have a tax system. So I could have said, give it to me, I'm coming in with my thumb drive, load it up. But then when I got to CNC, the guy would have been, what should I do with it? So instead of just calling them and looking it up on his computer, because it already had it, I brought this whole thing to him. And he said, well, I know your eye that had corner syndrome from this section is bothering you. But it's an infection. And these were fascinating for me as a resident, but waste of time. Yeah. Right.
It's hard as a patient to know in advance when that's going to be. And the problem, even as a clinician, sometimes you can't tell. The problem is, if that was essential and you hadn't brought him over, then it would have delayed your care. Not only the length of time it is for you to get over there and pick those things up, but then have an appointment.
So it's so we need it, right? That really is the challenge.
What's the website you're looking for?
Right now, this is HIS Talk Blog.
Huh? Which one?
HIS Talk Blog.
Oh, this talk blog. Okay.
So then the next thing is
and then how is it that neighbors in my doctor's office get into it just happens.
She gets paid for it.
Does that happen?
Can the NSS people
Academic guy, you know, high on principles.
Well, the sad thing was, very influential, this Washington partner.
Dave Washington. I didn't know he was serving East Coast guy.
Yeah. They brought him in.
Is that an article you showed me?
No, here's the article I showed you. I've got it on here. And it actually came from
They're saying, here's what we have, here's what we can accomplish.
From the Annals of Internal Medicine.
We're doing, here, look at, that we need to, you know, RLS.
Current issue.
And it's the currently cheaper way to go.
And basically what they did is a meta-analysis of all the literature looking at the effect of HI on quality, efficiency, and cost. And basically what they showed right here is key points.
Whatever. And saying, if you want a personal health record, I don't think this was because you're going down a road that
Last week,
That was just sort of a think tank, Washington State.
it's executive order. It's decided they're laying out the plans,
Through their governor's leadership. Elected.
And they have very little money, but they have this support. But it's just the operation first.
Well, this
I was not dissenting, but they didn't ask my opinion.
they're funding more than anybody else right now, I think, you know. key is though, you gotta hook it into bioterrorism.
1,000 flowers.
You can get money as long as you got a bioterrorism angle. If it's just to improve healthcare, there's no money available for it.
Providers can play along. Get that data in there, or somehow. Maybe they can use their state Medicaid program to drive providers in, or maybe they have more flexibility there than we have. Is that? I think it's a good. It should be on the roadmap. You're heading that way. Everybody knows where they're going.
First, it should be about 15 minutes each. 15 minutes each.
But ultimately, that's the case where it's again, that's another thing where the perfect median is good. You won't be able to get started. You'll be so busy trying to build, the golden, the gold. You still working so hard for the gold medal that you'll miss out on silver and bronze. You'll be stuck with nothing.
That's why I like our ED. So this little segment, this little bit of data, that's all just not so good. Oh, no, they have it out. Okay. It's scripts, it's talking, it's scripts. They have doctors already. And,
I can help with
right,
it.
so they create a sheet and have the doctors come see it. And they can see it. So for them, it's not good. So it starts to really show. These doctors aren't sure scripts. So you see this question of how real things and then they're just reaching out back to all of those people. So it's really, it's very doable and necessary. It's very uneven safety issues and quality issues.
I mean, my Cal Rio should be really laying out the roadmap, setting up the tools, hopefully it'll be local groups that'll come together and make Cal Rio sit on top, as opposed to Cal Rio actually going.
Yeah, we should do that.
Yeah.
Okay, plug this in.
Right, exactly. I mean, we can't get a better with that. Sometimes you talk about ED linking and it starts sounding like Cal Rio is actually going to be actually in there linking the ED data. That's not good. But to actually set up a tool and template that everybody agrees upon, I really like Cal Rio can be a linkage.
And I think for us, we've already developed pilot research. Now we're not vendor papers. So rather than have such process
Check on the page for Tom to do the program. It'd be great. That'll come, if you can do it, it's probably the best way to do it. That's just clarify that for you, right?
we have 3 pilots going. This is the agency, so they're naturally following issues. And we want you to work with us when we're with us, we set up that as long as you can do that. And then go talk to them and make sure that happens.
Right.
Don't call me again.
Actually,
That's so we can leverage the costs.
Right.
yeah, that would be a program is just happening. I don't know. And how much is it?
Great to just get test case and you'll see everyone start to jump on the page.
But it's often we have to get the whole thing
Right. Oh, yeah. You're creating a clinical case, a business case, or the local interoperability, you know, the local consortium get together.
Yes. And that's really what
I have. Yeah. So one of the. I still have it on my computer.
Don't go with it.
You want to put cameras?
When you were leaving? Oh, I'm just going to step outside.
I think it was but actually, the last one. But he had some plans about the producing things, so I asked him
So they've started to move into a viral. It does cost less to use medication. It does look about tomorrow. It could fix that. And so eventually there's a return. So probably soon. And I think whatever.
Only 2/3 that are lost. And you have to lose them again. Fewer adopters, you have less back on
and so paper neighbor and staff should get it overnighting it and her parents. So there's people, you know, you go in any office and they're always faxing everything to the
pharmacy. You know how that.
Yeah.
Actually, they do the business case analysis of how they're going to make money on the fax machine.
Exactly.
You know, how they're going to return their investment on the fax machine.
Yes.
The fax machine set up this way.
And I've been corresponding with her for a long time. She's faxed me everything. And then one day she calls me up and she says, I sent you this letter on May 12th. We didn't keep it. He sent me more fax. Not realizing that the fax machine.
So you pull the table back. Oh,
It was even made in 3 years that I won't respond to it.
But you know what? The funny thing is, the only thing there's something else start wanting to make the faxes come in.
No. And actually, since I'm older than you are, I remember when the fax machine was I just stuck it into the two folders, and I had to use personal paper, and it was such a novelty. All the work stopped and everybody must have grabbed the machine.
The rotary phone, you stuck it in the. Yeah, my dad used to have a little modem like that, stuck in the whole thing.
And the teacher and now it's just, that was when I just got out of this UCLA. You know, I have a bachelor's degree from UCLA. I did not bring it. I got just done this one, and I just got it. So, can you be typing stuff and just pressing second, I don't know how to type like you starting to do contractions. I'm not going to be your secretary.
I was actually the first attorney to put a computer out. And I got such flack about how it wasn't professional. It wasn't just wonderful. It wasn't professional. It wasn't manly. It wasn't manly.
Oh, that's so funny. I've never done it.
So that's how long ago that is.
I know. And the fact that you made you were doing this sort of actually
I've been tight at after all these years now. I can type on my right. I can't.
I'm not ready to go now. I've hung out with too many doctors, I think, because it's really bad.
Yeah. In plasmosis, it'll move in and take over your ability to write.
Great. Yes. No, I use section 6. And they just before, so they gave me docs and I could use it, but I was actually being held by
So one of the things to highlight
which one do you want to do? Show me that one. So I had to do it because I was working at Health Tech. So you click here and right click on that. You click on that one. And you split screen. So there you go.
And well, that's the problem.
So our view is
patients that they use. The other day, Terry Hill Sitting in the airport in Eureka, very so loud. Name, identifying information, and then all the elements of their story.
You didn't have any trouble using your
I know. I hear you.
There's coded ways of saying that difficult. Difficult functions or yeah, there's all kinds of coded references that we have. Like a pseudo front lines.
Thank you. Yes, I do. You're David? Are you Tom Dixon? Peter Yellow. Well, I've spoken to maybe on the phone. Certainly, I don't know when. We're not telling.
No, I mean.
We're learning too, but we're that far ahead of us.
Okay, we're going to get started around 1:30 or so, and we don't lose too much time. We have a terrific panel that I think will have the afternoon, keep everybody awake after lunch. And I'm going to introduce them one at a time. We're going to look at some of the legal and policy issues. We raised some of them, I'm sure, this morning. And we're going to try to dig into them this afternoon. I'm going to make just a few introductory comments around some of these issues before introducing the first of our panelists. And I want to start off with a comment that Leonard Schaefer made recently. Mr. Schaefer, as many of you know, was the past CEO and chair of WellPoint. They merged with Anthem and are now the largest health insurer in this country, even larger than United. Mr. Schaefer was on campus twice this year here at Berkeley as the Regents lecturer. And he has an ongoing relationship with our school. And he made the following comment. Security and confidentiality are other big issues. He's talking about IT. But they're enormously expensive to put in place. And they've made the systems much more complicated than necessary. For instance, to protect the confidentiality of our members, we went from Social Security ID numbers to unique numbers using middleware to change everything across the corporation. The project's finished. We had no problems, but it did cost a huge amount of time, money, and effort. And for what? Mr. Schaefer asks. There is zero utility to the health insurer. But in theory, confidentiality will be maintained, which is good. And the quote from Mr. Schaefer. So we will get into some of those issues this afternoon, but again, in terms of the incentives for adoption and spread and who gains and what's in it for me and value creation for what set of stakeholders and how do you bring enough of them in alignment to get to the tipping point of moving this along are some of the issues and challenges that we face. From the provider side, getting closer to the patient, we do have emerging evidence that the use of electronic medical records, at least in the provider-patient setting, is beginning to have some positive impact, at least on process measures of care. So, for example, in some work that we've done here at the university on over 1,000 physician organizations across the United States, we measured their IT functionality within the practices. And those that had more IT functionality, in fact, did more things for their chronically ill patients that evidence-based medicine suggests you ought to do some of these things in terms of process. Also here in California, reference has been made to the pay-for-performance program we have in the state where we reward doctor groups now for giving superior care rather than paying them the same, regardless of the kind of care. And we're probably the only major program in the country that directly rewards doctors' office practice, medical groups, for using information technology, both at the point of care and in integrating lab and radiology data as well. That's a domain that accounts for 20% of the total quality bonus. About 50% is on clinical measures and 30% on patient satisfaction measures. The other 20% is directly on IT. Now, 2 years ago, the first time that we did this, I believe, and I've got the data here somewhere, only about 64 of the 230 medical groups participating in this voluntary program were able even to provide any kind of electronic data. And last year, that grew to, I think it was 122 groups were able to submit data. And of those, 74 out of the 122 actually received partial or complete credit. That is, they either got 10% or 20% for being able to integrate some of this information at the point of care. What we do not know and what we have been unable to get funding for, although we're working on it with Kaiser Permanente and others, is to get funding to link it to actual patient outcome data, health status, functional health status, and so forth. And then try through that to look at the role that IT might play. Tom Randall and colleagues are working with, again, colleagues at Kaiser Permanente. I guess, Tom, you talked about it this morning as another example here at the university of some of the research we're doing in this area. Let me say a little bit about what I see as some of the major issues around security and privacy. But I want to add two others. Convenience of access as an issue. And then also, this morning, I think somebody mentioned, maybe it was Laurie mentioned it, the portability in terms of if you switch insurers, you switch health plans, etc., that your personal health record is yours. It ought to go with you. The electronic medical record that's feeding in some of that information, your personal health record, ought to go with you. And so that can create additional security and privacy issues, but there's also proprietary issues vis-a-vis health plans who might claim, well, we'll do all these great things for you if you stay with us, but if you leave, sorry, you don't have to take that with you. These are some issues I think we need to talk about as well. Some of the personal health record capabilities, let me just list a few that Jeremy Noble, who's a Harvard School of Public Health colleague of ours, has highlighted very recently. And I'm just going to mention a few of these. That some of the essential features of the personal health record now is that it be able to collect data of multiple types, including administrative data, claim-derived data, lab data, medication data, biometric device supply data, as well as self-entered data capacity. Secondly, that it be able to download this information automatically and without member involvement, so that the personal health record is to a certain extent automatically populated and not all information is self-entered by the member. The third characteristic is that the data be on a secure and easy to navigate website in a way that is simple and understandable to the consumer. Fourth, that link data to useful decision support tools that can reveal options and consequences of various health-related decisions and behaviors. So it's really a smart kind of thing. It's interactive. You can learn from it and move data around and look at linkages and relationships and manipulate it. Another one is that it should be able to be linked to various types of educational content and resource offerings, including condition-specific information, therapeutic options, available providers to treat your conditions, and the costs, the alternative costs of various therapies. To share, another one, share the individual record with the member's permission without the primary physician care team and other caregivers using the security key or some other method. So it's not just like, can the individual doctor, my primary care doctor, have access, but again, with chronic illness, it's a care team that you're going to be interacting with. So can any member of that care team enter? And, so what does that mean? Who's even a member of the care team? And you can't even keep track of some of the people you're interacting with. And finally, to track information that can be linked to reward systems that provide both member and the physician with the motivation to engage with the personal health record and interact with each other. So also, what are the incentives to use these personal health records with clear promised benefits? So these are some of the things I hope we can get into with the panel and with your questions this afternoon. Let me introduce the first speaker this afternoon. A member of our panel is Lori Evans. Lori is the Managing Director of Manat Health Solutions, Policy and Consulting Division within Manat. But most recently, before she came to Manat, she worked with Dr. Brailer, with David Brailer, in the government. She was his senior advisor. And if truth were known, Lori really did all the work. And let Dr. Brailer take credit for it. She's kind of the front person. This is the way I do it. So, with no further ado, let me introduce Lori Evans. Lori.
How's that? Can you hear me?
Yeah.
Well, good afternoon, everyone. It's a privilege to be here. I wanted to show you sort of a fun set of pictures that I think underscore why we're here today before I jump into my presentation, which is just sort of an old picture of a hospital in 1935, the view of a much more sophisticated hospital in 2006, the view of inside a hospital in 1935, inside the hospital in 2006, operating room 1935, operating room 2006, patient file 1935, patient file 2006. So what I'm going to focus on, and I think at 15 minutes, is that? Okay. Is I wanted to focus on some practical observations with respect to legal and policy issues. So in other words, what are the business and clinical decisions that need to be at the forefront of any health IT initiative before you really get to the actual true legal sort of counsel and advice that you would need. And then if there's time, I sort of wanted to throw out some additional considerations from a market development point of view, from a privacy and consumer engagement point of view, and I'll probably pass on the standard and certification because it sounds like you guys talk a lot about that. In terms of the things that are really going to have a big policy influence on sort of the health IT movement into the future, if we have some time. But Initially, I think really letting clinical priorities and a business plan drive sort of the legal scope and the legal priorities of health IT projects is something that I found to be really important as I've been working on the ground with a variety of different health IT projects. So the key issues to address and to think about are the following. What clinical problems are being addressed through the project and how? What are the sources of data? What are the uses of data? Who has access to the data? Where is the data stored? What are the privacy and security policies based on these clinical goals? How are these policies enforced? And what are the financial commitments of participating stakeholders? Very, very important set of questions to think about. And the point is, and getting to the practical observations is, don't start too soon with a lot of legal analysis and a lot of contracting. Really focus on developing the kind of organizational structure and decision-making process before initiating significant legal counsel. The scope of contracts that you'll be getting into need to align with the implementation stage and the implementation priorities, and securing funding that's commensurate with the business plan and implementation priorities is going to be really important. Next, don't confuse policy direction with policy realities, and I'll tell you what I mean by that more. And then if clinical and business priorities are clear, all legal issues can be addressed a lot easier. And I think that in thinking about interoperable health IT adoption, health information exchange, the electronic health record components, again, from a policy point of view, there is HIPAA, the level of HIPAA that we all need to deal with. As David was mentioning, HIPAA was never conceived for an interoperable world, and we need to move beyond it. But nevertheless, there's a set of analysis that needs to be considered with respect to HIPAA. There's also a set of analysis, and again, these are very critical pieces that need to be informed by the law. So there's the state law analysis as well, but then there's a whole nother level of policy that doesn't exist with respect to health information exchange and interoperability in electronic health records, which is around patient consent, around the role of the consumer and their rights to their information, how is information, what are the policies around information sharing once it's disclosed. And so there's this whole nother level of policy that doesn't exist yet. And a lot of initiatives are really struggling with how to do that. And I think some of the things that we'll be focused on next is this, this template structure that has gone such a long way to be able to lay out the kinds of business and legal issues that a lot of projects need to wrestle with. So it's sort of a great set of tools. I think some of the key policy issues, again, at sort of a bigger picture level, are what really are the benefits for patient care? What is the cost and who provides the financing? What's the return on investment? Who will have control? How does it impact the competitive marketplace? Is the technology ready? Can privacy and security be achieved? What legal barriers can be anticipated? And again, in the spirit of really focusing on what the clinical priorities are and being able to infuse the kind of process to answer these key questions are going to be a critical part of driving success in a variety of health IT initiatives. Now, moving to sort of some of the sort of policy and market developments, and sort of, I think, a summary of issues that I think are really going to influence how we make progress over the next coming years is really, how is this tension between providers and payers over control of infrastructure and access to information going to play out? Maybe we could talk about that in the discussion. The changing business plans of system integration companies and EHR vendors, getting to David's point about having more of a EHR heavy application versus something of a heavier network, and where is the application consolidating? How quickly will integrated electronic health record and health information exchange service be commercially available? And how will this change the purchasing decisions of consumers? This emerging national performance measurement system that the latest IOM report talks so eloquently about, including public reporting and pay for performance and pay for use, what does this really mean? I mean, I think a national performance measurement system is inextricably linked to health IT, right? That, in a nutshell, is the crux of the health information technology debate moving forward, right? We need the infrastructure and capacity to have interoperability and to have electronic health records, but we need the kinds of reimbursement changes that are very slow moving. And how do we do the ladder walk? It can't be a chicken and the egg problem anymore. But how is that going to unfold, and how is that going to impact our view on this? I think a huge piece of this is the state's role. What is the state's government's role in RIOs in particular, and the funding of health information exchange infrastructure? And what's their role as a convener? What's their leadership role? Should they regulate? Can they provide funding vehicles? Really sort of important questions about the state's role. Also, how the sophistication of privacy and security solutions, come to bear, and how consumers play a role in those privacy and security solutions. One of the most important things we can do in all of our health IT initiatives is build privacy and security up front, not only into the technical architecture, but also into the business architecture, which sort of speaks to the earlier point about sort of the practical considerations and the answers that need to be addressed from a clinical and policy point of view first. I think a lot of electronic prescribing and sort of the Part D management of drug costs is going to continue to swirl around and be a part of how things evolve. I think the aggregation of data and advanced research and analytic platforms is ultimately going to be what really moves the market. I mean, I sort of think that electronic health records and health information exchange is going to become a commodity. And what's really going to drive the market is how we are able to aggregate and apply data appropriately for widespread population health improvement activities, for pay-for-performance, and for a lot of the public health components. But that's a huge unknown. I mean, there are no policies around data aggregation and who has access and when can it be shared. And, what are all the roles and responsibilities of the players in that? Whole areas of policy that don't exist today. And I think the IOM report pretty eloquently sort of outlined the fact that we need a governance process to deal with data aggregation and then how we apply that data for so many things that we need, because that's when we're going to realize the true value of health IT. And I also think, as David mentioned, the AHIC breakthrough projects will also be something that we all need to watch, and I think will be a help as things move forward. I think just sort of some other quick considerations, again, related to sort of policy and market developments, is at what pace will the supply side of the health information exchange market really establish itself and become mature? We have these prototype national contracts, we have a lot of other pioneers that are moving forward with infrastructure, but how is it going to evolve? We have the certification commission that's focused on outpatient EHRs, it's moving to inpatient, it's doing PHRs. You know what? It's also supposed to do the infrastructure. It's supposed to do the nationwide health information network components. How is this case going to influence how we do things? I think I mentioned this ladder walk between infrastructure and payment policy that's going to be so critical. And at lunch we had an interesting chat about how the IHA and some of the other health IT work can come together to really start to give us more answers about how we do the ladder walk. And then the very last point here is, I think, being able to think about the impact of performance measurement and how we measure outcomes, how we report them, how we measure them, but then what the link is and what the tie-in is to evidence-based medicine, right? Those should be aligned to make sure we're having the right capacity we need to perform well and then to pay physicians based on that. I'm going to skip over this one. I think touching quickly on consumer engagement and privacy, I think, engaging consumers and guaranteeing privacy is the most important issue that we face today in the health IT movement. And determining whether there are adequate privacy and security practices and policies in place to drive health IT adoption. As I mentioned earlier, going beyond HIPAA, right? Addressing consent, opt-in versus opt-out, patient access, and this whole level of policy that doesn't exist yet. As I already mentioned, building privacy and security into the business and technical infrastructure is key. understanding how variations in security and privacy practices present unique challenges for interoperability. And I think a lot of the work that California will be doing as a state partner to the federal privacy and security contract is the very purpose of that is to get it at this suite of issues. And I know that that Cal Rio and others are involved with that. Object Health is, if those awards are being favorably. I think one of the key things is also really being able to monitor and assess and have the capacity to do that with respect to evolving privacy and security practices related to the various ways in which health information is shared, stored, analyzed, aggregated, and applied, and what the corresponding mechanisms are for determining that governance structure. And again, how consumers are involved with this. Huge unknown, a huge area of policy focus from my point of view. Understanding the role of federal and state governments with respect to RIOs and addressing consumer empowerment and privacy, as I noted. And then really, I think this is really key, is understanding how we as consumers, as Americans, feel about our privacy and the implications of all of our attitudes on successful innovation in healthcare. Right? I know in a lot of other industries, the increase in consumer demand has impacted how the sort of market drivers end up working. And in healthcare, we don't have that luxury yet. We don't have any consumer demand. So it behooves all of us to really focus on that piece of it, because I think ultimately it's going to end up, flushing out where, how things really end up working and what the inner workings of interoperability really means, and the Nationwide Health Information Network, and how the certification piece ends up working. And then I also think sort of determining where employers fit in, which I think is sort of a much bigger question, and I would word it differently now with respect to personal health records. And I asked David a question about that because there is a lot of noise, and there's so many models right now with respect to personal health records. Right, there's the provider model, which is more of the Palo Alto Medical Foundation clinic models and Kaiser models and so forth, clinically rich. There's the insurer model, based on claims data, a lot of issues around privacy and patients engaging in protective behavior because they're afraid of their insurers getting their information for underwriting and other things. There's the employer model, which everyone heard the Dell announcement a few weeks ago. Intel is building an employer coalition to try and address this. Lots of issues there too. There's the direct-to-consumer model, right? The Follow Me, what's the other one? Where Netum has a piece of that where consumers will enter and data themselves. There's the specialty vendor model, which is where I would put the Googles of the world, some of the decision supports, the Intuits, right? And then there's probably someone who could probably come up with another model, but it's very fluid, and I think we as consumers, I don't know what to do. I don't know what to pick. I mean, thankfully I'm a healthy person. My grandparents and my parents carry around their notebooks. They're thinking about, transitioning to the CAPMed portal if they end up rolling that out this week, where they can, start to keep track of stuff. But it's a piece that is really going to, evolve over time. And I really think the claims to clinical information framework with respect to the privacy and security issues that are being debated is going to be an interesting thing to watch. So I'm going to stop there, and I look forward to our discussion.
Can you hear me with this? Is this on? I think so. Before I introduce Alan, I just want to comment on one thing that Lori introduced that not all of you may be familiar with. She referred to recent IOM report. And what she's referring to, it's two reports out of 3 that are now out. And the first report calls for a national quality coordination board for the country that will make some sense out of all the performance measures we now have around quality of care. And there's, the National Quality Forum, and there's the HEDIS measures, and there's specialty measures ad nauseum. And what the report calls for is to say, let's set some goals for our country on quality. Let's agree upon a standardized starter set of measures, which builds on all the good work that's occurring. Okay, and this board will not replace these other organizations. It's not going to develop its own measures, but it will choose the best, the most reliable, the most accepted, and say these are the ones we're going to go with. And this will be what she was referring to, the national standardized performance and measurement system that everyone, nursing homes and home health and hospitals and the physician sector can shoot at in terms of the information technology that try to produce the reliable numerators, denominators, aggregation processes, build-in security, and so forth. So this report is out there. We can get you, access to that if you're interested. We'll see how much of that's going to be implemented. I can't help but it strikes me just as listening today around the IT and all the issues that Laurie has raised. We're in the same kind of evolutionary point that all the performance measures were in 10, 12 years ago. Let 1,000 flowers bloom, all kinds of models, all kinds of technology models, all kinds of potential business models, and it's very confusing. And I'm wondering if we can learn it all from how the performance measurement side apparently is beginning to come together to some extent. So that's something we may want to talk about further. Let me introduce our second panelist, Alan Briskin. Alan is with the National Health Law Practice of Davis, Wright, and Tremaine, based here in the city. He serves as member of the firm's Health Information Technology Practice Group. Alan's practice is focused on community health information exchange, network development, and network user information. He's a principal author of the book Connecting for Health Common Framework, Resources for Implementing Private and Secure Health Information Exchange, and Model Contract for Health Information Exchange. He's assisted numerous firm clients in structuring information exchange pilot programs for comparative testing of new technologies, flow redesign, and evaluation of patient authentication, privacy, security, and functionality improvements, including governance and organization surveys, and developing a model agreement for regional network connectivity. Alan Briskin.
Okay, first thing I'm going to do is back off the slides. It was I spent my entire career representing providers of healthcare services, payers for healthcare services, information control organizations, and not representing consumers. And when you start talking about the legal and policy issues involved in electronic patient records, the consumer's role is very important. It barely made it into the slides. And I recognize that as I was listening to people talk today. I can just put it on the list of things that need to be overcome as RIOs and similar organizations are set up. It's the fact that the consumer really, is off to the side, thought of often as an afterthought, usually the last party listed. We're talking about the essential players, and that's something which needs to change. The second thing, just again to go off the slides for a minute, is an anecdote if I can about pay for performance and adoption of technology. I think the effectiveness of pay for performance is going to be dictated in large measure by how much of the provider's compensation is going to be driven by meeting the measures. And typically, in connection with technology, it's a very small amount. There's often been not enough to modify behavior. There's an interesting development that a number of clients of mine are very upset about, which is that Blue Cross has announced that effective July 1, surgeons are going to have a 25% difference in the fee they receive for doing surgery, if they the fee they receive for providing outpatient surgery, if they perform it in a freestanding setting versus in an ambulatory surgery center that's associated with the hospital. 25% more to provide the same service away from the hospital. The reason, as Blue Cross explains quite directly in its notice to the providers, is that it costs Blue Cross less to have the service provided in the freestanding facilities. And that's not because, the letter says this, that's not because the services actually cost less to provide in outpatient settings, but Blue Cross has been able to get better rates. And that is something which we think is going to modify the physician behavior. It's a large enough number to have an effect there. And I think that needs to be used as a counterpoint when we talk about the use of pay for performance around HIT for influencing physician behavior. So anyway, back to the slides. What I wanted to talk about was an essential aspect of organizing the RIO, or another term which we're using is the SNO, or the sub-network organization. So the notion is a smaller organization, either regional or based on some other kind of affinity, that brings together data providers, data recipients, to facilitate information exchange. Because of the legal context in which this activity is going to be taking place, a contract is required. At a minimum, you can say, you can point to one thing, which is, if I'm a healthcare provider and I've got data, before I share it, I want to make sure that the party who's receiving that data is going to use it appropriately in compliance with law. There are many other issues involved in the contract, but that's the key one, and usually uses the first point for noting the necessity of the agreement. The conceptual point about these agreements is that they're multilateral. A bilateral contract is one between two parties. You and I have a contract, and I know that you're going to abide by certain terms, and that gives me a confidence required to behave in a certain way. But when we talk about information exchange, there are a number of providers, a number of participants I have to trust in this regard. I have to know that anybody who is going to receive the information that I provide is going to abide by certain rules, and I'm not going to have a contract with them directly. So the structure of the agreement is that each participant contracts with the RIO or the SNO, and one of the things that the RIO assures the individual data provider is that everybody who gets information from you has entered into this agreement with the RIO, and so that you know the terms that they've agreed to, and can adjust your behavior according to that. In addition, another complicating factor is that we note that many of the parties that will agree to participate in the RIO are not individuals, they're organizations, hospitals that will make this arrangement for members of their medical staffs or for the non-physician staff of the hospital. And we also have to know that the rules that are so important are going to filter down to the individuals who use the information. Finally, people are implementing these arrangements now. Before there's a framework in place that's going to link all the RIOs together so that my information can be available in LA if I have an episode down there. And so the contracts have to accommodate how we're later going to connect, create bridges among the organizations. When I first contemplated the notion of a multilateral agreement among healthcare providers, users of information, my first thought was, please just kill me now. Because I've been working in this field for a long time, familiar with the relationships and agreements and attitudes that the various players have with each other. And they're not collaborative. They're competitive. In some cases, they're competitors. In some cases, they're adversaries. In other cases, they view another participant as a source of largesse. In other cases, they regard a certain portion of the group as prey, someone simply to victimize, squeeze, and then abandon. In order to set up a RIO and create a legal environment in which information can be exchanged, a more collaborative approach has to be developed. So the other items I've listed here are challenges for structuring the agreement. I think the most important part of this is that there's a need for a common framework, terms that apply to everyone, to anyone who has access to this information, whether they're local to us or whether they're not. And then the need to take this common framework and realize that it doesn't apply, it can't apply to everyone in different parts of the country because of different needs. The most obvious need is the laws are different in certain areas. I, as I say, a holder of California information, have to comply with the California rules of it, and someone in New York is not going to know that. So for a common framework that applies to them, isn't going to include my California rules. And then finally, and it's often the last thing on the slide, is that there are going to be exceptions, and that certain providers' concerns are going to have to be addressed. So, as I said, the parties need to approach the relationship differently, and most important, I think, it has to work with both parts of the decision-making coming from the top down and other parts coming from the bottom up. It would be death to this process to handle the contracting for Rio the way that healthcare providers and payers manage their contractual relationships now. You have every provider bringing at least 2 lawyers to the table. Everybody working for, again, not speaking for the interest of physicians or of hospitals, but for my particular physician or my particular hospital. And secondly, with the notion that we all, as lawyers, and some organizations too, have very strong feelings about the right way to say certain things. And even if your way gets me 95% of the way to where I need to be, I really want that last 5%. That's an impulse that needs to be suppressed. And that certainly some organizations make that a very important part of their dealings with others, health plans are the worst, but they're not the only ones. In some cases, special deals will be justified, say, for example, getting a critical participant in the community to come to the table. And then finally, we recognize that in this environment, the terms start changing tomorrow, and we can't set up something that, if we sign today, we're going to be calling up tomorrow saying, okay, time to negotiate an amendment and start over. So we thought about coming up with a simplified process for negotiating large numbers of agreement, and that essentially is coming up with standard terms that apply to all, while allowing the flexibility to create certain exceptions, and coming up with a simplified process for making changes. By bypassing the traditional contractual negotiation standpoint, the way we think to make it work is to have stakeholders involved. They would then take the place of the army of lawyers that comes to the table to negotiate these contracts on behalf of everyone. I've tried to list here some examples of the participants who need to come to the table. Some critical points to make about it is it's not the same as the governing body. Usually, in our democracy, as applied to business organizations, you get a bigger vote if you have more money on the table. And for this process, it probably isn't best to do that. It probably is best to determine what the critical group is, who needs to buy into this, so that the parties, the individuals who are at the table, feel that they can trust the organization and trust the system and participate. Consumers, of course, are the best example of that. Let's see. Okay, so the concept here again is to develop, before we start negotiating with people, the common framework for national terms, the regional and local terms, and then in the specific data user agreement, presenting it as a final product and saying, just sign it here. It's not going to work in all cases, but it's something which is worth pursuing. And a lot of our work has been designed to address that and to try to accomplish it. Finally, needing to come up with a mechanism for amendments. As I said, things are going to be changing all the time. Here are some examples of ways in which things can change. The approach that I've been following is what I call the book club model, which is, I'll send you parts of my amendment, and unless you object to it, you're in. This is not something, this has been developed actually in California to a great deal in dealing with contracts between healthcare providers and the health plans. Basic rule is I can send you an amendment if I need to do it to comply with the law, and it applies whether you like it or not. If it's something that isn't required by law, but which modifies your rights or your obligations, then you have an opportunity to opt out within a particular period of time. And if you don't, you're deemed to have agreed with it. The only way we think this can work, again, is to have stakeholders participating on a continuous basis so that you don't send out the unreasonable or self-serving amendment. It causes lots of people to drop out. How am I doing on time? Was it 5 minutes? Okay, great. I want to summarize the legal context. There are a number of measures here. I think they're all familiar with what's happened in discussing, making discussions so far today. I've listed what I think are the network-wide issues that if we are going to set up a nationwide or larger network for information exchange, these are the topics which need to be addressed. And in particular, I'm going to talk about privacy and security for a moment, primarily privacy, because it is becoming recognized that HIPAA is not enough. That there are many issues it doesn't address, but it certainly doesn't create an environment around privacy that is going to get essential buy-in from healthcare consumers, and that a higher standard needs to be developed. We need to reach a large enough consensus so that we can truly offer it to people and say, this is the way your information is going to be treated, or else the consumers will turn and opt out of this. For the most part, what I'm seeing is that programs offered to consumers are going to be, in the initial phase, opt out. There will be the dual level of they can opt out from having their information listed at the RIO at all, and they can also opt out with a specific provider. So that, say, their mental health records wouldn't come in even if they participated with respect to the rest of their information. Okay, and then switching to the regional and local issues, the issues that have to be dealt with by the RIO or the sub-network organization. It's a fairly long list. I think that the key parts here is that the concept of relating to the common framework is that the common framework sets up the rules that everybody has to abide by. The RIO's rules can be more generous or more restrictive so long as they don't conflict. I think an example of that would be in connection with permitted and prohibited uses. Certainly, the clearest example, I guess, would be of in certain states provide different levels of protection for information pertaining to mental health or HIV or any number of other sets of medical information. That is something that might not be an issue in one state, would be an issue of another, and the common framework would permit the RIO to adopt that standard. More issues. I think the key points here really are the last three, which is really where we need to have the collaborative process where people are talking about this and these arrangements come in the open process. And then learnings. We worked to develop the common framework materials, which have been published within the last month. They're available on the web for free at connectingforhealth.org. But we had some interesting learnings from the people who had used these materials for developing their data user agreements and setting up their RIOs before the materials were released. And not surprisingly, lawyers did not come out well in this feedback. For the most part, I mean, certainly the first statement they made, of course, was that stakeholder participation was crucial, and that the composition of that group really was essential, and that the participants learned a tremendous amount during the process about what was important to establish it. And one of the final lessons then was knowing when not to listen to the experts, knowing when to modify the agenda, often to shrink the agenda and offer a bit less. Having materials like that allows them to leave their lawyer at home so that they can develop a business plan and other terms that matter. And in the end, when the lawyers get involved, having the client deliver a substantial work plan that sets the legal terms for this, and which encourages the attorney working on this not to act as counsel for this hospital, but simply to act as counsel for the deal, which is the establishment of the data user agreements that will bring providers and users and patients together.
Thank you. Okay, we're going to move along and introduce our third panelist, and then we're going to open it up for questions and discussion. Our third panelist is David Spellmeyer, and David is a research staff member at Almaden Services Research Group, really IBM Almaden Research Center in San Jose. Before he joined IBM, David was the Chief Scientific Officer and Vice President of Drug Discovery for Signature Bioscience. He has also worked at DuPont Pharmaceuticals, Combichem, Chiron, DuPont Merck, DuPont Medical Products. He has experience in the establishment and management of over 14 pharmaceutical partnerships, 4 mergers and acquisitions, collectively worth more than $160 million. He received his PhD in organic chemistry from UCLA. He's evidence you can do some things other than just organic chemistry. He followed that with a 2-year postdoc at UCSF. He's an author of over 35 scientific publications and was the launch editor for annual reports in computational chemistry. David continues his interaction with UCSF research groups, where he is also an adjunct assistant professor. David, welcome.
Thank you very much. I'd like to talk to you today about, we've been talking a lot about integrating electronic health records, and the research that I'm interested in and have been involved in is really to take the next step and say, this is going to happen. What happens when it comes online? What happens when we get a patient-centric, not a physician-centric, not a payer-centric, but a patient-centric electronic health system? Who's going to own that information? Where's that information going to be? Who's going to make money on that information? We know, in fact, that we don't know who's going to make that, but how can we study that? So we believe that patient-centric healthcare really is going to transform and create a variety of new business models. So a group of us inside IBM that involves people from the healthcare industry, from research, from our sales group, from our financial services group, and from our retail organizations are looking at understanding the emergence of retail healthcare, where consumers really are going to be the driver. We're looking at new healthcare information infrastructure. We're participating in the internet, in the NIHN prototypes, and healthcare information management. And in particular, I'm interested in the development of a research activity that can help identify those key market drivers that are going to help us move forward, and actually the inhibitors. And Ravi, I'm in Jim Sporer's group, where we're involved in the development of services science, management, and engineering. And why I joined this group is because I want to look at how services evolve from this. And the social, technological, environmental, and political are all aspects of things that we have to really research and understand. We're going to be working externally, not just internally. Interestingly, people do complain about IBMers talking to IBMers, but here we actually really need to work with people on the outside because this really is happening on the outside. So what's going to happen, and let's create a strategy, work with our clients to capitalize on those, and our deliverables are going to be new insights into those models and engaging in new revenue opportunities for related to those business models, ourselves or with our clients. So that's starting with research, but moving towards our clients. So we believe that there are, we know there are emerging healthcare business models that are out there. And the legal aspects that, Lori, I think you outlined, of some of the questions that need to be addressed in terms of the structure of how we come across policy and other things are going to be driven by these things happening and then us responding to them. So when you talked about letting the system sort of evolve and then come back through and help put policies in place, that is happening, and we believe that that is really how this is going to evolve. Retail healthcare is happening. It is going to continue to grow. Groups like the Minute Clinic, which are small healthcare facilities that are in stores like Target. Now Walmart is looking at putting those in. CVS is looking at those. You literally go into Target, you have your healthcare taken care of as long as it's not an acute, you wouldn't go there for a heart attack. But if you have a child who's got an ear infection and you know that you need a certain particular medication, you know you can do that. The benefit for the retail store is that they get you in the store and you can wander around and buy things while you're there. And the benefit to the consumer, and interestingly to the payer, because insurance companies pay for this, is low cost, rapid time, and convenience. You get to go where you know you can get to and get back to work. We also believe that information liquidity is going to happen as we're talking about putting information online. Right now, people hoard information. There are, in fact, a lot of drivers for insurance companies not to create a system where I can go from one insurance company to another. In fact, I suspect I've switched from one health plan to another within the same provider. There may not be an incentive for me to do that if there's a financial hit for them. We believe that that actually has to change and will change based on consumer demand, individuals demanding that that happen, that there be some financial driver. And there are a lot of different examples of where this is happening. One of the interesting areas are information banks. I think there was a question earlier about ASPs and whether physicians' offices are putting the electronic health records online in their own offices, or if they're using an ASP as the holder of those records. There are very good reasons why you might want to use an ASP. Those are, in fact, information banks. Those are repositories of those records, and the question is who owns them and who can use the information. That's the question we want to start asking. Interestingly, that particular case, those are not independent. Those actually represent the provider, not everybody independently, not the payer, not the patient, not the hospital. Incidentally, I was just at my dentist, and it scared me. He just got a brand new system, and he was really happy he was going to be getting DSL so he could actually, have everything online. And I asked him about how he was going to protect the data. He said, well, I'm going to have somebody come in and make sure we have virus checkers on it. That happened Wednesday. We believe that there's going to be an evolution of the current players or some unknown players that will in fact evolve into what we believe is the equivalent of, or actual health record banks, the equivalent of what we do with our financial services industry, where we have large repositories of information, but people actually put that information on deposit. Think of the personal health record, that all of the choices that we have today, but we get to choose where it is deposited. And that we can put information in different places. I think, Robbie, you talked about RSS feeds as a portal. I think that's a good example of how you might be able to manage your data. It likely will evolve from the current players. That's what happened in the financial services industry, but it may not. Apple Computer is doing really well today with iTunes. What happened, though, before that is that Napster demonstrated that people were very willing to move the music around on the internet. Something happened. Somebody showed that was an interesting way to do things. Somebody got really upset, and we created legal constraints, or we resolved some legal constraints. And Apple came along with digital rights management and created iTunes. What's the equivalent here? Is that a good example or not? I mean, that's going to happen. Incidentally, we keep talking about curative care here as well. I think we need to be prepared for something to emerge like that that's going to radically change our view of how healthcare happens. The music industry is still selling CDs. They're still dealing with things in the ways they used to, but boy, they're selling a lot of stuff online now. And it turned out that it wasn't that people were worried about Britney Spears not making millions on her new record. What people are paying for are things that are no longer out in the stores. Brand new business model. So we want to be there. There are a lot of analogies from the financial services and retail industries. These are consumer-driven industries. In financial services, the IT spend is 5 times what it is in healthcare. And the reason is that people will spend money to make money, and there's real value that's seen in that. We have to get to the point where that's the case in healthcare. We don't know exactly how it's going to emerge. We do know that there are going to be a lot of new players, and that, this is back to the service of science, we need to think about what's going to happen and study it before making prescriptions on how it's going to work. I mentioned I'm going to shift into some of the other things that we've been doing. We actually are one of the 4 groups that is working on development of prototypes for the NIHN. We're working with a variety of companies in implementing the information infrastructure for Taconic Health systems in New York and 2 in North Carolina. The whole idea is to make it clear that this is an example, demonstration, and implementation that's real of a regional health information organization. We've got a lot of people from across the company. It truly goes from research to sales and services. We just recently participated in Connectathon, and we participated with the largest number of vendors of any one of the providers there. And I'm not going to go into all of those, but We are working in an interoperable way with standards, which is fundamental to what we believe. We also believe that privacy, security, and confidentiality are important. We also believe that they need to be embedded in the systems from the very beginning. If that doesn't happen, it will not be a trusted system. So we've got, this is one particular group of technologies called the Hippocratic databases. There are a variety of different ways that we are working on implementing and embedding privacy and security in the systems themselves. There are 6 different aspects of that in this particular set. I'm not going to go into these because this is not my area of research. But I just wanted to say that we are, in fact, working very diligently. We do believe that privacy, security, and confidentiality are important. So much so that IBM became the first employer to actually have a genetic non-discrimination policy included in its non-discrimination policy. So we're very pleased by that. And with that, I will say thank you.
Okay, we're going to open it up for questions for the panel. Does anybody want to start off? At this point, I want to ask a question while you're thinking of your questions. And I want to go back to something that I think has come up this morning and maybe throughout the day. Given the realities of the market-based economy we are in this country, not the UK, the European countries, how do we come about getting to a reasonable degree of agreement or a tipping point on standards of privacy, interoperability, code development, the role of the RIOs, other possible new organizations that David has referred to, and so on. I think it would be very interesting hearing maybe a little bit from each of you, your own take on it, and how we push that along. I know, Lori, if you want to start and go to the right. Usually at Berkeley we go to the left. But there's no help. We got to go to the right. Right?
Well, that's probably, if we need to answer. Is this on?
I think it's on.
Try that.
Can you hear me? Don't use it?
The thing's on. I mean, I think it's picking up. Maybe this will be easier.
Oh, it's on? Okay.
Yeah, it's okay.
Okay, sorry. Well, I think if we knew the answer to that question, we all wouldn't be spending the rest of our careers and then some trying to solve the problem. But I think, I think understanding and maybe this is where I'll focus my comments and then pass it off. But just being clear about how the public-private partnerships that have been created and formed by the suite of federal contracts from David Brailer's office, sort of, how they fit together and what the inputs and outputs are, because I think that's one level of process that is driving the agenda. And, the standards harmonization group, the Health Information Technology Standards Panel, is clearly trying to create a capstone process for the SDOs to work together and make decisions. Now, that needs to be very closely linked to how the Nationwide Health Information Network prototype contracts are working and how they need to be singing off the same song sheet, which is why the American Health Information Community breakthroughs are so important, because they're providing that song sheet. The privacy and security solutions is another key piece, because ultimately I think there's sort of going to be a business and technical component that comes out of that ends up interfacing to the NHIN, so that privacy and security components, again, that are built in up front can be harmonized appropriately, so that one hospital that uses a biometric can continue to use their biometric, while the ones who choose the offices down the street that have a username and password can use their username and password, and that those can relate to each other and talk to each other. And then we have sort of the certification commission that's out front being more of the commercial push to all this in terms of driving certification and driving the development of the market, at least to the extent that health information supply doesn't exist and needs to be generated. And I think it's a complicated set of relationships and processes, and I can say that because perhaps we over-engineered it. But in any event, it's moving along, and they're really meant to be viewed as public-private partnerships. But at the same time, I think one of the other things that needs to continue to occur is all the other kinds of prototype work and community work and the work that Cal Rio is doing in particular that's really driving forward and looking to the kinds of tools that, you know, that are out there, and considering all the moving parts, being able to make decisions. And to go back to what David said earlier, make decisions, pick your standards, and pioneer, and push forward, and don't wait. Do not wait for this sort of, you know, suite of public-private partnerships and processes to give you the answers, because, you know, it's going to take a while, and, you know, I think folks really need to plow ahead on the ground and make tough choices and keep making progress.
I describe the process that Lori was just talking about as doing the hard work. Having the non-governmental organizations doing that will be a significant piece of what pulls people along. I think the tipping point is going to come when payment is linked to this. The problem, and I wish I knew the answer to this, the problem is identifying the payer who will do that, can do that. You know, the commercial payers, for the most part, are in competition with each other. I mean, notwithstanding the United Healthcare and the Anthem conglomeration, very often the individual payer won't have enough of a piece of the provider's compensation to actually be able to drive that compensation, that provider's willingness and ability to fund significant acquisition. You know, Medicare is, of course, the bigger payer. Medicare could, I believe, impose this as a condition of payment, user participation, and payment in the program. The challenge there would be to figure out a way to do that without dragging along the regulatory burden, both in substance and in the time it takes to get that done. And because of that tension, that's why I don't know the answer.
So you were asking about tipping points in terms of the standards. So IBM participates in a large number of industry standards bodies. In our implementation, we're working with standards to implement that in international examples. We, in fact, are working with Denmark, and we have a group in Haifa. We really are looking at international, not just national, but international standards, and we believe that that's really important. In terms of the tipping point, I think it cannot be underestimated the role that CMS has in this country. They can literally overnight change how healthcare is reimbursed and delivered. And people seem to forget that because we aren't, that our government isn't the single provider. It's not like in the UK or others, but CMS is a pretty big deal. So I think that those are examples, and I think David and Lori are right in terms of the getting out and using standards, but part of the sandbox you're talking about has to be that you're willing to cooperate with other people. There are groups out there who are not willing to do that, and that has to be gotten beyond. That's not really said.
Just to make one comment about CMS. Okay. Is about the CMS side is in addition to what Alan just pointed out, just the modernization effort that CMS has to go through to execute is enormous. I mean, it's just from a very practical, operations point of view. And they've been doing that, and that's still a large part of what they're working towards. But adding that to everything else is pretty significant. And I think timing-wise, a lot of people are speculating on when is CMS going to have national authority to change payment policy. And the MedPAC report, the last MedPAC report that was the November 2005 report, basically called for Congress to give CMS that national authority and begin with paying for public reporting and then pay for use and then pay for performance. And, most things that end up in a MedPAC report end up in legislation. And CMS, has publicly said they support this MedPAC report. So, that's leading people to say, well, maybe in 2 or 3 years CMS will have this national authority.
Just to add to what Lori has said, and cause for hope, for optimism, the third report of the Institute of Medicine series that's been referenced earlier will be coming out this coming July or August. And I've had the opportunity to serve on this committee, and to spend a couple hours last night reviewing one of the chapters of the Pay for Performance report. And CMS through Congress is the contracting body for this IOM study. And I think it'll be along the lines that Lori has suggested in terms of what MedPAC is recommending as well. So to be careful, because with IOM reports you can't say very much until they're released. But I think there's little doubt that CMS wants to step up to this. They realize they're the big gorilla in the room, and there's a lot of experience beginning to happen quickly in the private sector. There's 107 of these programs in the private sector, pay for performance, that the commercials are doing. We have one big one here in California. But you have to be very, very cautious, because financial incentives are a very important part of all of this. But there can also be a lot of unintended consequences as well, which you reward, that can harm patients and can have reverse effects. And those are things that this report will document, and how to be cautious, how to learn as we go, how to monitor, how to make midstream corrections quickly, etc. So that if and when CMS sees fit and gets the authority to pull this trigger, it will be done in a way that will promote what we all would like to see, and not some potential negative consequences as well. So I think in part what all of us are saying is yeah, I mean, we have this capability now, but there's two other pieces of the puzzle. The financial incentives are one, and the other is the public reporting, the visibility and the transparency. And I have to tell you from our own experience here in California and elsewhere on the provider side, what really gets movement is not the amount of money. In fact, in pay for performance in California, the first year or so was only about 2%, okay, of the physician's total revenue or income for the year. It probably needs to get to 5 to 10 or some of the national estimates to really get people's attention. But no one wants to see the name of their medical group on the webpage or in the Chronicle the next day or wherever it is with only 1 star when the group down the street has 3 stars. Never mind the fact that consumers, for the most part, aren't reading these things yet or understanding them or voting with their feet. That may come. But boy, the providers are really moving. They want to change their behavior, how they're managing the diabetic patients, etc. So I think that's the third part of it too, is the public reporting. So if you get those two in place, along with what we've been talking about here, I think we will get some traction. And then if you can get to the shared rewards kind of thing, I think we were hinting at, so that what's in it for the provider, what's in it for the patient, what's in it for the health plan. And so maybe they share in some of the rewards from having really good data, IT systems that can aggregate valid data, et cetera, that CMS indeed then starts paying for better quality. And then that has a positive reinforcing cycle. Let's make the data even better. Are there other kinds of systems that will do this more efficiently? Because there's really a carrot at the other end. And then the other thing for CMS to decide among all the sectors that they pay is, do you make this mandatory from the get-go? Or do you recognize that healthcare is very complicated and some sectors may be ready for this and you say it's mandatory, maybe hospitals, home health, nursing homes. But then you look at the physician sector, which is really terribly, terribly fragmented sector. They're not there yet, frankly, and some of this stuff is expensive, etc. So maybe you say something like, well, it's voluntary for a period of time, perhaps. You all have to pay in, you take it out of the Medicare stuff, so you're all, it has to be budget neutral, these rewards. But after 3, 4, or 5 years, perhaps, then it's expected to be mandatory. So it'll give you 3, 4, or 5 years to get up to snuff, get the IT, et cetera, et cetera. If you want to leave money on the table, you can, but others are going to grab it up. So if you don't want to even play, that's up to you. So we'll see how that plays out. But let's open it up out here. Questions? Mesmerized? Awake? Tom?
Could I ask for a little more clarification of why HIPAA is so inadequate for the interoperability age, and
what people see as a direction to go in that would fix that problem.
I think it's Sasha's key.
It's on that.
Yeah.
It is, okay. HIPAA permits use and disclosure of protected health information without the patient's consent or authorization for treatment, payment, and healthcare operations. Those are three very, very broad categories, much broader than most patients are willing to accept when they start looking at the specter of their information being transmitted electronically to a potentially unlimited number of participants. Unless you, what's been found so far is that unless you start narrowing the ability to which the information can be used or disclosed, most patients' attitude will be, no thank you, don't want to participate at all. And HIPAA was designed. This is a good part of HIPAA. Once you put aside the fact that it's interfering with interoperability and information exchange rates, that it was conceived without that in mind. It has this. And I say this from the perspective of one who works with providers and payers. This is great because HIPAA doesn't get in the way for what our core business is, but that doesn't translate to the public trusting organizations to use their information for the business that they do. Insurance companies is the sort of clearest example, but it even goes beyond that of, in some cases, not wanting to have, one physician that you go see know what's going on with another when at least the patient sees it as being, unrelated disciplines. Rightly or wrongly from a healthcare standpoint, people do feel that way.
Yes, Dan.
So I can tell from your response that the privacy rule has become synonymous with the term HIPAA. But actually, the administrative simplification has a bunch of provisions, some of which are quite useful, like the X.12 standards for billing and the provider identifier. All that stuff actually is, in fact, the stuff of interoperability, and it works pretty well. And unfortunately, the specter of the privacy rule and the concomitant specter of the security rule have overshadowed the fact that HIPAA actually has some constructive, useful stuff in it, and that is running well and does contribute to interoperability.
Well, from a consumer protection standpoint, some of the things that HIPAA prohibits are good things to prohibit. There was certainly, a lot of, I believe, misuse of medical information happening in states that didn't control it.
And I think the other pieces, there's sort of two pieces. One is, consumer organizations or some of the PHR models that are developing don't, there's not a designation in HIPAA with respect to consumers and their role, and that's a big problem. But I think getting back to the privacy and security rule is that, at least in the security rule, for example, there are so many choices you have to be compliant with the security rule, and then within those choices, there's no, instructions about what you have to do to, comply with one of the 4 choices you have in any given area. And that, in and of itself, when you're talking about multilateral arrangements and multiple partners in data sharing, which is, the heart of interoperability, you can't, you need to reconcile and harmonize that because you're going to run into barriers to achieve the portability or the interoperability piece. And maybe that's okay, it's just, it needs to be addressed. And in the near term, that's sort of the spirit of having people come together and really talk about privacy and security solutions. How big is this variation with respect to with the security pieces and the privacy pieces? And then based on that variation, how do we solve the problem? How do we solve the barriers to interoperability problem? And sort of as more of a, I think an assessment that needs to be done, and then based on the solutions, we'll see how it shakes out. But I think, at the end of the day, that still doesn't address the issue of consent and the issue of the role of the consumer and how inadequate the public feels. Those, basically what we have today doesn't guarantee the kinds of protections that people seem to want.
Yes.
So this question, I guess, for David, in looking at the different business models that you've been doing, do you have sort of a sense of timeline? Because the reason is that, as was observed this morning, I guess some of the inhibitors just had to do with the psychological hurdle of sort of different people in the ecosystem adopting this, whether it be doctors or wherever. And I guess earlier the Healthion experiment sort of showed that I guess there was significant resistance from I guess certain parts of the medical ecosystem. So.
Yeah, of course, you're asking about timelines. I think that, we've heard...
And maybe key inhibitors or hurdles with you.
Well, we heard a lot about inhibitors for adoption by physicians earlier today. I mean, there are many of them, and they are large. And I agree, I think that the real trigger is going to be some financial incentive. Something's going to change that will make it so that zero is not cheap enough. Something's going to have to change, whether it's a more rapid processing, it's a more rapid assessment and understanding of all aspects of when a patient comes in, how do you rapidly identify what the copay is, where their eligibility is, whether they've got secondary coverage, all of that. If that happens instantaneously and somebody pays for it, that may actually tip the game. But in terms of other business models, some of those are happening very quickly, and some of them are going to happen very slowly. I think we talked about the fact that it's going to take a decade or more for a lot of the electronic systems to really become fully adopted by even some of the smaller physicians' offices. But what's already happened is that SureScripts is already online and transmitting electronic prescriptions between something on the order of 60% of all of U.S. pharmacies. That happened, and that company was formed in 2001. So that happened pretty quickly. It was a very specific business model that they went after. There are other business models that are starting to appear, and they're being tested, like the Minute Clinics. It's not; those are all private organizations at this point. It's not clear what the real financial drivers are there yet, but they seem to be successful. And so when those start to get replicated, I think we'll see that adoption happens pretty quickly. A completely different area that's consumer-driven was LASIK eye surgery. It's the only example of any healthcare delivery which, since payers didn't pay for it, was a consumer-driven, high-dollar value, low volume procedure. That the first it was $5,000 an eye, and you got a 60% success rate. Today it's $500 an eye, and it's a 90% success rate. That was completely driven by consumers. So those are the sorts of business models that I think are going to change, and timelines are going to be different, whether it's consumer-driven or some other adoption-driven. I think that paying attention to that and seeing them evolve, we're going to get some sense of the timelines that are necessary. So it's a long-winded answer. I don't know what the timelines are. Nobody really does. We need to pay attention to them. Some of them are going to be short, some of them are going to be long.
Just on the physician side, currently about 15-20% of physician office practices in this country have some IT functionality. It's just some. They're on the radar screen. And it hasn't changed much over the last 5 years. There's speculation that with some of the things that are occurring, it'll speed up a little bit. We probably have a long ways to go there. One thing that may help is the Medicare Quality Improvement Organizations. There's one in each state. The QIOs are funded to give free, at least in dollar terms, not in terms of opportunity cost of one's time, technical assistance. And the IOM report has indicated that the QIOs are focused laser-like now on quality improvement, the information technology infrastructure, helping providers being able to aggregate reliable data, and in particular, targeting those in underserved areas, rural areas, smaller physician practices. So that might help a little bit on the TA side. You still need some of the financial incentives as well.
May I ask a follow-up question, actually, what David was just talking about? When I was hearing you describing the business models, the word that came to my mind was specialty. That it seemed, certainly for pharmacies, like the Minute Clinic, the scope of the information involved is much, much narrower than in acute care, than in physician care generally. Is that going to be an important piece, do you think?
Yeah, I would actually call that slightly differently. That's market segmentation. And each part of the market then requires smaller bits of the data. you still have to transmit it interoperably with standards. This actually gets to a point that you made earlier about interoperability isn't just about the electronic health records. The ATM system was interoperable as long as you're within a bank, and eventually consumer demand said, we really want this to be interoperable. Last year I was in Costa Rica and in Novosibirsk, Siberia, and I got US dollars out of both ATM machines. Paid a little bit for it, but it happened. So the interoperability and infrastructure take a lot of different roles, and we need to keep in mind that so when a Minute Clinic goes in there actually is IT that goes in behind that. And it may actually be standards we already know, TCP/IP and other things that are already there. So yes, in fact, it's smaller bits of specific kind of data. I think that can be handled as smaller bits. You don't have to have the whole package. More largely, I think it's market segmentation, and that's where, as the information comes online, we're really going to start to see some changes. The question becomes, do insurance companies start to look at market segmentation for consumers in a different way or employers in a different way than they have in the past with information that's available in some way? So that's where I think the retailization of healthcare is really going to change healthcare.
Yes, Christine.
Yes, I wonder, and this is a question to all of you, is the legal fears from the medical profession encourages electronization or computerization of the overall system, the relationship of communication between patient and the healthcare provider, or it inhibits. I can think of both ways. The inhibition can go, the rationale could go that one is concerned that more electronization or digitization, more proof you have of some problems that you didn't pay attention and therefore the patient died or got injuries. On the other hand, the pro argument could go that, and we see that, for example, you have doctors prescribe more radiological images frequently just to protect themselves. MRI scans and CT scans and so forth and so on. So what's your take on that?
Since I have the microphone, I'll go first. My father's a radiologist, and he's a little sensitive to that last one.
I am sure.
He used to get woken up in the middle of the night for real emergencies, and
yes.
He's retired now, but near the end of his career, it was very frequent that whoever was on call got called. In all honesty, I think what you're seeing is that we're in a transition period, and because of that, we're going to see some rough spots. When I talk to individuals and doctors about, are we putting all the information into an electronic health record that would go onto a paper record, I'm not sure, but I also understand that not everything went on the paper record either, for legal reasons. And so I think the argument about one or the other is simply because we're in the middle of a transition. I mean, there are still people who insist that the only way to listen to music is on vinyl, but the vast majority of us use CDs, right? I mean, it took a while for that transition to happen.
What?
Sorry, I'm not.
What was the comment? No, what was the comment?
He's catching up.
For my take on that, physicians are particularly concerned about liability, and I would generally say they're over-concerned about it, seeing it as more of a barrier than it is. However, I'll admit I missed the presentation where this stuff was talked about, so I don't know if I'm repeating something that was already said. But having this information available will change the standard of care. And a lot of it, those of us who aren't physicians don't want to say how it will change the standard of care because we don't feel qualified to do it, leaving it to physicians to figure out. And I think at this point, there is a big lack of certainty where the problems, the potential problems are all stacked up. The different scenarios that lead to horrible outcomes. And I don't think answers have started to be developed yet. And I think until that does, until we can not tame the beast, shrink the liability beast, the physicians are going to be very resistant.
A simple example is I work in a facility where clinicians are trained to assist them in becoming researchers, medical doctors and young graduates. One of the functions of some of our staff is to teach IT skills to this group of people. And we, as instructors, will be confronted with whether we are violating the HIPAA, privacy, security, protection, in teaching some of these software applications. I mean, that's the first question. If we are not able to answer that we are actually within the rule of the HIPAA, then we can't teach it. So we are confronted again with another dilemma of whether to teach them IT skills and move them a little beyond what they already know, or not teach them at all.
So there's an example actually of HIPAA being blamed for stuff which is generally people just not understanding it, and it takes, in this case, ignorance takes the form of paranoia. Because in fact, treatment, payment, and operations easily allows the scope for all of those things to happen without any concerns, but it has sort of put the fear of HIPAA in any movement of person-identified health information. Everyone suspects that, oh no, this may be a HIPAA violation. And I guess it just says that the educational bar has risen quite substantially, and most folks haven't really risen to that level of actually understanding the terms. And it's unfortunate because the net effect is we stopped doing things that are quite useful as a community, not really knowing for sure that it was a HIPAA problem, but just scared that it might be.
Well, this perhaps points to an importance of education, generally speaking. I belong to a generation like your father that I remember when the first digital CT came about, that my colleagues sat in the hospital would print it on a film so that they can look at it through the windows.
In fact, then they would get large numbers of monitors. But they used to, they'd expand out the monitors.
Right, because that's what they were trained.
Yeah. Last question, perhaps in the back there. Yes, sir.
Yeah, can we expect that somehow an emerging IT service provider industry will take over the liability beast from the healthcare providers?
It's really worth repeating the question.
Yeah.
You want to
Are you saying will the IT...
So that there is a new IT service provider industry emerges, which takes over this whole liability issue from the healthcare provider.
Oh. You should get our friends from IBM.
That's Microsoft.
No, our friends from IBM, perhaps.
Oh, I'm sorry, IBM.
You guys probably can answer that a lot better than I can. I sort of wanted to come back to your point for a minute that may relate to your question. But I feel like, I have been successful in bringing along those that are opposed to health IT from a privacy point of view by, just sort of describing how it ultimately would be a lot more private and secure because, granted, there's been lots of examples in the press lately about hacking and records getting out of hand, but at the end of the day, everything is audited, everything is trackable. And it's not inescapable. And your records are driven in taxis across town and can be pulled from records without, any trail and so on and so forth. So being able to just paint the picture of sort of the auditing and the tracking and the kinds of consents that you can track, the ways you can give consumers. I mean, one of the things that consumers have found the most interesting in those that are using portals is the ability to see who has viewed their information. And is part of the whole sort of transparency movement. So I think that has been successful for me in trying to, sort of discuss the differences. I think related to the liability question and the health information providers, I think for me that raises an interesting question about how, RIOs, in my mind, are really policy and business organizations that actually help set the policies and determine the rules that address that very concern, but yet there are technology service providers that actually do the day-to-day technology operations and auditing, and there's there's an oversight relationship that takes the fear and the issue out of the doctor's office.
Right. And that was the question. So I guess the question is there sort of a market pull for someone to provide those services as health IT services, and then, as Dr. Grela was talking, have that be part of the forces that drives the notion of standardization? I mean, I think, so what I'm surprised about, you're answering this question, we don't know when, isn't there is probably money to be made in this health IT services, and so why isn't that driving it?
Yeah, well, I'm a little biased in it, but I think there is too. I cannot actually address the liability issue because I'm not an attorney, I don't know. What is happening though is, as we talked about, practices are using ASPs. They're using small groups that actually hold their data. There are reasons for that because of the backups, the reliability, all of the business continuity services are provided by a different group. Again, back to my dentist, I'm really concerned that he's not doing that. Another group that's actually doing that, there was a group over in Marin that was literally the group that did all of the transaction processing for doctors' offices. Doctors went to them and said, will you hold our records? So there's a financial provider that's doing that. So I think that the answer is yes, there's a lot of money to be made in this field. The question is, how do you define the contracts? How do you define who owns what and what liabilities and what responsibilities? That's way beyond chemistry for me. But I think we're going to have to actually figure it out.
It's really hard.
Yeah, right. But I do think that that's why I think health record banks as an independent entity, repository, whatever you want to call them, they're basically repositories of information that represent consumers, payers, providers, everybody, labs as independently as possible. This is back to your point about getting the attorneys to actually represent the deal rather than each one of the parties. That's the equivalent of what a health record bank is. We've seen them emerge, but they're not yet independent. We'll see if that happens.
Alan, last comment?
Just a couple of points on liability. Liability belongs with the person who's able to control the risk. If you transfer that, if you have someone else assume the liability, you're just buying insurance. And it's not any more economic, it's not economically any more efficient. And you're paying for it one way versus paying for it another. I think for the most part, when we're talking about physician resistance to HIT from a liability standpoint, is they're not so concerned about liability that arises, say, from a HIPAA violation, because that really is quite theoretical. More concerned about having this information available, having information available is going to change the way the physician practices medicine. And the rules, unfortunately, this is the way our system works, the rules regarding what is the standard of care and how much are you liable for are determined retrospectively. It's after somebody gets killed that we figure out what he should have done.
Yep.
That is conceptually frightening to the physician, looking at it both from the point of the care of his or her patients and also the insurance premiums. That's very frightening.
Yeah.
But there's no money to be saved by having someone else come in and pick that up. That's what the malpractice insurers now do.
Let me just sum up if that's possible at this point. 3 or 4 takeaways that just registered with me. What Lori said early on about building in privacy and security up front, really critical for figuring that out. Alan's whole theme of his talk really was the importance of working out these multilateral agreements. Some very valuable tips and suggestions on what needs to be done there. And then what David said, he said it again, it's come up with the question of these health record banks and the opportunities there, and also this whole notion of information liquidity. And I said earlier on the portability, and those kind of go together. And then I think the overall discussion we had about how what we've said here, the impetus to move this forward is going to come from CMS, from the big payers in this country that are going to implement some of these financial rewards, and the public accountability is going to begin to drive this, I think, towards the tipping point, perhaps even a little bit sooner than we might imagine. So please join me in thanking our panelists. It's a break. We have about a 15-minute break now.
There's coffee and cookies and something outside.
Yeah. All healthy. All healthy.
See you later.
Well, you know, CITRIS headed up the report on the last month, and that was one of their recommendations. But currently, we're funded by Medicare to work with specific providers designated for paramedics, and that doesn't include the community, federally qualified community health clinics because they don't bill Medicare, right? So. I think the IOM is called for expanding of our mission, expanding of our scope beyond that narrow scope that Medicare. We, as within our mission and within our vision,
You're a concept. I am.
It's similar to
We want to see what's being done already by the highlight
Well, yeah, tiny modifications.
Well, virtual reality is one example. Another one is example to show you the same where machines I've got a person at the gas tank.
So it was a brand new concept. Yeah,
Well, if anything develops,
They work in the other administration.
great model for a scalable approach to diverse population, geographic distribution that actually have the only one by one.
Great to meet you. Yeah, nice to meet you. Take care.
I will have to share class.
Oh, yeah, I
Try to feed it into the conversation. Yes, please. Give him your feedback. I live in Omaha.
But I'm very interested in patients.
I live in Rhode Island.
I have 6
They're very expensive.
That's why actually they just all these.
Right, all knowledge recommendations.
Hey, Lee has
Oh, so I think portals are potentially very useful. I mean, I find it very frustrating. Actually, the only way I can see my medical records is to make an appointment.
little more oxygen. People are like they, yeah. It wasn't like there was a heavy lunch, you know. So
Right.
I'm just going to reach behind you folks and get some. All right. Do you mind if I open the window?
Very, very interesting.
Well, those are the ones who seem to make things happen, right?
The sun never says it.
But I'll be around to the end, so you'll.
Yeah, I gotta take off, but thanks.
Yeah, we'll be in touch.
No, nobody's doing anything. Everybody's
All right, bye. Thanks. Just do a little housekeeping for you. Take care of you.
Oh, did you? Oh, okay. I mean, this is me, makes personal
Well, I don't live too far.
Oh, I think-
I live in Oakland. So.
I lived so far away that maybe a year ago, so.
Right. Well, yeah.
Actually, if I leave,
I know. I gotta work out all my schedules.
Really try to get with all the
Right. That's all. Yeah.
wine country weekends.
Yeah.
It's a boy, more people come to your neighborhood than go to Disneyland now.
Is that right? No, it's more than this.
You had Sonoma plus back. That actually makes.
I'll email you before our meeting, because you want to know this.
Not that anyone falls on me, but
So I'll
still.
email you hospitals this week.
I'm sure you do better than
Well, I'm
That's right.
All right, thanks a lot.
I have a toddler. I think
Oh,
we're
yeah.
going to Disneyland more.
Yeah.
Big problem.
Joseph Phelps versus Disneyland, I think it's Disneyland.
Yeah, exactly. Although, God knows we could use the wine. Nice to see you.
Bye-bye. Yeah, nice. Did you bring them out?
Because it doesn't matter where you have to
Here they say, here. I just don't know how to do it. So maybe you yeah, sure. Yes. Yes.
Do you know my husband, Sashi? He's from UC Davis and he's with CITRIS.
Oh, okay.
Yeah. So anyways, I'd like to exchange cards with you.
Okay, sure.
This has been very, very interesting.
Oh, somebody wrote. Okay. All right, never mind. I can give you this.
Okay.
Because I don't get any other. Okay, good. Thank you very much. I'm not a director, so.
But this is still your communication.
I have a very good feeling.
I have been here only 5 years.
No, I wouldn't, because I thought maybe you were yours. A friend of mine's on the faculty. Business school, which is in public college. Oh, so you had
I used to be at University.
Tampere.
Oh.
University of Chicago, right?
Wow.
But my good friend Ruby's teaching me.
I know.
He was my
Yeah, we went to San Diego. That's what I thought.
And then I was studying connections.
I just thought, that's it. Oh.
No, it's, I'm with Stanford. But I'm a novelist. You gotta go in for my next meeting. Yeah.
Hi, Richie.
Yes. Trying to do with numbers.
Oh, I was just wondering what we're doing. We just got to get the order on that.
Yeah, I have John Kenny, I have CITRIS, I have organizations and because I don't have a, you know, I do zoning work process.
Those studies are all but there's small lists of others who do. It's getting more and more popular.
That's what I was hoping.
So the first time, first time doing. Oh, really? Yeah. There's not that much out there.
Yeah, I know. Just all I know is, all I'm hearing is about EMRs.
But you need to have numbers.
Can you sing? Can I sing?
Well, that's a great singer. It's like a good time like this, you need somebody to sing.
Baritone?
Yeah, somebody to kind of it's falling asleep.
I have a cold. Yeah. Oh, I'm sorry. I'm a little bit sick, so I shouldn't say. Yeah. Yeah, we talked. Yeah. You went? I think yeah. I don't know. I told a course, well, you know, so to say, I'm trying to actually is to I told a course twice semester now. So take the steering wheel, look it up. There's, you know, have more projects yourself, and that we like to probably do more actually. Sure. You know, there's a little bit of doing actually projects that are relevant. There's some complicated I'm hoping in about a year we will try harder. I think we're going to see. Oh my God. essentially it would be speech transcripts. This is use a little bit of context information so that the complexity of the resolution is a little bit narrow. Really complexity, this gives me a recognizable as either a general medical vocabulary or sometimes an area-specific vocabulary might be a sort of histology vocabulary.
Oh, I went to the time with the
but it's usually not case-specific, and so we like to follow sort of caseology. No, I'm still using language models. Just using those models, probably using mixtures of those models. So you can mix those models. There will still be an anagram model that's still nice to evolve, but and it wouldn't necessarily be a strict kind of text. That was basically language models. It would be typically when you have evidence or that we know something about a patient, it's not necessarily that they have this condition. Like they have this condition with 90%, 5%, etc. So probabilistically, you can blend all that together and now still, in a sense, the grammar was probably a problem to say, but its complexity was considerably narrowed. So in principle, normally narrowing that will help recognition forward. Yeah, and in typically, if you have some case knowledge for the patient, which we might either try to get medically, or we might simply use language that what is the steps for that patient. So that's what we take from history, but history goes through a conversation. So your slides are
I mean, I'm trying to think of this room for a few minutes, but yes.
So good afternoon, everybody. I appreciate those of you who stick around to the bitter end. We had a very fruitful and challenging day, and the last session is on secure technology for electronic health records. Well, we have 4 participants on this panel, all very distinguished, who each have done considerable work in this area related to technology as applied to healthcare, privacy, security, reliability, which hasn't been mentioned very much, but if you are not going to have a reliable technology, I assure you, doctors will throw it away. So reliability is very important. The first speaker is Professor Janusz Stepanovic from Computer Science and Electrical Engineering professor at Vanderbilt University. He runs and supervises and leads an institute for software, ICE called, for software and integrated systems, and which addresses mainly a foundation of systems, model-based system design, integration, and he is leading an effort in collaboration with Dr. Dan Macy's, who has spoken here this morning on the initiative of My Health. I think I will introduce all the speakers so that then we can just go through and they each will give they are charged with 15 minutes of presentation so that we have roughly about half an hour for conversation. Next to my right is Professor John Mitchell, Professor of Computer Science from Stanford University, who is the Murray and Gordon, excuse me, I am one of the elder tech, so I need my glasses. Murray and Gordon Crary Family Professor in Stanford, and his research in computer security focuses on trust management, distributed access control policies, and security analysis of network products. He has worked, he's well known in programming languages, analysis and design, formal methods, that's how I know him from some times ago, and other applications of mathematical logic to computer science. He is currently involved in multi-university Portia, P-O-R-T-I-A, research project to study privacy concerns in databases. You heard that what's coming are these large electronic databases, so his research is very relevant to that, and information processing systems, and now recently he and I are, as with many others, are members of the National Science Foundation Science and Technology Trust Center. He is the author of over 100 research articles and 2 books. And I would not even dare to read what he will say because he can say it much better than I can. The next to him is Professor John Kenny, who is a professor and colleague of mine in the Electrical Engineering and Computer Science department here at UC Berkeley, working in human-computer interaction, information retrieval, IR, retrieval and privacy. He is a professor of, he owns a chair of Paul and Stacy Jacobs Distinguished Professorship. His 1987 PhD from MIT received the ACM Distinguished Dissertation Award. His publication spans through computer. He's a really multifaceted researcher in computer vision, robotics, cryptography, information retrieval, human-computer interfaces, and CSCW, I don't know what that stands for, but anyway. He will talk about, he's interested in to facilitate design of next generation user-centered location services. His approach is a technology probe, a deployment of phases with extensible functionality directly into the hands of users using Qualcomm Subtrack GPS. The user interface is a simple, non-verbal model that allows a rapid prototyping of new services. At the back end, he uses a novel native XML database that allows a variety of metadata to be managed. And the last but not the least speaker is Dr. Michael Eklund, who has been the main organizer of this symposium. So it's perhaps very appropriate that he can conclude this symposium, although we have a person, Dr. Rami Memana, who will be doing the summary and conclusion. But anyway, Dr. Eklund received his PhD in controls theory from Queen's University in Canada, and he has been a postdoctoral fellow for almost 3 years here in UC Berkeley, and has been very much hands-on, involved in building an architecture for integrating these sensors on people and in environments, and the architecture that he will speak about. Okay, so after this introduction, Professor Stipanovic, the floor is yours.
Thank you, Jana. I won't use the 15 minutes. Let me just talk to you a few words about my be here? Okay. Let me just tell you a few words about what we are doing in this area in trust and some thoughts that I got during this meeting and the last two-day review meeting, what we had with NSF regarding the trust program. I'm sure that Shankar in the morning introduction talked about generic trust and what we are doing, and you know that trust is organized along different integrative projects. One of the integrative projects is EMR, electronic medical records, which was a very lucky coincidence. We had a meeting with them based at Vanderbilt last December and came together and matched their research program on medical informatics and particularly the patient portals and trust research goals, and it was clear that there is a good match and we will cooperate. We established a nice set of technical challenges that are that clearly showed us how rich is the problem and how much we can do in trust to address some of the technical issues. These challenges stem from access control, and I'm sure that John will talk about it later, that relates to EMR, data privacy issues, distributed trust management across different healthcare providers. My group's particular interest in the whole area is specifically information architecture modeling and analysis, with the unique problems that are brought about by the technical and organizational heterogeneity, which is in this area, the huge role of legacy systems that are present in the healthcare provider environments, and of course the overall scale and complexity. And we were also talking about, and it came up in this meeting several times, the interesting societal impact of patient portals and the whole area and how it will change healthcare in the future. Now, coming back to this issue of heterogeneity, even in these little experimental setups, what we are doing, we see that many different kinds of devices and networks are linked together in many scenarios, from sensor networks to wireless communication networks to wired internet network. There is a number of devices, databases, computing infrastructure which is used, and all of these are sources of a variety of vulnerabilities that arose on all levels. Obviously, the challenge from a technical point of view for us to clearly understand these vulnerabilities to provide security. Now, if I look into aspects of it, how can we address this? It was really interesting, that discussion for me, what we just heard before. So if these kind of heterogeneous infrastructures, information infrastructures has to be offered for healthcare providers, is it possible that a business model emerges where some information service provider industry will offer these services? The first question, of course, is that some kind of contractual interface has to be created. And that contractual interface would require to specify some form of quality of service in terms of privacy and security that makes the whole thing contractable and trackable. But as we know, it's not a solved problem. So certainly one issue on our research attempt on the trust side might be how to express precisely privacy and security requirements and characterize it similarly as the quality of service concepts are done, let's say, when we are talking about bandwidth in networking or computational capacity. Of course, the other solution is that the extreme solution would be that we just solve the problem and build computational networking software infrastructure which let us to make inherently secure code. And we understand so deep the area that, that the issues just go away. Obviously, the engineering solution for that, what we do particularly in our take on this, which is architecture, modeling, and analysis, that you tease it apart and look the subproblems. One area is code vulnerabilities, issues such as buffer overflow, format violations, dereferencing, and so forth. In that regard, Trust has a nice agenda, which includes static analysis techniques, dynamic analysis techniques with symbolic execution, and so forth, and targets the development of tools for automated verification and security properties. My group is primarily concerned with system-level vulnerabilities, not so much the code-level vulnerabilities. We are interested in different network composition models and vulnerabilities that are emerging of each network component. We are interested in modeling how to configure security policies that are consistent across the different networks, how to form and model multi-level security agreements, multi-level security and partitioning issues. And after understanding the modeling aspect of it, develop static and dynamic analysis methods that check and guarantee these system-level security properties. In that regard, what we are working on primarily modeling model analysis tools and automated verification technologies for this. Yes, these kind of tools are what we are building these days. So finally, coming back to what we target and what we would like to have with Vanderbilt Medical Center Trust collaboration from our point of view is take the MyHealth Portal as an interesting technical artifact and apply techniques, technologies that are developed inside Trust in that particular context and contribute to that. So let me just finish up here.
Well, there are various places you can think about putting
Speaking of interoperability,
Maybe we shouldn't carry that idea too far. All right. So I'm going to talk a little bit about one angle of this on this problem from a technical standpoint. And here's some. I thought I'd give some general ideas just to set the context and talk about one thing we've been doing. And at various points, this is joint work with students, former students, postdocs, former postdocs, and external collaborators. Helen Nissenbaum is a philosopher, really, at NYU, who helped us a lot on some privacy concepts. Will Winsborough is some peripatetic sort of academic. I don't know where he is now. He was at NAI Labs, and then he went to George Mason, and I think he's in Texas somewhere now. Anyway, good friend, obviously haven't talked to except by email for a few months. But anyway, and I think my goal here is kind of get some feedback. Okay, I mean, we've been looking at policy languages, or what might be called authorization logics, for several years, and there seems to be some applications for these concepts to healthcare systems. So I'd be interested to hear back from anybody left in the room west and happens to have a medical bent. You know, what's useful to you? What concepts are important? What kind of systems would be useful? How can tech guys like me be helpful? And then a sort of disclaimer, there's a bunch of stuff that's been going on. You know, I haven't missed the beginning of the day. Maybe that was kind of probably with some other meetings. But there's a bunch of stuff that I've seen fly by that I don't understand at all. So there was talk about snow in Rio, and I don't know what that's about. But you can send us email or call or anyway. So enterprise access control is some traditional area and has to do with who can do what, when, and where, and controlling access to resources in various ways. And there are a lot of different systems that have been designed and built and designed and not built in this area. For many years, the intelligence and military communities funded lots of elaborate, oops, this is timed, go ahead, elaborate kinds of research in this area. Much of that never got deployed. Here's the kind of traditional setup in case you're not familiar with it. You assume that somebody, a user or a process on a computer system is trying to access some kind of resource. And most traditional things work at the granularity of a file or a document or, at the finest granular set of attributes or columns in a database. And there's assumed to be some kind of thing that is called a reference monitor or a gatekeeper, some portion of the system that looks at the request and some kind of policy and says, yes or no, you can look at this or you can't. And the assumption is this system, this reference monitor, knows who's asking. You have some identifying information, the name of the person or the process is running on behalf of a certain entity and there's some information about that. And that there should be, and it is only as useful if there's no other way to access the resource except through this monitor. And then there are lots of work on what kind of policy is there and how do you make a decision. So I'll tell you a little bit about that if you're not familiar, just to set terminology, and then I can tell you a little bit about where we are or where I think we're through this. Here's a thing that people always talk about if you're not familiar with the area, is the access control matrix. So these are, users get to access files. And the operations, the granularity of this kind of system is you can read this file, or you can write this file, or you can read and write. And there are various ways for implementing this kind of policy. Traditional thing is access control is a column of the matrix stored at the file or as part of the file system. But notice here you either get to, you as user get to read the whole file or not the whole file. So it's very coarse-grained, and part of the reason why I thought I'd bring this up is to try to have some give you some idea of where things are progressing in that sort of way. And there's been some, seen in some documents, reference to role-based access control. So I just remind everybody or say what that is. This is just a simpler way or an alternative way of specifying an access control matrix, usually. You categorize the individuals according to roles. Are they in engineering department, marketing, human resources, etc.? And then you say, everybody who's an engineer gets to access this resource, people who are in marketing can see these too, and so on. But it doesn't have any finer-grained control, traditionally, than the other system I just talked about based on access control lists. It's a way of writing down access control lists more succinctly. Another kind of problem that comes up is, what if you have a big distributed system with information coming from different places, and you're trying to make an access control decision? So this is kind of a confusing picture maybe. But the idea is, somebody sitting somewhere can access different kinds of information, and for each kind of information that might be supplied by a distributed system. And if you think about a lot of different kinds of systems, it makes sense to have the policy, that is, who gets to see what and how, distributed in the same way that the data is distributed. So if there's some policy like, a doctor gets to see this information under certain such and such conditions, whether somebody is my primary care physician might be known at my clinic, but the access might be to stuff that's at a hospital. And so the only way to make a reasonable decision is to collect together information from different sources and then use that at the point of making a decision. Now, why would this policy or information that goes into the access decision be distributed, well, it makes sense if I change to store things at the point that they're known and deal with replication automatically in the system. If I change my primary care physician, if I have a certain kind of coverage, well, I might register that at the clinic, and I'm not going to tell every hospital where I want to go if I have an emergency, that information. So you need a system that manages that. There's been research in this direction in various ways, different kinds of policy languages that are amenable to distribution, different kinds of algorithms for looking up information to make an access decision, and so on. So let me just give one example that we've used in some past research that illustrates what we mean by a distributed policy. You could have some online publishing system company, and they could say, here, university students get to see this kind of information for free. Maybe it's advertisements for textbooks, or excerpts from textbooks, or free term papers on Shakespeare to get them addicted to buying term papers instead of writing. In any case, they could say, their policy is something simple, like university students can see this resource. Now, how do you decide who the university student? Well, there are accredited universities that might be determined by an accrediting board, and each university might know who their students are. So in order for Alice to get access to some publication, you want to collect credentials or information from various places in order to make this access decision. And there's a fair amount of work, goes by varying names. One title is trust management, having to do with systems for storing credentials at various points and making inferences based on those credentials in order to make an access decision. We did some work at Stanford with Nick Wheatley and Will Winsborough for a number of years on different variations of languages and algorithms for making decisions based on policies written out in these languages. The reason why there are a bunch of them is it depends on how complex and fine-grained a kind of decision you want to make. But there is, I guess, the big picture is there's a line of work in this direction that looks at different kinds of problems there. One thing that I think is important is that if you are going to write down for some hospital, for some bank, for a university, who gets to access what, that's a kind of large description. And it's like writing a piece of software. So you have all of the same things that come up in writing other kinds of software. Did you write down what you meant? How do you test that what you wrote down as the consequences you want? And so on. So one of the things that I think is important is to look at tools for testing, debugging, editing, managing policies over their life cycle. And there's been a fair amount of work on different kinds of algorithmic problems in this direction as well. Here are a couple of things, just two general points I want to make about what I'm calling policy languages. Ways for writing down who can access what under which conditions. One basic question is, are you going to write down only who's allowed to do what in a positive way? Here's what's permitted, here's another thing that's permitted, here's another thing that's permitted. And have access be granted if it's explicitly permitted and denied otherwise. That's a pretty sensible idea. And that's one kind of basic design decision if you're building this kind of system. Is it a permit-only system? Now there's a reason, I'll give you a picture on the next slide, why you might also consider ways of writing things down in which you say, this is explicitly permitted and this is explicitly denied. And if you go that direction, this is top-level design decision, then you have a problem. What if you say, this is permitted, and then you say something else is denied, and there's some special case that falls under both of those categories. Then you have a contradictory specification or description of what's supposed to happen. So you have to resolve that in some way. Then there are different ways to do that. You can say, well, contradictory policy is meaningless, and you need some tools to detect that, keep people from writing it down. Or you can have a way of saying, well, one of those things takes priority over another. We had a speaker from the last panel on from IBM. IBM had an enterprise policy authorization language. We worked with them for a while on it until it got mired in lawsuits, so they didn't want to talk about it anymore. Some bad stuff happened, and we lost our contacts between people in research over bad stuff. But we found that we didn't actually like the way that they had solved this particular problem, although there are a great many kind of interesting and good things and innovative stuff that I've been able to do. So that's just to give you an idea of the design space. Another issue is policy combination, I think, is an important thing. If you have two organizations that are working together, then their effective policy for things that fall under both, or the information that comes from both sources, is how do you get the policy? That is a combination of the things from the two sources. So if you have a policy language where you say explicitly what's permitted and explicitly what's denied, then if you combine them, you say what's permitted is what they both permit, or what one of them permits, and what's denied is what one of them denies. Then you can tell whether you have a conflict or not, because you know you have a conflict if one permits something that the other not. So you can check that out. On the other hand, if your assumption is denied unless explicitly permitted, you have no notion of saying the overall policy of one organization conflicts with another. You just don't have a way of saying whether you have a conflict or not. So when you get to combining a system that combines input and policy from different organizations, it seems to me it's better to have explicit allow and deny and implicit deny, just for this reason of understanding whether you've got unintended behavior. So that's it for my kind of summary of some, concepts that are in the air. And I wanted to tell you in a couple of minutes about more recent kind of specific line of work. And this is with Adam Barth, who's in the back corner. If you have anything complicated, maybe ask me, Adam will answer the question. This is a framework for privacy, and it's based on a concept that's been published in the legal and philosophical literature called contextual integrity. And that phrase and name doesn't probably convey much of the meaning of this, so I'll just try to tell you what it's about. And we've worked on formalizing it, that is, relating it to a particular mathematical logic for which there exist algorithmic tools that can be used both to decide whether something is allowed and also to do other kinds of decide other sorts of properties that would be useful if you were trying to build policies and make sure they said what you wanted to say precisely, and so on. And in our paper on this, which will be presented at what's called the Oakland Conference, the IEEE Symposium on Security and Privacy, in a month or so, we looked at different kinds of privacy laws and showed how to express certain parts of it in this formalism. I'll just give you, very informally, kind of a brief, maybe a GLDA example for that. And we also wrote down some comparison between this approach and some other things. And I think the big picture is, I think we're addressing in this work some concepts that are relevant to medical applications and electronic medical records, but I don't think that we've hit everything you would possibly want. So the state of the art, as I see it in this area, doesn't provide a comprehensive off-the-shelf solution for everything you want, but I think we're getting to close enough that we can have good discussion and look at things. So here, do I have a couple minutes? Or? Yeah. Couple minutes. How many is a couple? Two. Okay. The basic primitive ideas here, we're talking about Alice gives information to Bob that's about Charlie. So one thing that's different between here and access control is who is the information about? And that's used in deciding whether it's okay. We categorize people into roles and so on. And maybe I could end here if you want me to end. But this is the kind of thing we can say. A manager may read an employee's performance data. One can actually, in this approach, get a little more fine-grained and say, if M is a manager and he is an employee, and D is performance data about this employee, and M is E's manager. Something that's not really clearly stated in the distinguished statement, then M may read D. So that's very different from saying, if you're an employee in this if you're a manager in this organization, then you can read performance data about every employee. And I think this is maybe this illustrates the direction we're headed and why some of the older access control systems, which are a coarse grain, are not really addressing some of the kind of things that come up. HIPAA, skip all the Greek letters, skip the automated tools. Maybe here it's just an example. What are these two examples? It could be 30 seconds. So here's a just core statement from HIPAA privacy rule, and it's the kind of thing we can say directly. It says, if the sender or provider of the information is a covered entity, and the recipient is a healthcare provider, and it's information about a patient, then it's okay to send certain kinds of information. That's the thing we can say is allowed. I mentioned temporal logic sort of briefly in the text. Something that comes up in GLBA is kind of notification to the person about whom the information is, the person whose information this is, and by talking about things that must have happened in the past and things that must happen in the future, we can get at these kind of policies that say, A can give information to B about C, provided in the past C gave his or her permission, or things like SB 1386, which say, if information about a customer is revealed, then in the future you must, soon you must notify the customer. So there are some other temporal kinds of constraints that seem important in current privacy legislation, and we have some approach to those. And maybe I'll end there.
Very good.
Okay.
Thank you very much. We will get back to your points after Mike and then
Would you like the microphone? I think. Okay.
Thank you. Yes, I'm going to talk about part of the Trust EMR project, in which we're looking at the ITILH project, which is information technology for assisted living at home, which was started off as a separate project and is being included in the Trust EMR project as a test bed for developing some technology for both security and privacy, and for testing some of the protocols that are being developed elsewhere. Some of the players, Rishna Shankar, and several of the students that are involved in the project. You saw a similar slide at the start of the day. Just as a reminder, one of the huge issues that are facing the healthcare systems right now is the enormous cost increases. This is a little bit updated from the slide that Shankar showed this morning, talking about the enormous increases in cost to the healthcare system expected in the U.S. and how it's generally one of the big cause of that is the aging population. And that's where the ITILH project originally came about from. And in these charts you see the darker colors being the increasing age of the population, and in the other charts you see it as well. I won't go on that because we've seen that before. So the purpose of this project and information technology for assisted living at home in general, which certainly this is not the only project going on in this area, the idea is that if you can keep people living at home as long as possible, or at least in facilities where they require less care, it's much less expensive to provide that care. And additionally, it generally results in healthier and happier people. Moving people along through the system to more intensive care places is generally something they don't like to do, and it has a detrimental effect on your health and your happiness, and also has a strong effect on the families as well. So the goal of this project is to try and provide as much support to allow people to live healthily at home, and to do it in a very cost-effective manner. Of course, you can do that with all kinds of nursing care and so on, but trying to see how much you can replace part of that care, anyways, with information technology. So the system, as it looks sort of right now, this was animated before, which is a little bit easier to see maybe. We've got these sensors at home, wearable sensors up here, and sensors in the home to monitor what people are doing and try and extract them from their behavior, what their health is, whether it's through heart rate monitors or fall detectors like we've already developed, or motion sensors to see what they're doing as we're working on, other people have implemented elsewhere. Connect those to some sort of a mobile platform, whether it's a mobile telephone like this, or some sort of home system that's connected to the internet, to whatever service provider it might be, over at this side, through the telephone system probably, or your DSL, or whatever it might be. Connected out maybe to a hospital. Maybe if you bought this from a third-party provider, maybe it's just connecting you to a healthcare service, or maybe it's just connecting you to your relatives and neighbors who are going to come and check on you in case something's the system tells them that something's happened. So the current state of the project is we've been concentrating on the initial sensors in the system for connecting them to the mobile and to the home system. And we're expanding that with additional sensors and trying to look at some of the sensor and data fusion issues that we know that, and communication issues with having multiple sensors in the system. And then as well, how to connect this, do the actual connection from the home or from the mobile platform to to whatever the service provider might be. And of course, we're getting some support from telecom service provider Telecom Italia as supporting us in this project, which is going to enable us to make some great progress in this area. And then the part of that's particularly relevant today and to the trust part is how do we then, once we have this data and we're able to take it away from the home, how do we put it into an electronic medical record? How do we provide it to the hospital system? How do we provide it to the healthcare providers so that they can use it and it doesn't overwhelm them having all this information flowing to them? But how can we actually integrate this into the system so that it goes into the system, is available there for them, it doesn't cause a tremendous burden on these healthcare professionals that are hopefully going to be using it? And as I'll just add, as Dr. Baylor said earlier, he sees this as a very clear thing that's going to happen in the fairly near future, and glad to hear that plug from him. Not prompted at all. Just to acknowledge some of the players in this, the project itself is the home-based project is a collaboration between researchers at Tampere University of Technology, TechIS, and also Helsinki University of Technology is getting involved as well. Aarhus University in Denmark, and ourselves here at Berkeley, several through the Trust Project, and as well as Telecom Italia, and who supporting us and also put a project in to micro for this. And certainly this, we're very pleased to have this international cooperation for it, particularly when we're starting to figure out how to integrate this into medical systems, because not only are there many medical systems here in the Bay Area alone, but there's also different rules as you go to different places, different countries outside of the U.S. So we have these biomedical sensors, the wearable sensors or sensors around the home, and the initial intention is we want to be able to monitor for acute things that happen or accidents that happen. But then also we know that these sensors are going to provide us a lot of information about chronic conditions as well. And then how are we going to take that? How are we going to store that information into the medical record? How is it going to be processed so somebody can make an evaluation of what that data is telling them about someone's condition, whether it's an accident that's happening, which in some ways is simpler to do, or if a deterioration in their condition. And is it useful to do so? We certainly think so, and we certainly feel that there's a tremendous medical benefit to be had by having this kind of data available if we can figure out how to put it in an accessible form for the physicians and their systems to use it. Currently, if we were trying to take a system like this, or indeed if you go into a hospital and you look at the way medical devices are used, most typically there's a machine there that is disconnected from everything else, and probably it has a little bit graphical display that shows you what it's reading, and if you press a button, it'll give you a little paper record, and then somebody would probably take that paper record and put it in the paper file, and that's the way that the data would be stored. If there is any kind of electronic recording of the information, it's probably done manually. They have to somehow store it and move it and do all these different things. And so this data is then, it's very difficult to access in terms of doing any kind of analysis on it or aggregation and comparing across patients and so on. There's certainly some progress being made in that in recent years. But if we could have access to this data for individuals, there's been demonstrated some very clear benefits from having this kind of data. For instance, we're working initially with accelerometers for fall detection, but there's been studies that have shown that just ensuring that people have enough movement and activity during the day has a very strong effect on reducing the incidence or the progression of osteoporosis. So if you can figure out a system where it either provides them feedback directly or give some information to the doctor so that they can provide feedback to someone, say, you really have to be a little bit more active if you want to fight this osteoporosis off. Then that's a tremendous benefit. And then, once it's in the system as well, you can do this comparisons across larger populations and so on. And similarly, pre and post operative evaluations are at best a snapshot of how a person's actually doing. And typically it's probably done with an interview, maybe taking the blood pressure and heart rate and so on. There's a very, very limited amount of information that's being provided, to a doctor if there's an operation going on, or after the operation, to actually evaluate what the person's condition is or how they're recovering from the operation. So if there's a way to use these kinds of medical sensors, particularly in the home, so they can take them with them, and then the doctors can easily check on how they're doing after the operation and so on. There's a potential for tremendous benefit here in terms of recovery and also preparation for the surgery in the first place. So this is very similar to traditional telemedicine, which is exemplified here with somebody with a computer and whatever system at home, and they go and connect somehow to a physician somewhere else, probably in the hospital. And these kinds of systems, of course, exist, and most people are probably familiar with them in some form. But these essentially remain a one-to-one activity. Somebody's in the hospital or in some place, a nursing station or whatever, and even actually connecting to somebody. So it's convenient. It reduces costs, but it doesn't actually reduce the workload that much. It can reduce a little bit more by having a store and transmit system where somebody can, when they have the time, they can look at the data rather than having to make sure that they're at the same time. That's an improvement as well. But and these kinds of systems exist in commercial products, easy to find. You can get service providers that will install these in your homes and do these sorts of things, and certainly medical providers will do this as well. This is an example from Honeywell HomeMed, their range of products. But what we're really interested in trying to do with this is instead of having this one-to-one relationship between the patient and the healthcare provider, trying to automate a lot of the functions so that the data analysis does. Not all the data analysis, of course, but a significant amount of it can be done automatically by the information technology that you're using either on the system or preferably on the sensor device. This is the picture of our fall detector that we're developing, which is a significant sized little CPU on it. This is a Berkeley note that we're also evaluating for the fixed places in the home. But these have enough processing power to do some amount of processing on this and do an initial evaluation of whether the data is, for instance, worth saving or worth forwarding or not, or everything's fine, they don't do anything. Detect this initial condition of something of interest has happened, whatever it might be. So to take this, to try and automate this functionality as much as possible and really reduce this amount of monitoring that's required, and also the amount of data that's required to be either forwarded or stored in the medical record, and so on. And in a similar concept, if we're going to be taking data from these kinds of devices and trying to put them into a medical record, as Dr. Bailey mentioned earlier, you cannot have somebody there approving the data every time it comes through or checking it and deciding whether it should go in the medical record or not. We have to figure out some way to automate this process or at least semi-automate the process, so there's a very limited amount of authorization required to do so. So in order to evaluate how to do this and try to figure this, how to apply the messages of security and privacy that are being developed through Trust and in other projects as well, we're going to. The goal of this is to actually have a system running, and if we can prove that it's running well enough, hopefully we can convince Vanderbilt MyHealth that we can actually try and implement this within the system. Similarly, with telecom and tele, we hope to be able to actually be able to test this on at least a test bed that they have to evaluate the functionality of the communication system. And in the meantime, we're building our own test bed here based around this ITELH project and using open source electronic medical record system called OpenMed or OpenEmed, which name they were using at the time. It's based on our own central system within the lab to start with. Using laptops and different computers to simulate the clients and servers of the EMR system. And then we'll be taking this, we've already been using volunteers from the elderly community in Sonoma who've been very gracious about letting us collect data from them on activities of daily living with our accelerometer system. And we're trying to take this out there and actually implement this basically from end to end with automated sensors, some sort of system in their home, a communication system back here to the lab. We'll be actually be able to try this out and evaluate if we, what are the real issues we're trying to import this information into the electronic medical record. So just to give you a sense of where we are with this, the initial devices that we're developing here are fall sensors, and for reasons that many people are probably familiar. Falls are the the leading cause of fatal and non-fatal, certainly expensive treatment in hospitals amongst the elderly, and it's an enormous cost involved here, and that's what motivated us to get started on this particular problem. And we're using accelerometers and gyroscopes on the devices to do this. However, as soon as we started collecting the data, it became obvious that we were going to be able to do a lot more than just detect falls for these people. So these accelerometer motion devices reveal a lot of information about what the user is doing, what their activity is, and so on. And which of course provides us a tremendous opportunity for doing other kinds of health monitoring, long-term health monitoring. But of course, if we're able to detect what they're doing, then this data also then becomes a threat to their own privacy. What we do with this data, we certainly can't just screen it around and say they're walking through the home doing fine, they're watching TV, they're asleep with all the lights off. This is not the kind of information we obviously want to be sharing indiscriminately. Okay. So just an example, these are some examples of one individual doing several tests, walking and sitting and saying. So it's very clear that we can pick out a lot of information about what people are doing. One of the immediate things we want to be able to do is identify when something's happened and they need help, and to do this in an automated way. But then once we're able to extract more information about what they're actually doing, there's some implications, as I mentioned in the last slide, about what that can mean for their health and as well for their privacy and so on. So we feel that the implications of being able to take this sensor data from people's persons and from their activities at home does have a very strong implication for what kind of health care we can provide for them, and probably in quite a cost-effective manner. The cost of devices are fairly low, the processing is very low, it doesn't require much extra additional manpower on the hospital side or the healthcare provider side. But in order to do this, this data acquisition has to be automated or worst semi-automated, almost completely automated. And of course, we have to make sure that the data is secure, the systems are robust, and the system in general is secure. What does this notion of security mean? And this is what trust is all about. One of the things is, of course, that we have to be able to assure that the users will have their privacy maintained. And we're not just talking about the medical information, which is, of course, extremely important as well. But once we start introducing these kinds of sensor systems, as I mentioned, we do have to maintain many other aspects of the privacy as well. And of course, we have to make sure that the data is going to be secure as it's transmitted and entering the medical record with the state integrity intact. And this also introduces other things that we will probably have to think about. If someone has complete access to all their medical devices at home, then it's probably possible to imagine that they may be trying to use these devices or trick these devices into providing data that is not accurate for whatever reason that might be. And this is something to consider as we move forward. So just in conclusion, this ITEL-H testbed is part of the Trust Electronic Medical Record project. We're using it to develop the testbed, using it for a testbed and to develop protocols to understand how to incorporate the sensor data directly into electronic medical records. To start off with, we're using this open source system that we have full control over, that we can do anything we want with. We're going to be implementing many of the policy and access controls and model-based approaches of our trust partners in this. And then as we move forward, we're going to be integrating into communications and telecom provider test beds, and hopefully with the Vanderbilt University Medical Center system as well. And of course, the goal of this is to enable the live automated medical record entry from sensor systems. And the first application is within the home, but there's also very clear applications of this in the clinical setting where this is a real challenge as well. And hopefully we'll be able to learn in home setting where we have lots of control over it and be able to transition to the clinical setting.
Thank you very much. Okay, now the last not the least, Professor John Kenny, and then we open the floor for conversation.
right, so briefly by way of background, I'll mention that I'm in the computer science division and I work in a design group on campus. The other thing to say is that I'm going to talk about 3 projects. The reason, the rationale for these projects has to do with a course that I taught recently on medical technology, and probably what drove home to me most clearly was the difficulty of working in this area, the incredible practical challenges of working with real medical records. But nevertheless, it did seem like there were a few quite specific opportunities of things we could try to do in the short run that might have significant benefit. The first of these is private computation for analysis of health records. The second one is certain specific progress in speech interfaces for, let's say, physician order entry or other oral presentations of patient commands and so on. And the other is the wireless wellness, which is related to Mike's talk. So private computation. So private computation is a way to make patient data work for non-specific uses for that specific patient. The major use of record data is to shape therapy for that patient. But another significant use, which tends to now be restricted to clinical settings, is using that patient information to, typically for insurers to look at predictors of conditions, for caregivers to improve their evidence or evidence-based therapies, because they're limited usually in terms of evidence to clinical studies. Whereas as we have much more ubiquitous patient records available, we could be doing a lot more in the field, if you like, or in the wild by way of statistical analysis. And it's specifically relevant to things like drug interactions, where in clinical trials it's usually combinatorially impossible to test all possible interactions, but there are patients in the world typically taking those combinations of drugs. And if we were able to do that analysis safely, we would have a lot more opportunity for improving care. So aggregation, mostly when you're talking about these applications, you're not interested in an individual patient record, because a particular combination of outcomes for one patient usually doesn't tell you anything significant statistically. You need to aggregate over a large number to decide with confidence whether there's a causal phenomenon or not. So the types of data include discrete data, yes, no, or multiple choice questions, or continuous data. And perhaps down the road we could look at semi-structured text data, but we're not doing that now. So the idea is that somehow there's some data living on various repositories. Those repositories might include the patient's, let's say a patient's computer, probably less likely, or a healthcare provider. The reality is that an individual patient's data is already spread across typically several locations right now. But some entity is interested in aggregating that data. Often it's untrusted. It'll be a while before we can manage those trust relationships. The question is, can we allow this entity to get the answer at once without exposing the sensitive part of the data? Again, it's the aggregate that we want in these cases, not the individual data. So can we get one while protecting the other? And that's what we've been working on for quite a few years. And we have a specific, we use a specific scheme, which I won't go into, which we claim is practical. And we've been rolling that out recently. For medical records, we're right now doing simple statistical linear analysis, regression, ANOVA and ANCOVA analysis. It can also handle a certain class of evidential models or causal probabilistic models. And the property that it has is it doesn't expose any information about patient data beyond the aggregate itself in an information theoretic sense. To make that sort of system work, you need to be able to validate data, because since the data is actually fully hidden, any user or an aggregating entity can like a healthcare provider who you're getting the information from may deliberately bias the data in a very large fashion. So to avoid that, we actually need to normally do sanity checking. So our main contribution has been an efficient way of doing that that would allow sort of quite large-scale analysis. I'm going to have to talk faster. It has some limitations, has to use integer data, but we tried some data sets. We weren't able to get real medical record data for this, so we used some data sets that were sort of close. Anyway, we did some experiments, got typically good iteration in the numerical sense, and quite good error residuals, and performance is quite good. You could aggregate roughly one patient record if you like. A second. We were doing data sets with more than 1,000 fields. No information, like I said, is exposed except the aggregate. And you can repeatedly apply the system, do many queries, and there's still no leakage of patient information. And accuracy is quite good. And there's a certain limited type of sanity checking, basically checking that each record, the values are not too big overall. So that's one project. Another opportunity that we think is quite significant in the short term is improving speech recognition for medical applications, and it's already a big piece of medical technology for reasons that are pretty obvious when you think about it. Transcription needs to be hands-free, eyes-free. Providers are typically moving around a lot, they're often sterile and so on. So speech is already doing well. My group recently has ramped up its speech effort significantly because there are actually a lot of demands for speech in related areas as well. We actually tried to get some speech data, record data again, and it was again very hard to do. We're still interested, but we're going to work with other data sets for a while. So, yeah, anyway, speech interface, by the way, getting a lot better. It's not initially the industry focused on just pure speech recognition technology, but actually layers of usability and design on top of that to improve the industry a lot. So we're right now in the process of porting a large open source recognizer to cell phones. That's just an example of a small device which would be suitable for dictation or transcription. And we're trying to, in a general sense, support contextual information, which means in this case, context would include case knowledge. That is, this is a specific patient. They have this specific history. It's still probabilistic. We don't assume we know what the patient's condition is, but we may have some expectation that they have a certain set of conditions. And that's pushed all the way down into the recognizer, so it will be looking more for certain terms than others. And the other thing we're working on is trying to integrate a little bit of dialogue. In this case, since it's mostly transcription, there won't be much dialogue, but generally the dialogue will be in resolving ambiguities. So concretely, this would allow case-specific prior information. So the recognizer has some sense that this is a diabetes patient when it's listening for drug names and so on, or dosages. And it also has an ability to intervene and say, I don't really understand that, or that doesn't sound very likely, did you really mean it? If the recognizer receives a high complexity term. So it's still early stage, this project, but I think it's very interesting. Finally, another project we're in the middle of is this wellness monitor, which is very similar to what Mike was describing. We've gone after a specific set of wellness indicators that we feel we can get in a small device. And we're looking at wellness as sort of a clue to perhaps early signs of conditions, like before conditions actually perhaps become problematic, either acute or chronic. Are there variations in diet, muscle stress, etc., breathing irregularities, heart rate, and so on. So let's see. So that's relevant to chronic conditions, but also there are other things we like to monitor. So here's the, yes, sorry to say that. So the design is roughly a chest-worn device because that puts some sensors in a good place both for EKG sensing and also for gastric sounds, which can be quite interesting, and you get some chest sound as well, some breathing sound. And the intention is to put some muscle tension and GSR sensing on the back, the large muscles at the back there. So it's designed to monitor ECG, chest sounds, muscle stress, perspiration roughly, or DSR response, and chest movement and activity. And that's the goal. Again, it's just similar, would leverage the infrastructure that Mike mentioned for uploading home wellness data. And this is a prototype we built last year. It doesn't do the EKG or ECG or the EMG, but we're doing a more integrated version. This is slightly integrated. It has a module for the radio, and we're now working on a more integrated one that looks like this. And there are electrical engineers in the audience. The striking thing about this is its simplicity, believe it or not. This is the entire radio, that's the CPU, and there's just a few amplifiers. So it's quite low cost, small, but it should be able to monitor all of those conditions. Okay, so in summary, I talked about some private computation, a system that we've been building and exists as a code base, which we're trying to make public, which is quite relevant to a class of queries for aggregation of medical record data. I talked about speech interfaces, which is this early project for us, just really starting up, but it's leveraging some other work we've done on context. And this wellness monitor that we're in the middle of, we're doing this second prototype that I just talked about, with the goal of creating an alternative source of general wellness information that you can accumulate as part of patients' records, and hopefully by doing that type of analysis, look for perhaps early markers of more chronic conditions before they actually happen. So, yes?
Very much. Thank you for all speaking to the And now, before I open the conversation, I'd just like to bring out some issues that I'm concerned. Is it on or am I on or no?
It's on.
It's on. It's on. Yes, yes. And that perhaps can start the conversation. So one thing is very clear in all my life when I did interdisciplinary collaboration, and this includes the collaboration of an engineer with medical, is that technology tends to be more generic. We are all looking for more, wide acceptability, while in medical and particularly in the application area for a single patient, where you want to monitor elderly people and hence give them opportunity to live more independently, is much more subjective. So one challenge we have there, besides all the things that my colleague mentioned, which is robustness, reliability, easy to use, privacy, security, all those good things, there is another thing that comes specific from this application, and that is calibrating to each individual. I mean, that is very clear, comes to us from this studies of the accelerometer, where clearly what the signal gives you depends very much on the weight of the person, on the height of the person, on the agility of the person, and all those things need to be adjusted and in fact periodically recalibrated. So I would like your experience, your comments along those lines. The other thing that I like to bring out in this conversation is what Professor Mitchell pointed out, that we are here, a bunch of engineers who are really seeking and to understand where are the problems where you, as health providers and health professionals, from whatever side you are on this problem, think that where technology can really make a difference. So having said all of this, before I ask the audience, would you like to say something, any of you? Okay. In that case, perhaps we really like to hear from you. Please.
So I think this is for both Mike and John, and that is the observation that...
Oh, what?
John. It's John, sorry.
There are two Johns here.
We'll figure it out, I guess.
So this is on continuous monitoring.
Yeah, okay.
So, and both Johns can weigh in, but so the issue is when you do this stuff, you find out that most physiological signals are actually not that interesting. And the last thing your doctor would like to look at is 1,440 heartbeats per hour. Thank you. And so a lot of the issues of pre-processing are really looking for changes. We know that people have radically different patterns of mobility. They have radically different heartbeats. And that in and of itself as a baseline is often not very interesting. But what is interesting is when something changes. It's the basis, for example, of Holter monitoring in EKGs, where the analysis algorithms just show those one or two rare events which are very important, a set of beats that are out of sync with the others. So the question is, in both of your sensor applications, one, do you envision pushing out to the firmware of the device this aggregate pattern detection, where you could put it in a mode of just detecting that there's been a change? And then, and related with that is the notion of clinical index of suspicion. Because doctors generally think everything's fine, and then if something goes wrong, now they want to look much more closely. So that are the devices instrumented in such a way that they could be remotely programmed to have a mode that is now much more intensive. In other words, you could change it from a distance to look more closely at things that you were not interested in before, but now something has made you very interested in it.
Right? John? Yeah, this is
what
yeah.
No, absolutely. Yeah, that came up pretty early. Yes, I think there is a desire to try to abstract either by presenting large segments of data that are more or less the same. It's also useful to know sometimes that this is what the rhythm looked like for this amount of time. Here's the rhythm that maybe just been exercise or maybe it's something more serious. Sometimes the duration of those is important, I think, as well as just having the segment, knowing what the waveform looks like. But yes, generally with this low-level monitoring, though, we're not proposing that there's a massive stream that a doctor is going to look at. There's a little bit of just a simple technical question of can you fit an exhaustive data stream on the device and then take it somewhere else and then do the summary, do the, let's say, pattern recognition externally. There are some trade-offs of doing it locally that, whereas one can do it, it has the negative effects that if you are sort of looking for the wrong thing, you won't see the thing you went looking for, and you also won't be able to look back retroactively. So I think that the idea is to be somewhat conservative. With ECG, we can pretty much record it continuously for a week or more. With sounds, we can't easily do that. So the sound is going to be more looking for variations. But a lot of the time, there's just a regular breathing sound. Anyway, so absolutely, change detection is a big part of it. Whether we do it on the device, though, or externally, it brings a lot of issues of practical issues. But we generally err on the side of flexibility, so that we say there's no damage done by saving information. You can always summarize it and simplify it later. We have not got at all deeply into issues of how do we present this to a physician, because until we have the data, it's going to be a little bit speculative. But the first step is to try to get that, and to basically, I think there's opportunities for discovering maybe also a phenomenon that we haven't understood so well if we collect as much as possible. So I think that's our strategy.
By the way, this is a generic problem also in radiological images. What is normal variation and what is abnormal?
We've thought very much along the same lines as John in this as well. And one thing I like what you mentioned though is right now we're thinking sort of in two modes. One, where the data is just being streamed, whether that's because we're trying to analyze the data and understand what the patterns are so that we can come up with whatever the detection algorithm is. Or that same mode would be used if it's detected something, and then the healthcare professional or whatever can connect to the device and then actually monitor it live in case something's happened. And the other one is it just sends a signal to that. But I like your idea of them being able to say, okay, now we're concerned about this now, change your mode of operation and switch to this third or fifth mode or whatever it might be.
The potential of just continuous monitoring is sort of wireless bandwidth mutilation. Yeah. You know, that you're just filling the airwaves with signals that are really not particularly useful.
Yeah, no, we have no intention of doing that unless it's
As you notice, the two speakers, Mike and John, have dealt with, and myself as well, are dealing with observations and measurements and detecting changes or whatever significant features. But then my other two colleagues, Professor Stefanovic and Professor Mitchell, they are asking what are the abstractions about this and how can you deal with the abstractions. Anyway, please, other questions? Yes.
I have one for John of Stanford. We talked a lot in the morning about identifying people that are involved in care teams and the problematics in figuring out who's allowed to see the data and who's not. And I was kind of wanting to hear your ideas on what's the most advanced you can ever imagine the A to the B to the D algorithms that you explained to taking us in healthcare.
Yeah, okay, so I think I probably wasn't here in the morning due to some other commitments. One issue that I'm not clear on what you mean is whether you're going to identify whether someone is actually, for example, the nurse assigned to this area or not, or whether that's an input you're going to provide and then you want the
what I was
systems
wondering is,
yeah.
we talked about if you have one chronic disease, you probably end up on an average with 7 doctors per year, up to 13 doctors per year, and it's a heck of a hassle to every time there's a new member in the care team to go back to the data and say, okay, let's give this guy the right rights. And, so how can we take that into at least partly automated, and can we say that by putting new caregiver to one place, we'll write the algorithms for the rest of the system?
Good. So let me comment on that in two ways that I think are both. One is a kind of general idea that one of the reasons why a lot of security systems are not used or difficult to use is because it's very difficult to configure them. So this has been one of our motivating ideas from the beginning, is that the input to the system should be along the same lines as what you tell another person. And the few English sentences you'd say that say, the members of the team can see this, and so on, whatever your 5-sentence description to a friend or colleague or something, that should be our input to the system. And then we should be able to use deductive methods and algorithms that are general about reasoning methods to derive consequences from it. So we're very much focused on simple input and using the computer, which is good at reasoning, for deriving consequences from that. Second is, we've looked a little bit, and other people have too, at this notion of why someone is allowed to do something. And one of the kind of things you mentioned also comes up in partnering agreements between different companies and so on. You can say, if you have a database of financial information and an outside auditor, you say, well, the auditing team can access this in the way that they need to. And then it's up to the auditor to have input, and they're the people who know, in an audit exercise, here are the relative responsibilities. And so our system tries to automatically combine as input information that's relatively simple from different sources and try to derive a kind of conclusion. I guess in your case, you'd have a kind of scenario that says for a certain kind of treatment or progress of a condition, then people with these kind of roles would be given this kind of access. That would be a kind of template, and it would just fill in as needed who occupies those roles. But the system should be able to automatically derive anything that you would think follows in a natural way. And that is a good
Yeah, let me second that kind of question, because it turns out that one of the most vexing parts.
Could you please tell who you
Yeah,
are?
usually if I stand up, I can use the microphone. One of the most vexing parts for the National Health Services implementation is this whole notion of how to establish these implicit relationships, i.e., if I make an appointment with a GP, that automatically allows the GP access to my personal record. If my GP makes a referral to a specialist, that allows the specialist, and they are having one hell of a time implementing the logic that you described. The logic is pretty clear. The implementation is a nightmare. And the second part of that has to do with what I'm going to call sequestered consent management. That is to say, when we in fact get to this happy world where the citizen/consumer actually is able to grant read-write consent at will to segments of the medical record divided by either type or by location or time, then this also becomes logic simple. The implication is a nightmare. So anything that you can do to bridge that gap between the logic of the policy, which is very straightforward in my mind, and the application that has to take advantage of it will be hugely helpful.
Yeah, okay. We'll talk later and follow up with you specifically.
Can you identify yourself?
I hope so.
Yeah,
I'm Tom Jones.
Oh, okay. Please.
I want that picture, sir.
So that we know whether you are from more the medical area or the engineering area.
Not engineering.
Okay.
My purchase actually is for the engineering. I'm really interested in the wearables, because all of this presupposes compliance and the use of them. And having seen this device, we know it works. I have quite a bit of experience as a runner wearing devices like this, but also as an asthmatic, I can't imagine wearing one all day for my physician, for example, to treat a chronic condition. And if I take that one step further and think of my mother, who has a thing about elastic, and who has limited dexterity, I don't see her doing that. So I'm really interested in where, I'm sure this is a first generation or end generation device, where are you seeing that development going in terms of making this something that there will be high compliance and use?
Yeah, I think that's a good question. I don't think we have a handle on it. That seemed like a good starting point. There's other versions of similar things where it's built into a garment, like a vest typically, that might be better. I don't know. It is sort of a separate design question from what we attempt to monitor with the device, but definitely the feasibility. There might be several different versions of it. It may just not work for some people. But the hope is to get something that will work for some fraction of the population still.
I very much agree with what John is saying. We are struggling with this, where to put it. And ideally, let me put it this way, the ideal sensor would be implanted. Because one of the problems, for example, we have is what do we do at night? Where do you put the sensor? So right now, Mike and I are considering a combination of sensors in the environment and on the person. So when you are in bed during the night, you don't wear it, but there is a sensor in the environment that will detect whether you are, in the bathroom or whatever. On the other hand, during the day, maybe it's okay if you wear it on the belt and so we are, but also, what do we do with the data, as John pointed out and you pointed out. I mean, you don't want to over flood and over record data what is not necessary. So anyway, any other question? Yeah, go ahead, please. Yeah.
I'll just add to that a little bit. There are some devices that people are quite willing to wear that we've seen. People have fall monitors that are manual ones, which are many people are happy with them, many are not. But they wear them around the neck all the time. My landlady does that, or wristwatch versions and things like that. So there are ways to get the devices, get people to wear them quite comfortably. Many people, and certainly not all people, but then you get into the problem of if it's a necklace, is it really going to detect a fall because it's going to bounce around all the time? If it's a wristwatch, it's not in the right place from what we found to detect this kind of thing. And some people
I mentioned it just this morning.
And certainly the building systems into the home, floor sensors that measure movement and things like that are a great way to do it if you can do it inexpensively. Similarly, the wearable shirt sensors right now are really, really expensive, but there are such devices. In a few years they won't be so expensive.
The major criticism on the wearable, the implantable is that it's too invasive.
Yes.
Because it's within your body.
Yes.
Yeah. Oh, okay, let me repeat that sentence. Yeah, the main criticism is actually the invasiveness of the device being implanted into your system, your body. And but I think there are some other measures by which we could improve on the product, but making it smaller and making it lighter, and either use it as a patch. I don't know if those kind of technologies have already been developed.
They are under development. We're working with people in Tampere University in Finland that are working on both those, small enough that you can basically make it as a Band-Aid, literally a disposable Band-Aid that you put on the sensor. In there. And they're also working on implantable sensors, which, there are implantable sensors. Pacemakers are the best example. People are willing to wear them because they have to. You're not going to wear, but you're not going to wear something probably like a fall monitor or something like that. Something implantable. So you're absolutely sure that it's, no question safe.
Any other questions? Yeah, please go ahead. Yeah, there is. Yeah, maybe this will be the last.
I have a question about wearables, but not for patients, for medical personnel. So, I'm interested in the subject of how to algorithmic issues in doing infection control, tracking back to see where infections started, and this seems to be very hard to do in the general population, but a lot of infections originate in hospitals. And so you'd like to know what rooms the patients were in and who was in those rooms just before or just after or concurrently with them and things like this. And so the question is, and so an implication of this is that you'd like to monitor patients while they're in the hospital, which seems possibly doable, not clear on outpatient. But you'd certainly like to monitor where all the hospital staff are going continuously, so that you could infer which hospital staff interacted with which patients or were in the same rooms. Because doctor-patient interactions are logged, but I don't think they log the nurse-patient interactions or the receptionist-patient interactions or what other patients might have been in the same waiting room at the same time and things like this. Is there any work going on trying to monitor medical, or is there any indication as to whether medical staff will stand still for this?
Yeah, I think that's so I can answer this. We, at Health Technology Center, we were funded by a number of hospital delivery systems. A good percentage of those are looking at RFID to track patient and staff activity. So they have a real-time database that is, of course, stored with all activities of where people were, and there's a frequency at which those transponders are set to indicate where they've been. The biggest problem with this RFID is they only tell you the location, which in the case of infection control is actually quite important. In most other cases, you have to infer their activity. But if someone came within proximity of MRSA or some other sort of infection that could be airborne, then that's a very important component. In fact, it is so important that certain people in the Peace Health organization, it's in Eugene, Oregon, has actually hired a tracking analyst to look at this particular issue. And they're now looking at whether they can predict infection control and reduce it by looking at where the activity level has occurred and where people have gone who have come into contact with individuals like this. The second issue is that if they have a database of people who have been treated previously for MRSA, and there are patients who come into the system, it makes a lot of sense to put them on prophylactic medications to reduce the amount of human reservoir that can actually come into the hospital and cause future trouble. And they're looking at that too. So there's some things. Now, you asked about how big of a problem it is. Certain unions, medical staff unions, are worried that this information could actually be used in their performance evaluations and in looking at staff. And that is an ethical problem, privacy and confidentiality. Perhaps there's an angle here for the type of work that you do
in aggregating information for this sort of real-time information, to provide the information we need. So maybe there is some work there that can be done.
I think that might, well, I'll come back to that, but let's see what.
Well, and again, it's sort of a matter of routine monitoring and how important is that signal. There are focused areas, and for example, at Vanderbilt, they actually do have RFIDs on anesthesiologists who are monitoring more than one operating room at the same time. And the monitoring system, which has the ability to simultaneously show the vital signs of 4 different patients who are in surgery, knows whether the anesthesiologist is in the room when an event occurs that may represent an anomaly of a change of vital signs. And it generates a different kind of alert if the doctor's not right next to the patient and is instead across the hallway. So those are targeted areas where it really makes a difference, where you're in one place or another. I think the attribute of generally monitoring where the providers are is maybe another example of that most of the data, in most cases, is not really particularly interesting or helps you to make a decision better, and it does raise a specter of intrusiveness.
I mean, it's typically done for access to the stuff, I think. It's not so much an analysis technique. It's really, in fact, it's not clear you need to really record it, actually. But I think, back to your point, there's definitely been some reaction against the provider, against provider monitoring, especially from nurses, most typically, because they typically have the least, they often have the least say in whether or not this is rolled out and how it's rolled out, etc. And often a better answer is just to have a process where everyone that's actually involved is involved in the decision making about, the trade-offs between privacy and benefit of the system. So there's significant, if you like, management or deployment issues in doing this in such a way. You probably won't eliminate the reaction against the technology, but you can certainly, improve and usually reduce the amount of decision when the people who it affects most are actually involved in the decision to deploy. And that's quite well documented, actually. So yeah, and this is one case. This is one of the test cases, actually. So anyway, there are ways to do that where there's a better reaction from the monitoring staff, depending on how you do it.
On this note, I think we can conclude this panel and thank to all the panelists for their contribution. The concluding remarks come from Ravi.
This is always the tough part of the session because I'm the one who stands between you and the reception. So I will try to keep my comments short. I must say that I'm very happy that you all attended and stayed for the end. If you're a technology junkie like me, it's always a more interesting part of it. But let me sort of summarize my takeaways, and then I'll open it up for what people think was perhaps the more relevant part about this. In the beginning, we started with what sorts of efforts are underway to increase the adoption of electronic health records and why health records are really important. And we noted that they are, in fact, important. The evidence base isn't particularly clear, but it's getting clearer. And there are certain efforts underway, for example, what Lumetra has done that has increased the adoption rate to triple the national average, but there's still a great deal more to do. Here in our program under CITRIS, the Service of Science, we're interested in the mechanisms to accelerate adoption and make that change happen. So we'll be looking for ways to partner to study those things. Then we also talked about certain things to actually move people to adopt electronic records. And the topics that came forward were things like shared rewards and incentives for providers. The idea is to get consumers, plans, and providers to equally share in the benefits that would accrue from electronic medical record adoption, and to provide incentives to providers to make, in effect, to make zero not enough, to make it even more worthwhile for them to go through the pain of adopting an electronic mechanism of recording their medical care. Then we got into the issues of patient empowerment. What do electronic records really do for patients? And really there's this issue of transparency and liquidity of the information that would be made available to them. And we noted that there are actually some unintended consequences that people simply could not predict from having this free availability of information or free control of the information that rightfully belongs to you. So David Brailer talked about the transparency of information and what will happen. And David Spellmeyer talked about the liquidity of information and the fact that this could really transform the change of care, could also bring about new business models that could have unanticipated business and personal impact. And that does create a degree of uncertainty that makes people nervous, possibly rightfully so. Depends on whether you see the glass is half full or half empty, I suppose. We also talked about tipping points. What would it really take to move health records to a particular state? And again, we get into the issue of incentives and the role of the consumer markets to actually pull this in the right direction. We also then shifted gears after lunch and talked about the power of good policy and partnerships, how it's important to bring all members to the table early on to do everything from crafting an appropriate security strategy to making sure that privacy and confidentiality issues are addressed up front and openly, and in effect trying to get the legal side to work for the deal instead of to protect your personal interests that could actually settle the deal. We then actually shifted gears and talked about new technology, which I actually found quite interesting. It's really sort of a brave new world of a variety of technologies that will be part of electronic medical record. So those are sort of my thoughts on what I found valuable. Let me open it up and see if anyone has comments about what they found to be interesting. Don't tell me I got everything. No? Yes, Mark.
Turning around and you know, one of the things we're really hoping for is for some ideas on what we as on the technology side that we're not doing now that we could do in this area. So if anybody has any ideas or suggestions about something maybe we didn't talk about, certainly appreciate that.
One thing I'd like to toss out is that just the other day I had a local consultant working on sort of a political problem in medical practice at a local community hospital. There were a few cases that were routinely being flagged for quality purposes of the OR. And the chair of surgery was interested in trying to reduce this complication rate. And essentially, patients were being taken back to the OR for recurrent bleeding. These were GI patients, and they were on prolonged antibiotics. And the issue was, why is this happening, and what could be done? Now, normally, if it were a chemical engineering problem, you would do a root cause analysis and fix the pipe or solve the problem, as it were. But you don't really have that problem because you have a political problem on your hands. The hospital needs the physicians to use the facility to remain profitable, and you are in a delicate position to correct the professionalism. You don't want to challenge professionalism while you're doing it. So maybe there's a role for a data-based, a data/dash-based approach to this, where John Candy's gone. Oh no, he's over there. Where what John presented, an approach where to back up a little bit, the consulting company, the decision that actually came out is that they spent about 1.5 years trying to figure out what the problem was and why this problem is occurring. They narrowed it down to 2 physicians whose patients more than often, about 3 to 5 times the rate, had patients go back to the OR. And they discovered the reason it happened is because their cases started late. They started late, and they didn't put they were rushing, and they forgot to put their patients on antibiotics, and the antibiotic rate was, the prophylactic antibiotic rate was much lower than everyone else, and they had a series of complications because of that. Now that took about 1.5 years to get to that point. Part of the problem is they didn't have a good mechanism to do the analysis, the data analysis, to compare to all other physicians, and to compare it in a way that wouldn't be construed as a witch hunt. So perhaps you have a test bed here for the type of aggregated approaches that you use. It would be quite valuable for a lot of community hospitals that are facing this very political problem of trying to keep their physicians and improve the standard of care. Lots of comments.
So I guess I think we might have completely missed it today, in the sense that I think healthcare as a guild that protects a body of knowledge, like stockbrokers and like some lawyer applications, is at risk that a form of information technology like a TurboTax or a home lawyer will in fact flow around all of the resistance of the profession and redefine the terms of the game. And we didn't hear a model of that today, but iPods superseding CDs and those kinds of large-scale adoptions by end users are potentially the thing that would be the most disruptive or the most discontinuous change that would occur in electronic medical records. Most of what we talked about was sort of business as usual, and could we be technologically a little smarter? And so maybe if we're going to try and talk about where our crystal ball or our research issues ought to be is trying to be an early detector for one of these things that would simply redefine the game. I don't know. You have the sense that it's out there, but we just don't exactly know what it is.
So who could help us to formulate what this real change is going to be?
Well, so the question there, a very naive question is, from the consumer's point of view, are they in a position to be able to access all the pieces of data from different providers or the content players? So in other words, is there a legal and practical way of bypassing the bureaucracy as it exists?
Yeah, actually, I really do believe you're right. And in fact, the argument would be made that they don't need to have access to the data that we have today, that it would be a different set of data that we haven't seen yet, or it would be a different process or service or something that emerges that is drastically different. I mean, this has actually happened in industry after industry where some tremendously disruptive technology comes out and wham, everything changes overnight. And I think that's why I kept saying, we're talking about curative care here. It could be in wellness, it could be in the home, it could be that somebody wants to make money off of the information that Safeway gathers on our food, or the general nutrition centers. There's something out there that somehow consumers are going to say, that's what I want, and that's where it's going to happen. That's what happened with the iPod.
To be honest, there are some web models, so we looked at this at the Health Technology Center, there are some web models where there are web services where you call or type in your symptoms, they call you, they interview you, and they say you probably have such and such, but we won't take a liability for it, but this is probably what you will need to do. And this is where you would get this kind of help, and this is what you should look for. And they essentially coach you through what you think you need, and then you go and engage the health system to get what you need. It's actually one in Texas is one I know of, and if you push me, I could probably dig it up. But the beginnings are probably there, but I think you're talking about something much more consumeristic that is available to all individuals.
Well, Larry Weed observes that we practice healthcare as if we never wrote anything down. Right? And so it's the absence of being able to measure outcomes and the absence of aggregate data because all healthcare decisions occur behind closed doors, one at a time, millions a day, but one at a time. So we can't harvest the relationship between inputs and outputs. But if we could, now you could imagine web mashup models or patients who have utilities, which is, okay, well, let's say there are 10,000 people like me. What did their doctors give them, and what kind of outcomes did they have? So now you have a new knowledge source, which is the aggregate data that, again, harvests community intelligence and just the observed set of outcomes as a byproduct of a whole bunch of individually unrelated events. But when you begin to be able to compute across them, you have an emergent knowledge source, which is probably more powerful than any individual provider's remembered knowledge base. Right?
And I would be willing to pay to have that information on some thin level. That's basically in essence, depositing my information online for somebody else to use and to actually get interest on through the use of that data. I mean, that's what you're talking about is, you know, I want to find the 10,000 people that have a similar set to what I've got, and why not pay them for actually finding that data? Right? I mean, my health is important enough that I'm willing to do that.
Let's go here, and then I'll come back.
Yeah, okay, go ahead.
Okay, just some hints. My personal background, I'm working for the company who produces Walkman. Walkman. 10 years ago, maybe 20 years ago. You know, how it happened. It's started by somebody else, top management's personal interest, that case. But at that time, individual technology is already somewhere. I mean, good, sounding, earset or recording mechanism and so forth. These are components somewhere. But integrate those small technologies to make something happen. A technology side, we need that kind of company or person to do that. I think personally, I know the company already thinking about that. New Walkman for elderlies.
Well, so here's the new Walkman.
Yeah. I thought
things get smaller and smaller form factors, and you can imagine the medical data Walkman, right? Then it becomes possible to envision things we've never seen.
Yes. Let's go back to Tom, and then we'll pass it back to the young lady.
It worries me a lot when we talk about integrating technologies, when I think what we really need to be doing is integrating the information that's derived from the technologies. And so what I've not heard today is any kind, getting back to your challenge question, I haven't heard enough about the logic of information use inside clinicians' brains, which is where this is all taking place, whether it's aggregated information or individual information. So the schema of what it is to have a virtual patient representation of those 10,000 people who are just like me, what does that mean inside the brain? What is the logic of transmission of my brain image to another clinician's brain image when I say, you know, the fractured leg in bed 2, you know, and I'm just trying to describe in as quick a fashion something that makes this person think about those 10,000 patients that we both have in common. So that's one challenge. The second challenge is, although we pecked away on a device-by-device basis at an area which the University of Aarhus is calling, you know, pervasive computing, I didn't hear enough about the universe of information that is pervasive computing and the policies surrounding how it is that gets used and manifestly represented. We touched a little bit about it on the legal side, but boy, I think it's an explosively big issue, and I think that for a research environment to keep moving the pervasive computing ball down the line ahead of even policy is probably very important.
You had a question in the back. No? Okay.
Okay. Well, when you talked about this experience, it reminded me that when I was young in Czechoslovakia, in a small town or so, there was one person, sometimes doctor, sometimes was just an experienced woman, who collected information about various diseases through lifetime experience, and she or he was the aggregator of this information, and this was a tremendous wisdom. Now, what happened now, my observation is that because we have all the specialties, the unfortunate thing I observed either at University of Pennsylvania or here in San Francisco, that the individual specialists, they don't talk to each other about the same person. We experienced, Mike and I went to a cancer research center, and they shared with us the frustration that if you come as a woman who has some possible symptoms of the cancer, then first the oncologist will look at you. Then they send you to a radiologist. Then if the radiologist finds something suspicious, they send you a surgeon to make biopsy. If the biopsy finds something suspicious, it goes to the lab. And finally, if you need surgery, you need to a surgeon. So you go through 5 different specialists, and neither of them are talk to each other.
Well, so I think we're actually better at communicating and message passing, but the model is still fundamentally broken, because the only 2 sources of knowledge that each of those providers brought to your case was the literature they read, which is formal publication of something that happened almost always someplace else, combined with their own personal experience. And there's an entire class of data that's missing there. And that is not some abstract few patients written about in the literature, or just one doctor's personal experience with whatever they've done and observed themselves. There's a whole bunch of sort of locally relevant data which is currently completely lost. You know, it isn't really how do women with breast cancer on average do, it's how do women in this hospital and in this town and at my, you know, those that are very similar to me with a lot of local influences, where we are acquiring the data but throwing it away. And if we were to add that back in, we'd have tremendous ability not only to bring a new knowledge source to bear, but to educate our, you know, doctors to be and such in a new model of what currently is sort of based on you read a paper, you develop a mental model, you combine it with your own personal experience, which is never going to be as good as the aggregate experience of this condition. And that's the only thing I think that can dislodge the kind of guild and apprenticeship model we currently use. And that causes us to believe what you need to do is find a good doctor. When in fact what you really ought to find is a system that is greater than the sum of its parts, so that it is, if even your good doctor forgets something, the infrastructure still delivers.
I agree.
Mike?
Yeah, just along the same lines, there's the example, some people may be familiar with it, but the U.S. Postal Service, when in the early days of airmail, the average life expectancy of an airmail pilot was 2 years. And the Postal Service finally decided that they couldn't afford to lose that many planes. So they changed the way that they trained the pilots and the way that they flew the planes so that they wouldn't crash all the time. And I think, you know, there's an opportunity with electronic medical records as well to really, you know, systematize the profession. And I'd be very curious to know what the pushback would be from the medical profession on that, but to really systematize the profession in the way that, as you say, it's, you know, what you read a paper, it goes in your head, what you learn from your instructors, and what you manage to maintain and what you learn on your way is what you have. But really to systematize and regularize the whole process to bring, you know, best practices across the board. And I'm very curious to know what the profession would, how they would feel about that.
Basically what you're talking about is data mining, right?
Yeah,
Currently,
that's right.
we don't have the data in the system to mine it. So our first step is to get an electronic record out there so that this data is accumulated, that it can then be aggregated and looked at. And currently, we can't even do the first step.
Exactly.
Someone's going to have to
And then you can use privacy preserving data mining in a way to
just
properties.
An area on that, on the electronic medical data, and getting the data in there. Physicians all want free text entry. They want to be able to dictate it and have it go in. And if we do it by free text, then we've lost all the benefit of machine learning. You know, it's got to be put into the machine in a very easily codable fashion in order to data mine it. And if it all goes in free text, at least unless our natural language processing gets much
I don't
better.
think that's true. I think if we get it into electronic form, then you have a chance. I think there's lots
Well,
of
with natural language processing.
Yeah, a lot of people work
on this analysis, diagnosis analysis, before everything really works.
I'm sorry, can you say your statement again, please, with the microphone? I can't hear you.
So first about this technology part, there are actually related two technologies. One is collaborative in my field called collaborative filtering, where if you think about movie reviews, you review a movie and help other people. That's one aspect. Another is natural language processing, right? And you can actually use natural language processing, convert your data into relational tables where then you further down. And there are companies actually doing that. So technology part is becoming commercialized. So I think your point is good in the sense, first you have to solve the data, getting the data part. And by the way, I have another comment about what says how to let all the end users to adopt this, to do this, to support this. And from this community, because I'm new to this community, I see a lot of discussions say how to change the organization. And then when I go to the venture capitals, entrepreneurs meeting, they say, we don't want to give money to companies who want to sell products to companies. They want to give money to like company like Google who go to end user because end user actually are easy to adapt. So you see, I do see very different opinions from two communities. So.
Yeah. One other thing that might be worth saying is that I was talking about privacy, but actually it's also an issue of control, because if you move data, you also give up control of data. And in terms of some of these data mining issues, where for now the data is sort of owned and controlled by a variety of entities, it's actually difficult probably for them to give the data away to someone else for data mining. So either you have to distribute the query or you have to do something else. And one advantage of the privacy techniques, if you think of them as actually control techniques where that you're allowed to do certain things with the data but not others, you have a possibility, of being probably more compliant with HIPAA, because you're allowed to use the data for care-related things, but not to give it away, essentially. But it may be easier for aggregators of data to use the data in that way. And secondly, they can make money from it, probably, which can offset their costs of warehousing and etc., because they can charge for each query that comes in. And often in a distributed system, that may actually help incentivize entities to actually participate in these kind of things.
Another challenge I see with the data.
Another challenge that I see with the data that's been mined is making it useful or making it understandable to different groups of people. Not just the programmers, not just the data miners, but ordinary people, physicians, even patients. And how do we establish certain ways of reading those different types of data? Is there a technology that already exists for these data to be meaningful to different groups of people? It's a question.
Any other questions? Or are we all ready to adjourn?
Yes.
All right, with that, we are adjourned.
And it's been wonderful after a whole day. And just so everybody does know, hopefully sometime next week we'll have everything up on the website, the same place as the information on the website, and including the webcast. Thank you.
We're generating results.
There are some refreshments out
because they went out and they They found that,
I just had done healthcare.